Good afternoon. Welcome to the Senate Finance Committee. Good afternoon, Senator. Today is Tuesday, February 25th. We're going to have 12 bills today with 110 witnesses. So sponsors, you can have as much time as you need. Witnesses, I ask you to please respect the 2-minute rule. I have with me today my Vice Chair, Senator Antonio Hayes. I'm the Chair, Senator Bidel. I'm going to read the bill order, but it is subject to change based on if our senators are in other committees with hearings. It's a busy time of year. So we're going to start with Senate Bill 749, Senator Kramer, if you'd like to go to the table. Then 792, if Senator Motz is back from EEE. 854, 988, 919, 173, 219, 227, 306, 695, 830, and 957. Hopefully that'll be close to the order. Senator Kramer, would you like to bring up your panel?
If I may, Madam Chair, panel. Oh, there it is. The extensive panel. I do, that's hysterical. How are you? Good to see you. Well, good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. Ben Kramer to introduce Senate Bill 749. Colleagues, this is a fairly straightforward bill, and it deals with workforce shortages, which is a subject we have been hearing quite a bit about over the last couple of years. In this particular instance, it is workforce shortages within the dental practices, including our dentist, dental hygienist, and dental radiation technologists. Currently, in state law, we provide for the testing for out-of-state dentists and dental hygienists to be able to come into Maryland and be licensed and practice. And that's important to fill gaps when we have a dentist office where they do lose a dentist or dental hygienist for whatever reason, may it be military service or illness, for whatever the reason may be. And in order to keep that practice functioning properly, those positions need to be filled quickly. So current law does provide for out-of-state dentists and dental hygienists to come into Maryland, fill those positions. The problem has been it can be a very lengthy process in order to get them their license. So the bill before you simply provides that if an applicant meets the requirements for licensure under this section, the board shall issue the license within 15 business days after receiving the completed application. So the goal here is to expedite the process only for those who are qualified and to ensure that the board is moving promptly with these applications. Now, the other piece of this is that our dental radiation technologists are not in the current code as it applies to this out-of-state licensure coming into Maryland. So the bill before you also addresses that issue to establish similar licensing regulations as we currently provide for dentists and dental hygienists who are coming from out of state, so that they too can fill these workplace shortages in Maryland, and then also apply the same 15-day approval process once that application is received. So as I indicated, the bill is very straightforward. It addresses, for the most part, what currently exists in statute, but it puts a time frame for getting it done in place, and then it extends it a little bit beyond what we currently do to the dental radiation technologists. With that, Madam Chair, certainly welcome to answer any questions or turn it over to the panel.
Senator, let's do questions when we get through the panel.
Thank you, Madam
Thank
Chair.
you.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. I'm Dan Doherty. I am the lobbyist for the Maryland State Dental Association. Would like to thank Senator Kramer for sponsoring this legislation. The new piece to all of this is obviously dealing with the certification of dental radiation technologists. They don't have the system laid out where they can come in by what I call certification by credentials, showing that they have been certified in their current state with the same requirements having been met there that are required in Maryland. Currently, with respect to dentists and dental hygienists, that law is in existence, and the board has stated numerous times that they do, in fact, approve these licensures by credentials within 15 days, and we appreciate that. The problem is, and why we want it in statute, is that executive directors change, makeup of boards change, and they could decide not to follow that policy anymore. So we want the policy in statute. It is important from the standpoint of meeting gaps when somebody is leaving the practice for a period of time because of military duty, illness of a family member, et cetera. And particularly the smaller practices, it lets them continue to provide for their patients and to keep their practice viable. So with that, I would ask you all to give Senate Bill 749 a favorable report, and I'll be glad to answer any questions.
Madam Chair, Mr. Vice Chair, members of the Finance Committee, I'm Dr. Tama Beckett. I'm the legislative chair for the Maryland State Dental Association and a past president of the Maryland State Dental Association. For brevity, I'm going to say most of what's been said is me too. I'm just going to share a little story which shows how important this can be. I had a colleague who is the practicing dentist in Maryland, whose brother-in-law, who was practicing in New York State, passed away suddenly several years ago. And New York State had this in place, and he was able within 1 week to go up and cover that practice while they were able to then find a permanent solution to that practice in New York. So it was easy for him to split his time between Maryland and New York. He could keep his practice in Maryland going a couple days a week and keep that practice in New York going a couple days a week. So I ask for a favorable report on Senate Bill 749. Thank you very much.
Madam Chair and Mr. Vice Chair, members of the committee, I am Bill Lebo. I am a general dentist practicing in the Federal Hill area of Baltimore City, and I am the current Vice President-elect of the MSDA. I also would ask for a favorable outcome of Senate Bill 749. I can tell you as a solo practitioner, if we lose a member of our staff, it's a small practice, that could be pretty significant in the practice. So passing this bill would help to ensure the viability of the practice as well as the continued care of our patients. Thank you very much.
Thank you. That's this entire panel. Do I have any questions for the panel? That's a good sign. No questions. And we have one unfavorable. So, gentlemen, thank you for your testimony. Deborah Carty.
Esteemed Chair Vital and Haynes, and distinguished members of the Senate Finance Committee, thank you for the opportunity to speak in opposition to Senate Bill 749, which proposes expediting licensure and certification of out-of-state applicants. My name is Deborah Carty. I'm a registered dental hygienist and a member of the Maryland State Board of Dental Examiners. The board believes the language is unnecessary. In regards to licensure of dentists and dental hygienists, the board presently issues license well within 15 business days on receipt of the last qualifying document. If an applicant submits an application with missing or illegible documentation, the applicant is notified almost immediately so that the error or omission can be corrected. With respect to dental radiation technologists who are certified, presently, in-state applications must pass the Radiation Health and Safety Examination administered by the Dental Assisting National Board. But this examination is not uniform and required across all states. Senate Bill 749 provides that an out-of-state DRT shall be certified in Maryland if they have, quote, satisfied the examination requirements of certification in another state that the dental board determines is comparable. The board believes that it would be very difficult for it to determine whether an examination administered in another state is comparable to the examination that is required in Maryland. The board is not privy to exam questions, and even if we were, it would be difficult to determine if questions are equivalent. Presently, out-of-state applicants may obtain certification, and this is by our COMAR 1044-19, if they have, quote, engaged in practicing dental radiation technology for at least 150 hours, or may I finish, or about 1 month, and in the 3 years preceding application for certification in Maryland, which is pretty easily achievable. So I respectfully urge the committee to carefully consider these issues and return an unfavorable report. Thank you.
Thank you for your testimony. Do I have any questions for Ms. Carty? No? Oh, Senator Kramer.
Thank you, Madam Chair. So quickly, you point to the fact that currently the system's working pretty well within the 15 days. If that is the case, why would there be reluctance to put into statute what you're indicating is current successful practice?
I would say, number one, there's not a problem, but number two, some things do come up, like COVID, a pandemic, which, you know, could be problematic. Currently, the board has been dealing with an issue of Legionnaire's disease. And so things do come up that could maybe curtail slightly, but when everything is, you know, set, there's no problem. I mean, and I think that the minimal requirement of working 1 month within 3 years for dental rad techs is reasonable.
No, again, going back to the point, and so would you be comfortable if there was language that referenced during a pandemic or a declared state of emergency in Maryland? That seems like it would address your concern if there was a waiver during a state of emergency. And we know that that was exactly how many things were addressed during the pandemic to ensure that, yes, things might not be as timely. So if that's the concern, that there's going to be a state of emergency at some point, would you be comfortable if I were to draft an amendment that simply provides during a state of emergency, then the 15 days may not necessarily apply? I am very comfortable and confident that that could be done, and then it just puts in, again, to statute what is current practice, hopefully. And as was addressed during changes of membership or whatever it may be, that current practice of 15 days could become 30 or 45. So this way we're ensuring that that stays in place. And I'd be happy to work with you on the wordsmithing for your concerns with regard to a state of emergency.
Senator Kramer, we're always open to working with the legislation. So, you know, I can't speak on behalf of the board. I'm just one person, but I can reassure you that we are always willing to work with legislation.
And are you representing which board?
Maryland State Board of Dental Examiners.
Okay. So it's a competing board, I guess, from the dentists that we heard from. Is that correct?
So the dentists that you heard from were representing the Maryland State Dental Association, and there is one dental board.
Got it. And so that's where your concern is, that the board would have to act during a state of emergency, and that might not
I think the board's position,
be effective.
the board's position, I'd have to say, is there's not a problem, that we're very quick to turn things around. So not really sure why we would need it.
Okay.
But we can always talk.
Thank you. Appreciate that. Thank you, Madam
Miss-
Chair.
Before you leave, Deborah,
Yes.
when you were speaking today, were you speaking for the board? You earlier said you're just one person, but you were speaking for the board today.
I am speaking for the board today,
Okay.
and we have submitted a position paper.
Yes.
So I'm
Thank
speaking
you.
from the position paper.
I just wanted to
Senator
confirm
Bidel.
that. Thank you.
Thank you.
So that ends the hearing for Senate Bill 749. Next, Senator Mounts is back. Welcome back, Senator. Senate Bill 792. If you want to bring up your panel, it's Dr. Beckett and Dan Daughtery.
Madam Chair, I believe we have one other on my panel.
Is it Dr. LeBeau?
Yes.
Yes, thank you.
Madam Chair, Mr. Vice Chair, colleagues, it's a great honor today to present to you Senate Bill 792. This bill addresses, it's a follow-up bill from previous legislation. Back around 2022, we created the Expanded Function Dental Assistants, or EFDAs. In order to obtain this expanded function certification, there were certain educational requirements that were implemented. In coming up with those requirements, there were some compromises. Unfortunately, in the compromises, it turns out that we managed to eliminate two key educational programs that are essential to facilitating education for EFDAs. Senate Bill 792, in short, is a solution to that issue that would authorize training for those two particular areas that were blocked out by the compromise amendments. I think this is something we can work through. We've got a great panel. I encourage everyone's support, and I hope we can get the committee's favorable report. But with that, we have a distinguished panel, Madam Chair. I'd like to turn it over to our experts where they can give the committee members the details.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. Again, I'm Dan Daugherty, representing the Maryland State Dental Association. Senator Mounts has outlined the purpose of the bill quite clearly. The two entities that are very essential in providing education for expanded dental function dental assistants, or EFDAs as we tend to call them, are the foundation under the National Dental Board of Dental Assistants and Trapezio. And those are added to the bill. The bill also addresses that the board shall provide for online and in-person courses. The board last week testified in opposition to the bill because they felt the clarity wasn't there as to what should be clinical hands-on courses and what could be online. We have been in communication with the board. We have exchanged language. We're very close. I am very confident that we will reach an agreement. So with that, I would say we would ask for an adoption of and a favorable report on the bill with the amendments that we ultimately work out with the Maryland State Board of Dental Examiners. Thank you.
Thank you. Dr. Beckett.
Madam Chair, Mr. Vice Chair, members of the committee, Dr. Tama Beckett again, Legislative Chair, Maryland State Dental Association, and past president of the Maryland State Dental Association. Not to belabor the point, it's another Me Too moment for me. I will just have to say that the concerns that were raised by the dental board with the online and hands-on skills testing was appropriate, and I think the original language got a little lost in there, that when appropriate, the board can pick which courses can be approved, whether they be online or in person. And the Trapezio organization has stated that they partner with local orthodontic associations for periodic hands-on courses supervised by experienced orthodontic specialists to provide that hand skills testing. So I ask for a favorable report on Senate Bill 792. Thank you.
Madam Chair and Mr. Vice Chair and members of the committee, Bill Lebo from Solo Practitioner in Federal Hill in Baltimore City. I also have a Me Too moment with this bill. I can tell you that I have faith that the board will get the right language and everything will be worked out, because we all recognize that we need the didactic skills and the hands-on skills. And the best way to get the didactic skills without interrupting people's work lives and everything is through, most of it might be through Zoom. But in our training, everything was also hands-on, and we recognize that that is an important part of the training for the EFTAs. So we hope for a favorable response to Senate Bill 792. Thank you very much.
Thank you. Do I have any questions for this panel? I don't see any questions. Thank you all for your testimony. Thank you, Senator. We do have one unfavorable.
Thank you.
Deborah Carty.
Thank you again, Senators Speidel and Haynes, and the distinguished members of the Senate Finance Committee. I want to thank you again for the opportunity to speak. Currently in opposition of Senate Bill 792. My name is Deborah Carty. I am a registered dental hygienist and a member of the board, speaking on behalf of the board. And so while the board is in the process of trying to amend the current bill, we still have not completely reached a decision on that. So I'm speaking currently in opposition. There are two different courses. One is the orthodontic assistant program, and the other is the expanded functions dental assistant program. And the expanded functions dental assistant program has 4 new functions that were previously only completed by dentists and dental hygienists. And so for those 4 new expanded functions, they need to have an educational program that includes hands-on training. So the board, just to give you some history, we have twice promulgated rules and regulations, and the second set right now is waiting for a signature. And one of the things that has been a concern is that the 2 new courses that the makers of this bill would like to add are 100% online. And the board does not feel that that is enough to protect the citizens of Maryland. One of those added 4 functions is nitrous oxide, monitoring nitrous oxide sedation. Well, when you're monitoring nitrous oxide sedation, patients can aspirate, they can throw up, they can die during sedation. So we feel it's very important that they have this hands-on clinical component. Let's see, don't want to leave anything out. So there is other concerns that could be addressed with amendments, such as continuing education, and the language for that is extremely limiting, and clarity concerning reinstatement. So for these reasons, at this time, the board is opposing Senate Bill 792 and asks for an unfavorable report.
Senator Mount.
Thank you, Madam Chair. So I just want to understand, so there's opposition and there's opposition with an amendment. But it sounds like this is opposition, want to have an amendment, but don't have an amendment, right? It's sort of like, where exactly, I mean, I'm trying to understand your testimony a little more clearly.
So we testified last week in the House, and as a result of that, one of the delegates asked if we could work on amendments. And of course, we're always agreeable to try to work on amendments. That is in process right now. So we're hoping we can come to an understanding.
Okay,
Okay?
okay. Well, if it's of any assistance, please reach out to try to find a way to move this forward. I know there's some dentists from my district that came to visit me that were very, very much supportive and very interested. And with your testimony, is there, and I should know this, but were those points that you raised, were they submitted in writing to the committee as part of testimony?
The board submitted a position paper.
Okay. And so all your arguments are contained in that position
Yes,
paper?
yes.
Okay. Thank you.
Thank you.
Thank you, Senator. So you're going to work together on some amendments so we get this good bill passed? Absolutely. Thank you, Senator. Thank you for your testimony. That ends the hearing on Senate Bill 792, and now we're going to go, is Senator Lewis Young here? Hi, Senator. Senate Bill 854. Senator, do you have a panel?
I
think you
do.
Yes, you
I'm
do. Oh, you
wondering
have
if
a
they're-
big panel.
Some of them may be over in the House because the House hearing is the same day.
All right, so we have Caitlin McDonough.
She's here.
Is Paige here? Paige
Paige
Baroka?
is out of birth, so we have Tova,
Tova's here, okay. Nikki Williams?
yes, Nikki, and then I think we have Jen Chaffee. Chaffee, sorry. Oh, and Liz
Oh,
is on.
okay, Jen Chaffee's going to be on your panel?
Yes.
And then we have a virtual panel member, Elizabeth
Yes,
Reiner.
perfect.
So what we're going to do is we're going to hear from everybody, including your virtual panel member, and then we'll ask questions, okay? All right,
good.
Senator, you're up.
Okay. So, good afternoon, Madam Chair, Mr. Vice Chair, and members of the Finance Committee. Good to be back in front of you today. Some of you may remember the history of this bill because this bill is actually an update. It makes updates to the Licensed Direct Entry Midwife Practice Act. I'm going to refer to that as LDIM going forward for abbreviation. So House Bill 9 in 2015 established a licensing and regulatory system for the practice of direct entry midwifery under the Board of Nursing. The sunset of that bill is July 1st, 2025. I was a co-sponsor of that bill in 2015, as was your vice chair. So this bill does three things. One, it extends the sunset to October 1st, 2030. Two, it updates some out-of-date terminology and uses more current statute. The third thing it does, which will probably dominate most of our conversation today, is it removes certain statutory requirements on LDIMs that are not really practical in real-life applications. So we've had 10 years of experience with this bill. It's been tremendously popular, gone from 59 users the first year that data was collected to 613 in 2024. That's a 1,000% increase. I won't go into detail about some of the positive experiences. You'll hear that today. It's in your testimony, but just amazing. What a great experience it was to give birth in the home. And let's face it, there are some people who don't like the sterility of hospitals, the impersonalization, and this isn't right for everyone, but for the ones it's right for, they love it. So let's talk a little bit about the statutory requirements that just aren't practical in real life applications. Untimely notifications to pediatric providers, requirements that LDIM accompany patient in a transfer in all situations. You'll hear more about that, but it doesn't always make sense, particularly if you're leaving the infant behind or the partner wants to ride in the ambulance, then you have to make some difficult choices. Blanket filing of non-specific care plans. So this bill will clarify in statute that LDIMs are independent healthcare practitioners. it makes midwife services available to more patients by changing certain medical conditions from being prohibited from LDEM care to being permitted in consultation with other healthcare professional providers. Some of these conditions include anemia, undefined diseases and disorders, BMI outside a certain range. It also makes disciplinary authority of the Board of Nursing consistent with other Board of Nursing regulated practitioners. It makes reporting requirements for LDEMs consistent with other Board of Nursing regulated practitioners. So why do we need this bill? After a decade of initial licensure, we really have a much better grasp on how LDEMs practice and practically interact and integrate with the rest of the state's maternal health care system. The bill accomplishes updates to existing statute to be more consistent with LDEM training, experience, and model of care, and to better reflect how LDEM or CPMs practice in neighboring states. It makes LDEM and out-of-institution maternal health care more accessible to patients seeking this type of care, giving more flexibility, choice, and autonomy to patients. And it makes regulation of LDEMs more consistent with other midwives and practitioners licensed and regulated by the Board of Nursing. We're working with the Maryland Department of Health and the Board of Nursing, as well as other stakeholders, to clarify some of these scope of practice issues. And we're trying to get some greater efficiency, accessibility, flexibility, and superior care. And just through the initial conversation we had on Monday, I believe we've made some significant progress already in better understanding why some of the restrictions in current practice just are not efficient. In summary, I mentioned that you're going to hear some great testimony today about the merits of this program. At a minimum, I do strongly believe we need to extend the sunset, update some of the terminology, and offer some flexibility to the practice that we've learned in practical experience over the past 10 years. Thank you for the opportunity to present this bill and pass it on to my panel.
Thank you, Senator. Who would like to start?
I'll start if you don't mind, Madam Chair. Madam Chair, members of the committee, Caitlin McDonough here on behalf of the Association of Independent Midwives of Maryland and Maryland Families for Safe Birth, a patient advocacy organization for maternal health, here in support of Senate Bill 854. Thank you, Senator Young. This is a lengthy bill because it is making changes throughout the Practice Act, which, as she mentioned, is about a decade old now. And I would reiterate that extending that sunset is very important. LDMs are the primary provider for home birth care in Maryland. So if you don't have that licensed LDMs in the state, you really don't have home birth options in the state other than going to an unlicensed practitioner or going out of state. And you know, the reason we put this in place in the first place was to address those concerns. I have a large panel and there's more witnesses signed up. That is partially because the bill's being heard in the House and we wanted to make sure we had coverage on both sides. But we will have ample practitioners and patients to kind of speak to the real world implications of all the provisions in the bill. But to summarize, I'd put them in two buckets, and the senator kind of alluded to this too. Some of this is like functional practice of LDMs, notifications, what they need to send to hospitals, how they interact with the board and how they're regulated. And then there are some scope of practice changes suggested dealing with anemia, significant fetal congenital anomalies, body mass index outside the normal range. And again, we recognize there are risks associated with all of these conditions. I think what we're looking for generally is the opportunity for patients and the midwife to consult with other healthcare practitioners, determine what the level of risk is, determine whether it can be addressed with medication or other treatment during pregnancy before we're triggering a patient to transfer completely out of that LDM care. You're going to hear some more specifics from some of the LDMs on the panel and some of the patients seeking these priorities, but we are absolutely ready to answer questions about each and every provision in the bill. And again, I'll thank all the other stakeholders, the Hospital Association, ACOG, ACNM, and the department and the board for working with us on amendments. And you will see a different bill, I think, by the time you're hopefully prepared to vote. Thank you. Go ahead, Tova.
Thank you, Caitlin. Who's going to go next?
Hi, my name is Tova Brody. I'm a licensed direct entry midwife. I have a solo practice in Pikesville. I'm also a home birth mom to 6 kids. I am on the legislative committee in the Association of Independent Midwives of Maryland, and I also sit on the direct entry midwifery advisory committee with the Board of Nursing. You're going to hear a lot of technicalities on the bill. As Caitlin said, and I as a provider here on the panel, I'm happy to answer any questions. Also as a consumer of home birth and how hard it is to navigate finding a midwife, and especially for people who, are a little bit outside that very easy, low risk, obviously the risk scope. But I want to bring up a couple of things. First of all, I think while this bill is technical, it's really important to remember that it's centered around patient choice. And in a state where, we have reproductive freedom, I really believe that this needs to extend to patients being able to choose their providers and choose their birth settings. I think that we've been coming to the table with our opposition and all the stakeholders, not just for the past few months, but for the past 13 years that I've been involved in this midwifery legislation. And I think one thing that, unites us all is that we're all on the same page to bring down surgical birth rates, to better our terrible, American maternal healthcare morbidity and mortality rates, to address the horrible racial disparities in healthcare. I really feel like that can unite us with some of our, stakeholders who may not be so on board. And I just kind of want to remind everyone here of that, because this bill helps with all of those things. Making the midwifery model of care accessible really positively impacts maternal health care here. So I'm going to let my colleagues speak to the particulars of the bill, but I'm happy to answer any questions and specifics about, the anemia clause, and how one thing our sponsor said was that this makes it more consistent with other healthcare practitioners. I do think that's a little generous. This is just the tiny tip of the beginning that might help kind of streamline, because right now we're one of the most restrictive within the state as far as private practitioners. So thank you so much for your time.
Madam Chair and members of the committee, my name is Nikki Williams. I'm like this? Oh, okay. I'm an LDEM working in Maryland and surrounding states. I wanted to address some of the very granular particulars of the bill, the amendments that we are proposing. So when this bill was written, legal home birth practice was not yet a thing, so they just threw in a bunch of things to get the bill passed, and we have been working under these regulations for the past 10 years with amazing outcomes and successes, but there are some things in the bill that don't make any sense the way that we practice safely, and one of the things in particular is the requirement to involve a pediatrician before the baby is born. So right now I don't have the actual subsection listed, but it stipulates that we have to call the pediatrician when our client enters active labor. That could be 2 in the morning. They could have their baby 4 days from then. Some of the written testimonies that you have received were 2 pieces of testimony from pediatricians who we do interact with regularly, and they both have said that this does not help them. And in fact, when we started working under this regulation, we tried to do the right thing and call pediatricians, call their nurse line at 3 in the morning, say, hey, somebody's in labor. We were asked to stop doing that. So we're all breaking the law every time we deliver a baby because nobody is calling pediatricians when somebody's in active labor. We are then asked to contact the pediatrician within 24 hours, and then again within 3 days when we are ready to transfer formal care to a pediatrician. We are actually trained to take care of babies for 6 weeks in our, thank you for your time.
Thank you. You must be Elizabeth? No, Elizabeth's on.
My name is Jennifer Chafee. Good afternoon, Chair Beidel and members of the committee. I am a consumer. I am here, okay. Okay. I am here to represent Maryland Families for Safe Birth. We are submitting testimony in support of the bill, which extends the sunset on licensure for LDEMs in Maryland. Maryland Families for Safe Birth is a grassroots, consumer-driven organization dedicated to improving access to evidence-based, culturally sensitive maternity care for Maryland families. Our organization gets many inquiries from women looking for out-of-hospital birth providers, the majority of which are LDEMs. In 2015, the Maryland legislature passed a bill licensing LDEMs. This was a huge step forward because it allowed licensed providers to begin addressing the growing demand for out-of-hospital birth. But we need improvements. The desire for home birth continues to grow. We need more midwives licensed. The bill is a critical piece of legislation to continue to meet the growing demand for out-of-institution birth in Maryland. This bill also updates the statute to improve the functionality of LDEMs within the maternal health care system, allowing more families that wish to access care. Current regulations are limiting and need to be updated to reflect realistic circumstances that have become apparent over the last 10 years. We urge you to support this bill. We would like to continue building on the progress we have already made for the families of Maryland. Thank you for your time.
Thank you. And finally, we have your virtual panel member, Jennifer Chafee. Jennifer?
This is
Elizabeth. That was
No,
Jennifer.
I'm sorry, Elizabeth. Things are kind of out of order. Elizabeth Reiner. Yep.
Go ahead, Liz.
Go ahead.
Hi, good afternoon, Madam Chair, members of the committee. Thank you so much for all of the work that you do. My name is Elizabeth Reiner. I am a home birth mother, certified professional midwife, and president of the Association of Independent Midwives of Maryland, AIM. I've been attending births for 22 years, and I am proud to be Maryland licensed midwife number 7. Your support of this bill is quite literally a vote on behalf of the growing numbers of Maryland families who want to continue exercising their freedom and right to have home births safely attended by LDEMs. This sunset legislation is nothing extravagant. We are not asking to extend the scope of practice, which is something our clients request of us year in and year out. This bill primarily allows us to simply continue doing the work our clients already expect of us. And we've already talked about that it includes those areas where we would need to consult rather than outright restricting home births. So for instance, unlike in neighboring West Virginia, Virginia, and Pennsylvania, where I and many others practice, we cannot currently work with mothers whose BMI is under 19% or over 35. 40% of women in their prime birthing years, ages 20 to 39, have BMIs over 35, yet are also fit and essentially healthy and great candidates for home birth. Maryland mothers who desire should be able to make that informed choice. Additionally, this BMI restriction disproportionately affects women of color. Another area would be anemia. Anemia is a common condition of pregnancy that generally responds quickly to simple treatment. As the law is currently written, midwives need to transfer clients out of our care if their hemoglobin is below 10, but if it goes up with simple treatments, they can come back to care. So this is impractical and generally unnecessary. Our clients do not remember a time before CPMs were licensed in Maryland and have come to rely on the high quality care that they receive from us. Please support this bill and the individualized, respectful, and safe care that we currently provide. Thank you so much.
Thank you, Elizabeth. We're going to have several questions, but I have one in the letter from the Board of Nursing that is of concern.
Yes.
It says Senate Bill 854 removes the requirement that direct entry midwives transfer care for pregnant people with severe anemia, significant fetal anomalies, and rare diseases. This does not align with the recommendations of the American Academy of Pediatrics. Do you have a response?
We did have a pretty in-depth meeting with both the department and the Board of Nursing yesterday, and actually I think you'll see similar concerns reflected in the Hospital Association and ACOG's testimony as well, and we've been speaking with them as well. What we're suggesting in the bill, like in the example being anemia, is not, so right now if you dip below a certain level and have severe anemia, we have to immediately transfer you out. What we're suggesting in the bill, and I think we can clarify this a little bit more with some amendments similar to how we treat hypothyroidism under the bill, would be we'd have the opportunity to consult with a healthcare practitioner. The patient could see a hematologist, get medicated, and if they're able to treat that anemia to the point where there's no longer risk, they could stay in care. If under medication they still continue to be severely anemic, we would recommend also that they transfer out, that risk level may be higher. So it's that kind of flexibility, and as Liz mentioned, right now we have either we have to immediately transfer, which is very disruptive to the patient, or they're coming in and out of care based on their kind of anemic status and whether it's untreated or not. So just those kind of flexibility and opportunities. And in speaking with the Board of Nursing about that, I think we can come to an agreement. Similar, some significant fetal congenital anomalies absolutely increase risk and should trigger transfer. Others, like an extra digit when you're born, there's not really anything that you can do at that point. So taking that newborn baby and immediately transferring them to a hospital setting causes a lot of disruption for both the patient and the newborn. So again, seeking some kind of consultation, flexibility to make those determinations in real time, I think is better for the patients, better for the practitioners, and frankly creates safer transfer protocols.
Well, Caitlin, I hope you can work those things out because their letter is opposition.
Yes.
And we'd like to see at least a letter of information. So,
yes,
thank
and
you.
we are actively working with them. I believe their legislative committee meets on Thursday to go over. I think when we've explained some of the real world experiences, they are understanding a little bit more what we're looking at here. And I am very optimistic that we can work out some amendments.
Thank you. Senator Kyle, you go next.
Yeah, thank you very much, Madam Chair, and thank you, Senator, for this bill. As another home birth mom, I really do value the work that midwives do. But I did have a question. I mean, I know that there are some letters in here favorable with amendments, but expressing some concern, and I don't know. The bill sponsor or somebody else, maybe Caitlin, whoever wants to chime in. Just broadly overall, it sounds like there is still a lot of ongoing discussions. So maybe if you could just kind of tell us overall, where are the conversations to amend the bill and to strike compromise?
I'm happy to, Senator. Okay. So,
Okay.
I mean, and I can kind of run quickly, keeping your schedule in mind. So there's kind of one bucket has to do with notification, and I think as Tova mentioned, again, so our current statute requires notification to a private practice pediatrician when active labor begins and delivery is imminent. Understanding that can vary depending on the patient. What the rest of our Practice Act says is, should an emergency situation arise, we have to transfer that patient or that newborn, depending on where, in labor and delivery we are, to a hospital emergency pediatrician. So it's a little bit of a disconnect in that we're notifying like your private practice pediatrician, whereas if anyone's going to be treating this baby at this point, it's going to be a hospital-based emergency pediatrician. So that is, and then we notify again at 24 hours and then again at 72 hours. So I think we can kind of work out like what's the appropriate notification in that timeline so we don't have redundant and repetitive notifications, and that they're actually going to the pediatrician who would be conceivably treating the newborn, not to an answering service at a private practice pediatrician. So I think, maybe leaving in the 24 hours, I think we've got a little more understanding around that imminent labor notification. So that's one suggested modification. On the scope, which is the big ones are the anemia, the significant congenital anomalies, and the BMI. I think less concern around the BMI because usually if that's a reason to trigger, it's because there's a comorbidity like hypertension, diabetes, or something else associated with being outside that range. Those are listed separately as reasons for transfer. So if any of those were to come up, you would have to be transferred under the bill and under current law. This gives us a little more flexibility to take someone outside of the range, make a determination about whether there are additional risks, but they could still have that opportunity for care. I think we've got some understanding around that. Anemia, again, if we look to the hypothyroidism example, I think there's a way to allow for consultation and medication, but if that condition persists, then we would transfer. So clarifying kind of that it needs to appear in both the transfer list for certain conditions, but as appropriate for consultation at a certain point in time, I think is something that, we're working closely on. And then I think on the congenital anomalies, maybe listing out what we think are some of the low risk, which I alluded to in my testimony, that are more appropriate for consult and not immediate transfer. So, I mean, it is a little bit of wordsmithing, and this is a very lengthy, detailed practice act. No other state has this level of detail in their practice act. So one thing we struggle with is that this is all in statute and not in regulation. So kind of working out that level of detail. One other thing I will mention, because I know the Board of Nursing brought this up, we have very, very cumbersome annual reporting requirements where we have to report every detail of every birth and every patient we see, which is totally unparalleled with any other practitioner in Maryland. I don't think we're suggesting that we not do annual reporting, but that we give the board and stakeholders the opportunity to look at that process. It is very burdensome. It is difficult for the board to get through. We have heard testimony from or comments from other stakeholders that it's difficult to use that data because it's such a minute level. And also there are privacy concerns. As you heard, this is a relatively small community of patients and providers. We're talking 38 providers, 600 patients, give or take. So when we report by county, it becomes very apparent who we're talking about from a practitioner and patient standpoint. So trying to address some of those privacy concerns. And again, empowering the board to do this through regulation, through their DMAC committee, through, however is the best way to do it, which is what we do with all other practitioners, we think is more appropriate. But, still certainly responsive to having those reporting requirements or some type of reporting requirements, enshrined.
Okay. Thank you, Caitlin. Thank you, Madam Chair.
Thank you, Senator. Senator Jackson, is your light out? Yes. Okay, thank you. Senator Reedy.
Thank you, Madam Chair. And I've been a supporter of home birth since I got in the legislature, and we took us a lot of time to get it done, but
Very
we did.
good bipartisan issue.
Yeah, no, absolutely. A question that I have, just along the lines, it's appeared in multiple of these letters, and I think it sort of jumped out at me. Kind of two things. One is trying to get rid of the requirement to provide a birth plan to a hospital that you may have to transfer to.
Yeah.
And then secondly, the not accompanying someone to a hospital if they have to go. Now, I understand the sponsor addressed, sometimes there's a question about who rides in the ambulance, but to me is a little problematic. That's a concern to me that I don't think anybody that's sitting at this table or going to testify today would be at all unscrupulous, but if a hospital doesn't know what the birth plan was and somebody just shows up and says, oh, I was a home birth, like, you're not going to accompany the person that you just helped start to deliver it. Like, help me understand that. That's a concern to me.
I'm going to speak to the transfer plan, and then can you speak to the accompanying?
Sure. Yeah,
so on the transfer plan, in our statute or in our practice act now currently, there are two types of transfer plans that are required in statute. One is a general practice level set of parameters for how that LDM would transfer generally for
like this is how I in my practice
and it's like
transfers.
A practice level general form that is approved by the Board of Nursing and kept on file with the board. Then for each individual patient, you develop a specific transfer plan for them, and that's where you're going to be identifying the hospitals, because usually it's going to be based on the preferences and geography of that patient. I live in College Park. I'm going to have a Prince George's County hospital that I'd like to transfer. There might be other hospitals that don't have as large a labor and delivery unit, but they're going to be kind of the closer one. And then also emergency transport comes into play here too, because they're going to make a determination during an emergent situation on where you transfer. Our suggestion is, rather than kind of generally sharing our practice plan with hospitals, that patient-specific plan that calls out that specific hospital and is tied to that patient be shared as part of our communication.
That's what goes to the hospital in the event of a
So,
transfer.
and then there are several other places again, and it's hard to read the bill sometimes outside the overall Practice Act where we have to transfer records. We have certain communications with the hospital, whether it be a transfer in second trimester versus during labor and delivery. We've talked a little bit about all the different notifications and transfer of medical records to different types of pediatric providers depending on what's going on. So there's a lot of different requirements in the bill now. We find that one to be kind of unhelpful to hospitals and like generally burdensome to the midwife.
So we're
But
really
there
just,
is
for that, you're
cons.
getting rid
Yeah.
of almost, not duplicative, but there's two reports and you
like
don't need both.
You know, if it says, special birth health center, and then that you get our health plan, I don't know how helpful that is for the hospital.
Right.
If Caitlin McDonough's transfer plan is identifying, Doctor's Hospital would not be appropriate transfer, but Doctor's Hospital as, my transfer plan, that's where we think the kind of communication comes in.
Okay. And then on the accompanying part. yeah.
Sure. I think this is kind of where it's helpful to get these questions so we can let you know how it works in real life versus what the laws are on paper, as Nikki was describing with like the pediatrician notification. When I have a patient who needs to transfer, I am calling the hospital, hey, I'm a home birth midwife, I'm sending in a patient, who can I speak to give report? I'm handing my patient a page of recent vitals and significant information that is, relevant to their transport at that time. I'm asking to speak to the charge nurse, get their fax number. I'm faxing over their medical records. Vast majority of the time, I'm accompanying my patient to the hospital so that I can also, in addition to all of those things, give report orally and usually stay and support my patient. Where this has come up, where, as Nikki said, if we don't do this, it's breaking the law. In the pandemic, significantly, there were many hospitals that had restrictions on amount of people that could come in. So now we have a patient who's like, do I bring in my midwife or do I bring in my husband? And if we didn't accompany them and we're legally required to, that puts them in an uncomfortable position on making that choice. If we have a mom who's transferring postpartum, we stabilized a hemorrhage and she needs some fluid or maybe a blood transfusion, or she needs a surgical repair of a tear that we can't handle at home. Sometimes we're still doing immediate postpartum care for a newborn baby who's 1 hour old. So mom might go into the hospital for 3 hours while we stay to care
What's
for this
happening
neonate.
now when this comes up?
So right now what's happening is, as we said, we have this language of the law and we're sort of playing it by ear and what's the most practical in each situation. But we just want less restrictive language that allows us the autonomy as providers to make it on a case-by-case basis. We're not, dropping patients off at the hospital. The other thing that has happened is we'll call a hospital and say, hey, I'm a home birth midwife. I have a home birth transfer that I'm sending in for whatever reason. And the hospital says, they can't come here. And so now we're faced with, this is our closest hospital and we probably should get to the hospital. The patient can't be denied at the door if they show up, but that doesn't make it a hospitable environment for us to show up to. So it's complex. Actually, part of another bill that's going to be heard is that we need better bridges. There are some hospitals that actually do collaborate with us and have a policy for taking in home birth transfers. We have open communication lines, but we don't have enough of that in the state.
Okay, all right. I hear you, and I think a lot of that makes sense. I think there's a couple concerns there. Maybe we can keep, I'm sure we'll be working on it as we
Absolutely.
deal with the, okay, thank you.
And I will I know we have a lot of witnesses signed up in support, again, because of the dual hearings. So I know we've talked about a lot of the issues, so I'll urge brief testimony.
Me too, will work.
Yes, please, if you're prepared, Madam Chair.
Karen Milgate is favorable, Catherine Paterlo Mag, Valerie Campbell, Katja Harper. Are they here? It's 4 more favorables. Thank you. You can begin when you're ready. Thank you. Okay, someone needs to start. I don't care who, but someone needs to start.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Valerie Campbell, and I'm a supporting member of Maryland Families for Safe Birth. I reside in Baltimore County, and I'm in Senator Klaus-Meyer's district. I'm here today to speak in support of Senate Bill 854. And as a former volunteer with Maryland Families, I had already met and worked alongside some of our state's best direct entry midwives before becoming pregnant with my child, Choosing my provider was difficult. There were so many excellent options, a stark contrast to the typical OB/GYN experience where patients are assigned whoever is on duty that day. Over the course of my pregnancy, I bonded with my midwives. They felt like trusted aunts, always available to answer questions without judgment, no matter how small. They were not alarmed by my baby's larger size. When I had a single high blood pressure reading, they helped me manage it with dietary changes and supplements. Thanks to their guidance, my pregnancy progressed smoothly. However, during labor, my midwives noticed something was wrong. They stayed by my side, taking shifts to monitor my vitals. When my blood pressure began rising and my baby wasn't descending despite full dilation, they told me, "I think it's time we start thinking about going to the hospital." Take a moment to reflect on that phrasing. They believe in women making their own choices. They didn't force me, they empowered me. And because I trusted them completely, my decision was immediate. There's nothing to think about. Let's go. Upon arrival at the hospital, the patient-centered care disappeared. I was stripped of my clothes, placed in a gown, hooked up to IVs and monitors before I could object. When my midwives arrived, they continued advocating for me, but the OB/GYN was already frustrated. I had heard that hospitals resent home birth transfers, and I felt it firsthand. As I labored, the external monitor shifted with my movements. The OB insisted on an internal monitor, which involves inserting a device through the cervix and screwing it into the baby's head. She did not explain this to me. I only knew it because of prior research, which was part of why I had chosen home birth in the first place. I declined the intervention. My midwives offered to adjust the external monitors instead. The OB's response was, "Then we need to do a C-section."
Thank you. Thank you. Who's next?
Yes. Okay, thank you. Hi, my name is Catherine Pontrolomag, and I'm here to ask for your support of this bill. I worked in a hospital for 8 years as a Spanish medical interpreter, and that included interpreting at multiple hospital births as well as various prenatal and postpartum checkups. And this experience of witnessing firsthand the full spectrum of maternity care as it unfolds in traditional outpatient and hospital settings informed my choice to choose a different model of care when I became pregnant with my son. I had a planned home birth, and each prenatal appointment with my midwife team was an hour long, which allowed us to get to know each other very well. Their thorough, compassionate care and the continuous education they provided at every step of the way allowed me to make informed decisions about my care and deepened my trust in their expertise. Busy outpatient clinics don't have the capacity to provide that level of holistic attention to each patient. When I woke up in labor the day my son would be born, I was grateful to stay in the comfort of my own home, knowing that my midwife team, with whom I already had a close relationship, would be coming to meet me where I was. This is a significant shift from hospital-based birth, where patients arrive in labor and are often greeted by multiple new faces of healthcare professionals whom they've never met before, who are simultaneously attending to the needs of multiple other patients. When my midwife team arrived, their attention was solely focused on supporting me and my husband as we welcomed our son to this world. Furthermore, in the first days after birth, my midwife team provided all the health care that my son needed in the comfort of our home, and they continue to support my physical and emotional well-being as a new mother by coming to my home several times in the weeks postpartum. I hope you'll support this bill so that families seeking the unparalleled continuity and quality of holistic care that midwives provide may continue to access it for years to come. Thank you.
Hi, thank you for allowing us to speak today. My name is Katya Harper. I'm in Frederick County, just outside Senator Lewis Young's district. I would also like to express my support for this bill. In recent years, more and more mothers have chosen to give birth in an out-of-hospital setting under the care of midwives, including myself. Almost 2% of all women now choose this option, the highest level since 1990. There are many reasons for the increase in popularity of home birth and midwifery, but perhaps the most important is the autonomy and tailored care it affords expectant mothers. I myself gave birth in the care of Nikki Williams in 2023, and I can personally attest that I received a highly tailored, individualized level of care that was very difficult to replicate in a more standard commercial hospital setting. The women who choose to give birth with a midwife deserve to have access to all of the services that a licensed midwife is able to provide in other states. These should not be arbitrarily restricted because the midwife does not happen to work in a hospital, and birthing mothers should have the greatest degree of autonomy possible in determining if and when to transfer to a hospital. These principles are consistent with the recent Reproductive Rights Amendment to Maryland's Constitution, which passed referendum easily in last fall's election. The amendment codifies every Marylander's right to reproductive freedom. Surely this should also include a woman's right to choose not only her birth provider, but the services she wishes to receive from this provider. Restricting the circumstances under which midwives can provide prenatal, postnatal, and labor and delivery care would violate at least the spirit, if not the letter, of the Reproductive Rights Amendment. I urge you to continue to support women's reproductive freedom and vote in favor of this bill. And I would also just ask to not be too wedded to the American Academy of Pediatrics recommendations. The midwives that are on the ground and us patients have a valuable voice in determining what policies should be. And American Academy of Pediatrics standards often change every couple months or years and are unrecognizable from merely 6 years ago.
Thank you. And finally, Karen Milgate.
Good afternoon. Thank you for allowing me to present today. My name is Karen Milgate, and I come to you with 3 points of view. First, as a health policy expert. Second, as a licensed direct entry midwife in Maryland. And third, as a mother who first had a cesarean section in a hospital and then had a vaginal birth at home after that cesarean section. I'm also a resident of Greenbelt. I urge you to respond favorably to this bill to extend the licensure for direct entry midwives, as well as to do as much as you can so that licensed direct entry midwives can practice at the top of their license. I had a 30-year career in health policy, working for various advocacy groups, but perhaps the most important position was the director of the Office of Policy at the Centers for Medicare and Medicaid Services. So there I did a lot of research related to payment policy and incentives in the payment system for increasing and improving quality of care and outcomes of care. In that capacity, I served on the National Academy of Medicine Advisory Committee on the impact of birth settings on the quality and value of maternity care. And the research that we looked at in that committee found that for low-risk pregnancies, which is the large majority of pregnancies, community birth is a safe option with fewer complications, higher satisfaction, and lower cost care. Further, we discussed proposals for removing barriers to access to community birth, and of course, many of these proposals focused on legislation at the state level, such as allowing midwives with national certification to practice at the highest level of their training, potential insurance coverage, for example, Medicaid, and also just in general, decreasing barriers to community birth in all forms. Those were all parts of the recommendations in that committee. As a licensed direct entry midwife, I've seen how thorough, responsible, and competent community midwives are, both certified professional midwives and those that are certified nurse midwives. We take our training to identify what's normal and what is not very seriously. I've also heard story after story of how disrespectful, unsafe, and some women feel in the dominant model of care, and believe strongly that community birth can help in these cases. Thank you very much.
Thank you all for your testimony. I do not see any questions for this panel. Thank you very much. We have 2 favorable with amendment, Natasha Mayhew from Hospital Association and Christine Crone.
Good afternoon, members of the Finance Committee. I'm Christine Crone, here on behalf of the Maryland section of the American College of Obstetricians and Gynecologists to testify in support only if the bill is amended. I want to acknowledge the bill's sponsors and stakeholders for all working collaboratively through this bill process. The bill as introduced is in a much better place than how it began. However, Maryland ACOG still has a few concerns. ACOG reviewed the bill's provisions keeping in mind a direct entry midwife's scope, which is primarily to attend to a low-risk pregnancy and vaginal birth, providing prenatal care, labor support, delivery assistance, and postpartum care in a home setting. And we understand that the bill was introduced because the statute governing LDMs is set to expire in October. In addition to extending the sunset, the bill aims to update the statute and expand it to try to capture current practice of LDMs. Within the bill's provisions are 2 lists of conditions, disorders, or situations that can occur as prenatal care proceeds, which would trigger either a transfer of care or a consultation. And our concerns primarily involve the conditions listed on the consult list. We feel some clinical clarifications need to be made before we're comfortable with the patient safety aspect. Lastly, the bill also removes LDM reporting requirements. We feel the current data reporting isn't totally worthwhile for quality oversight purposes. However, we agree that quality oversight should be figured out some way. So we agree with doing away with these reporting requirements and keeping it in line with other health occupations regulated by the Board of Nursing. Again, I want to thank the bill sponsors and stakeholders. We still have a little more work to do, but Maryland ACOG is support only if amended. Thank you.
Good afternoon, Madam Chair, members of the committee. Natasha Mayer here on behalf of the Maryland Hospital Association in support of amendments to Senate Bill 854. Similarly to my colleague who just testified, we are in support with specific amendments to the bill. We have no concerns with the sunset, but we do have some concerns with the changes in scope expansion. So some of these scope restrictions are in place to ensure that home births are as safe as possible, that they're low risk, that they're within the scope of practice. We don't want to see these changes occur without it being clinically appropriate for their scope of practice. Hospitals do believe we need to strengthen the communication between the LDEMs and the hospitals so that there's a seamless transfer of care, particularly when there's an issue at home. Every second counts, and this can mean the difference between a catastrophic outcome and a healthy mom and baby. Hospitals need to know who to talk to, what happened, and more information about these birth plans and transfer plans. We do not have any concerns understanding that they want to address some of the onerous reporting requirements. We are open to streamlining those while maintaining a robust quality review for low-risk births within the scope. So we look forward to continuing working with the stakeholders on these amendments. We have made some progress, agree that the bill as introduced has been better than earlier, and we look forward to continuing that dialogue.
Thank you both. I don't see any additional questions, but I appreciate your work. I think we really do need to get this bill out, and just needs to be a little better than introduced. So thank you both for your efforts. So seeing no questions, I think we have one unfavorable, Deborah Bricado.
Good afternoon, Senators. I'm Deborah Bricado with Maryland Right to Life, and on behalf of our board and followers across the state, we ask for an amendment to exclude abortion purposes from this bill. Without it, we ask for an unfavorable report. While we recognize the very good intentions of the supporters of this bill to provide women with an alternative to hospital maternity care, we recognize that the services of a midwife includes providing or prescribing and dispensing medications. And there are some midwives who are trained or are training to provide abortion services. One of the medications that a midwife can prescribe is misoprostol, which has multiple purposes. One of those purposes is to bring on contractions and induce an abortion. With this in mind, the midwife is also able to decide to transfer a woman to a hospital. This bill would allow the midwife to do this without oversight by another healthcare practitioner. That's on page 6, lines 13 through 16. And it also removes the requirement for the midwife to accompany the patient to the hospital, and that's on page 11. It also removes certain reporting requirements specific to the midwife, and that's on page 11, starting on page 11. It makes it possible for a midwife to prescribe misoprostol for abortion purposes and then transfer a woman to the hospital, where the hospital and hospital hospital personnel would now be forced to oversee and/or complete the abortion. Liability and accountability are now transferred to the hospital and hospital personnel, the entity and people who did not prescribe misoprostol. We object to hospitals and hospital personnel being forced to participate in abortion. We ask for an amendment to prevent this from happening so that hospitals do not take over that liability or accountability, but without it, we do ask for an unfavorable report on Senate Bill 854.
Thank you, Deborah. I see no questions. Thank you for your testimony.
Thank you.
That brings us the end of the hearing on Senate Bill 854. Our next bill is Senator Lamb, Senate Bill 988, Dental Services, Dental Hygienists in Schools and School-Based Healthcare Centers. And his panel's Councilmember Felicia Porter, Dr. Winifred Booker, Robin Elliott, and Aaron Hansen.
Yeah, can we, I think Liz Elliott is also signed up. Can we also have her just come up on this?
I'm sorry, who else?
Liz Elliott?
Okay, she's not on, as your panel, but you can bring her up. if you
Yeah,
like.
I think she can just come up as part of the
Okay,
panel.
that's fine.
Oh, switch over. All right, I think we all fit. Great. So good afternoon, Chair Bidel, members of the Senate Finance Committee, here to be able to introduce Senate Bill 988 on dental services and dental hygienists in schools and school-based health centers. For the record, Clarence Lamb, Senator District 12. This bill, as drafted, seeks to streamline the process for dental hygienists to work with school-based health centers to provide preventive services to students. However, based on conversations with stakeholders, I think there was some bit of confusion about the current statute and the role that dental hygienists play in school-based health centers. So I've requested an amendment to just have the work group part of the bill get a report on how we can best move forward with this issue. So that changes the approach to this bill. So just wanted to make clear on that. Following the tragic death that many of us have heard of with Diamante Driver back in 2007, Maryland began to make significant progress on pediatric access to dental care. But recently that progress has stalled. Based on the state's dental access plan, we have had 64% of Medicaid-enrolled children receive preventive dental care in 2015, up from 50% in 2008. However, in 2023, we were back down to 56.5% of children getting preventive care. So it's 64%, which is up from 50%, and then now back down to 56%. For the last several years, we've been working towards expanding school-based health centers. I am the Senate's representative and designee on the Maryland Council of Advancement of School-Based Health Centers. These health centers would be ideal to help connect students and their families to dental care and also preventive services. The work group in this bill could help our committee identify how to better integrate dental services into the work of school-based health centers. And with that, I'm happy to turn over the rest of the members of the panel and take questions at the end, and appreciate the consideration of a favorable report.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Thank you for welcoming us this afternoon. I've been practicing pediatric dentistry for 33 years, and I have put over 2,000 children on the operating table with early childhood caries. So I know the suffering and pain that young children experience while in school even. And so I provided a packet for all of you because this is National Children's Dental Health Month, so everybody has this packet. And within that packet, there's an image you will see of children suffering with tooth decay that looks like this. And I would encourage you to take a look at that packet. Since the pandemic, we've had a large number of dentists that have retired. And while we have opened now in this country 70 dental schools, many of our young dentists are not aware of the amount of disease that we're seeing in young children. And I had one young lady who I mentored who said to me, she'll be graduating this May. She said, I am not going to work as hard as you. So with that, we do have an access to care problem. We have an access, a compromise to our workforce because we did lose so many dentists while we have dentists who accept Medicaid, I accept 79% of my patient population is Medicaid, but there are many who do not accept Medicaid or they take a limited amount of Medicaid. We're still trying to get operating room time for these children to be seen under general anesthesia that present with this massive tooth decay. And so with having the clinic in schools, I think that we address this access to care problem. One of the things that I will share with you is that the state of Maryland used to have dental clinics in Maryland public schools. Look at 1965. And so when you look at the package that I've provided, it will share that with you, that in 1965, we had dental clinics in school. I ask for a favorable report. Thank you so much.
Who'd like to go next? Member Porter, you want to go next?
Yes, ma'am. Thank you. For the record, Chair Beidel and Vice Chair Hayes and members of the committee, my name is Councilwoman Felicia Porter, representing Baltimore's 10th District and Chair of the Public Health and Environment Committee on the Council. As a public health scientist of more than 15 years, I've seen the work that you all have been talking about on this panel, but more importantly, I've seen the decline of this type of work at the grassroots level. I'm here to express my strong support of Senate Bill 988, which plays a critical role in improving children's oral health by providing preventative care, education, and early intervention. As chair of the Baltimore City Council's Public Health and Environment Committee, I know the importance of establishing the Maryland Collaborative to Improve Children's Oral Health. And also, as the sole sponsor of the Child Health Equity Act in the City of Baltimore, expanding school-based health services in the City of Baltimore, this initiative is vital to ensuring that our children in the city and across Maryland receive quality dental care they need. By passing this bill, we can take a critical step in improving access, preventing oral health issues, and promoting the overall health of our children. Senate Bill 988 is more than just a policy. It is a commitment to ensuring that every child, regardless of their background, has the opportunity to thrive. My office has been working very closely with families, community school coordinators, Baltimore City Public Schools executive leadership, and public health experts across Baltimore City to bridge critical gaps in health, education, and equity. These challenges directly impact student success, and our partners are ready to implement innovative, systemic changes that will create long-lasting, meaningful impact in the future. The passage and implementation of Senate Bill 988 will serve as a model to tackle these pressing public health issues and forward-thinking solutions. I want to thank the bill's sponsor for ensuring that children and families benefit from the good governance and high quality of care that is totally deserving of our great state of Maryland. Thank you.
Thank you, Councilmember. Robin, you want to go next?
Good afternoon, committee members, Chair Beidel. I'm here today on behalf of the Maryland Dental Action Coalition, the Maryland Assembly for School-Based Health Care, and the Maryland Association for School Health Nurses. This past fall, we took a close look at the numbers for kids and were alarmed by the decline in dental access for children. As Senator Lamb mentioned, we see improvement in access in Medicaid. After Diamante Driver's death, everyone worked really hard to try to improve access, and you can see that in the numbers. But after COVID, of course, the numbers plummeted, and they have yet to rebound. So we're really behind. Only 56.5% of children in Medicaid had a preventative dental service in 2023. So we know there's no money. We also know that we don't have enough dental providers. So what we thought we would do is good old-fashioned, get everyone together and figure out how we can do better with what we have. And so the collaborative has school nurses, dentists, dental hygienists, anyone who is involved with providing health care to children in schools. And we figured we should start with the schools because kids are in school. So with that, we would ask for a favorable report and really appreciate the support of Senator Lamb and this entire panel. Thank you so much.
Thank you, Robin. Aaron?
Good afternoon, Chair Beidel, Vice
Vice Chair Hayes, and distinguished members of the committee. Thank you for the opportunity to present testimony today in strong support of Senate Bill 988. My name is Erin Allum Hansen, and I'm the Director of Programs at Maryland Dental Action Coalition, a statewide network of individuals and organizations working collectively to improve oral health of all Marylanders. I am also a mom of a 3.5-year-old who will be attending Frederick County Public Schools in the near future. MDACT was formed as a response to the death of Diamante Driver, and our commitment to ensuring that Maryland's children have access to oral health services remain at the center of our mission. Now, almost 20 years after Diamante Driver's death, we're starting to see a concerning downward trend in the condition of children's oral health, reversing years of significant progress in the state. One indicator contributing to this concern and the need to act are the results of the 2022-2023 Oral Health Survey of Maryland school children. The survey was conducted approximately every 5 years by the Maryland Department of Health and is used to assess the oral health status of children in kindergarten and in 3rd grade. The latest survey results show a sharp rise in the students with untreated dental decay. Specifically, 21% of students experiencing untreated dental decay versus 14% in the previous survey. In addition, 30% of students needed early follow-up or urgent care due to pain or infection at the time of assessment, compared to just 13% in the previous time point. The interprofessional collaborative that this bill would establish would help launch a renewed public health approach to closing oral health gaps for children by focusing where children are, which is at school. So as a mom and an oral health advocate, I ask for a favorable report from the committee. Thank you.
Thank you very much. And I think we have one more, Liz Elliott.
Yes, Liz Elliott here. No relation to Robin, just thought I'd get that out there. I am the president of the Maryland Association of School Health Nurses, and maybe we're fifth cousins. We're still researching it. I'll let you know. And my mission is to help our state's kids grow into healthy and thriving adults. Oral health matters. I had a conversation with a nurse today about a child, elementary school child. And this little guy was really embarrassed because he had no socks. His shoes stunk to high heaven. He had no underwear. And this came to light because he came into the health room because he got applesauce all over him. I mean, thank goodness he ate breakfast at school, right? But so he had no socks and he had no underwear. And he had a big chunk of hair falling out. So what this bill will do is establish a collaborative to provide opportunities and ways to share really good programs that already exist in the state of Maryland with kids like this young boy who I did not find out about his insurance status. I didn't have time. But I'm betting he doesn't have a toothbrush. I bet you he's never been told how to brush his teeth. So there is an urgent need in our schools right now. We already in the state of Maryland provide hearing and vision screening because you have to be able to hear and see in order to learn. If your tooth hurts, if you have an abscess, number one, you might not make it there because you might be really uncomfortable. But number two, when you get to school, can you focus? Can you learn? And the answer is no. And we see those kids in our schools every day. And so on behalf of myself as a practicing school nurse and the Maryland Association of School Health Nurses, I urge a favorable report on this bill. Thank you so much.
Thank you, Liz. Thank you for your work. I have a question here from Senator Hayes.
Thank you, Madam Chair. Just first, as a point of personal privilege, I want to welcome Councilwoman Porter to Senate Finance Committee. Madam Chair, Councilwoman Porter and I work close together on many things, and I was very pleased to see her pick up the mantle as it relates to school-based health centers, because I think they're so vital and important to protecting our children, as illustrated by I forget the Miss Elliott testimony just a minute ago. Senator Lamb, I see that the Dental Association has submitted about 5 amendments, and I wonder if you wanted to speak to, if you've had a chance to review them, and if you wanted to speak to those amendments that they're suggesting.
So I think we're open to those amendments, but have not had a chance to actually. Actually, I think we're submitting. Have not had a chance to connect with them on them yet.
Gotcha. I understand. And for the most part, some of them sound reasonable. Some of them sound like they need a little bit more discussion.
Yeah.
So I would imagine so. Thank you, Madam Chair.
Thank you. I don't see any other questions for this panel. Thank you all for your testimony. We have one more favorable. There was no room at the tables. Sana Kataria. Hi, Sana.
Hello. Madam Chair, Mr. Vice Chair, and members of the committee, my name is Sana Kataria. I'm a dentist trained in India, and I'm currently pursuing my Master's of Public Health at Johns Hopkins. I also serve as the president of Johns Hopkins Oral Health Society, where I lead efforts to advance oral health advocacy, education, and interdisciplinary collaboration. I worked hands-on as a dental assistant and treatment coordinator in California. I also serve on the board of a federally qualified health center in California as well. I'm here today in strong support of Senate Bill 988. This will allow dental hygienists to provide preventive dental care directly in schools. Right now, over 10,500 children on Medicaid visit the emergency room for dental pain, many multiple times, totaling to over 16,000 visits. Emergency rooms can provide pain relief, but they do not treat the underlying dental disease, forcing children into a cycle of pain and infection. Maryland does not have enough dentists to meet the demand. Some counties have only one dental provider for every 2,000 plus Medicaid enrollees, leaving thousands of children without access to care. In total, there are only 203 pediatric dentists statewide to serve over 600,000 Medicaid-enrolled children. Maryland does not have enough dentists to meet the demand, but we do have the solution. This bill allows dental hygienists to provide preventive care in schools, eliminating the transportation barrier. They can apply fluoride varnish and dental sealants, which prevents up to 80% of the cavities before they start. Every $1 spent on sealants saves $6 in future dental costs. The data is clear. Putting dental hygienists in school saves money, reduces emergency room visits, and ensures that children get the care they need when and where they need it. Thank you. I urge you for a favorable report on Senate Bill 988. Thank you.
Thank you. I don't see any questions. Thank you for your testimony.
Thank you.
So next we have favorable with amendment, Dan Daughtry, Deborah Carty, Dr. Beckett, and Dr. William LeBeau. All favorable with amendment.
Thank you, esteemed Chair and distinguished members of the Senate Finance Committee. Thank you for the opportunity to speak in support of Senate Bill 988 with some very friendly amendments, 3 to be exact. My name is Deborah Carty. I'm a registered dental hygienist, and I'm speaking on behalf of the Maryland State Board of Dental Examiners. The board has always been fully supportive of programs that seek to improve the oral health of children, especially those that are the most vulnerable. Early detection and maintaining good oral health is critical, but we clearly need to do more. Cavities are the most common chronic disease among children, and untreated dental problems can lead to pain, infection, difficulty eating and sleeping, and other health conditions, as well as social and emotional issues and challenges in school. Preventive dental visits, such as checkups and dental cleanings, are essential to maintaining good oral health and can address problems before they become serious. The board supports Senate Bill 988 with 3 amendments, and these amendments are expressly written in our position paper. The First Amendment is at the bottom of page 2. It strikes section 1, lines 33 and 34 to help remove barriers. The Second Amendment is an insertion to include the chair of the State Board of Dental Examiners as a collaborative member. And the Third Amendment is another insertion on page 5 to include clarity of existing law in the collaborative study. The goal is improving the oral health of children. The board supports the Maryland Collaborative to improve children's oral health through school-based programs with amendments outlined in the board's position paper. For those reasons, the board requests that Senate Bill 988, as amended, receive a favorable report. Thank you again for the opportunity to testify.
Thank you. Dan?
Thank you, Madam Chair, members of the committee. I'm Dan Doherty, representing the Maryland State Dental Association. We submitted testimony in support of the bill with amendments. The amendments addressed Section 1 of the bill, which I understand from the sponsor's testimony is going to be deleted by his amendments. So therefore, the Section 2 that remains, we are in support of. So I'm not going to go through amendments that aren't going to be relevant and ask a favorable report on the bill. Thank you.
Thank you, Dan. Who's next?
Madam Chair, members of the Senate Finance Committee, after hearing Senator Lamb's earlier testimony, I'm going to just mimic what our lobbyist Dan Doherty said as the legislative chair of the MSDA, and me too, and we ask for a favorable report with a work group part of the bill being proffered. So I ask for a favorable report of 988 under those terms.
Thank you, Dr. Beckett. Dr. LeBeau.
Madam Chair and Mr. Vice Chair and members of the committee, Bill Lebo, general dentist from Federal Hill. I also am in favor of the bill with the amendments and would hope for a favorable passage. Thank you very much.
Thank you all for that brief testimony. Do I have any questions? Senator Lamb.
Thank you, Madam Chair. And this is just to follow up on the Vice Chair's question earlier regarding our amendment. So with our amendment, the sponsor amendments to change the intent of the bill to really just focus on the work group, you're comfortable with that?
We are comfortable with that. And our amendments were friendly amendments, just trying to clarify things anyway. So we are fine with the bill.
Okay. Thank you.
Thank you all very much. That ends this panel.
Thank you, Madam Chair.
Thank you.
Thank
We
you.
have two virtuals. Katie Batani's favorable, and then Christina Bartz is favorable. Katie, you want to unmute and start?
Thank you. Thank you, Chair Beidle, Senator Lamb, and committee members for allowing me to testify today. My name is Katie Batani. I've been a dental hygienist in Maryland for 23 years, and I've worked in the public health sector for about 13 years. I'm here in strong support of Senate Bill 988 to create a collaborative to study how access to dental care could be improved via school health services. I worked for many years developing and implementing school-based dental programs for the Harford County Health Department in close partnership with Harford County Public Schools. I've seen firsthand the difference these programs make by meeting kids where they are to identify tooth decay and to connect children and families to dental care. These programs provide education on the importance of oral health and good oral hygiene and nutrition. They provide fluoride treatments and dental sealants to children's teeth to help prevent future cavities. However, challenges still exist to making these programs as robust in our state as they could be. There is no direct Medicaid reimbursement for dental hygienists and school nurses who provide dental services. There have been dental hygiene workforce shortages since the pandemic, and there is typically insufficient grant funding to adequately maintain and grow existing school-based dental programs, even for programs that receive reimbursement from Medicaid. The collaborative is needed to unpack these issues and to create recommendations that will improve the oral health of children in Maryland via a school-based approach. My final remark, as we're celebrating Children's Dental Health Month, as mentioned this month, and remembering the legacy of Diamante Driver, is that tooth decay is a disease that is preventable. But we must use many different strategies to prevent it and to support our families. Schools are among the best ways to improve access to dental care in a collaborative way with school administrators, nurses, teachers, and parents. With that, I ask for a favorable report to establish the collaborative. Thank you.
Thank you, Katie. And Christina?
Good afternoon, Madam Chair, members of the committee. Thank you for your time today. My name is Chrissy Bartz, and I'm speaking on behalf of the Maryland Academy on School-Based Health Centers to strongly support Senate Bill 988, which seeks to expand school-based dental services across Maryland. As a school-based health center provider and director of community-based programs for Choptank Community Health, I've had the opportunity to witness the critical role that accessible dental care plays in a child's overall health, academic success, and well-being. Dental disease is one of the most preventable yet prevalent health issues affecting our children. In 2023-2024, during that school year alone, Choptank Community Health's school-based dental program served 3,565 students across the 5 counties on Maryland's Eastern Shore, and alarmingly, 1,107 of those students had active dental disease. That means that nearly 1/3 of the students that we examined were experiencing untreated cavities, infections, or other oral health concerns that were causing pain, difficulty eating, and problems concentrating in school. School-based dental care is a proven solution to address these issues. It ensures that children, particularly those from underserved communities, receive oral health care without the barriers of transportation, financial limitations, or lack of available providers. Additionally, for many students, school is a familiar and safe environment. The school setting allows children, especially those who may have dental anxiety or fear, to receive care in a place that they often feel very secure and supported. By passing Senate Bill 988, Maryland can build upon the successful school-based dental program models like Choptanks and expand access to care that not only prevents pain and illness, but also improves educational outcomes and student attendance. Investing in these programs reduces emergency room visits and essentially will help to improve and decrease healthcare costs. It ensures that no child's future is hindered by untreated dental disease. I thank you so much for a favorable and support of Senate Bill 988.
Thank you, Chrissy. So do I have any questions for these two witnesses? See no questions. Thank you very much for testifying. And that ends the hearing on Senate Bill 988. Next, we have Senate Bill 919. Senator Guile, you're going to present Health Occupations Practice of Audiology Definition. And you have Gil Jen, Alicia Didi Spoor, and then there will be 2 people. I don't know if you want favorable with amendment. Do you want those 2 folks on your panel? Senator?
Why don't we just have the
Okay, we'll start with these.
Hey, how are you? Good afternoon, I guess. Yeah. Good afternoon, Madam Chair and members of the committee. Senate Bill 919 tightens up some language on a bill I sponsored and that passed the Senate last session. As members may remember, the bill we passed last session modernized the practice of audiology language and statute to improve patient access and to lower costs. Since having discussions with the administration, as well as some of the opponents of the bill, and from our proponents with the audiologists, we decided to take a second look at doing some minor language adjustments in the bill. Senate Bill 919 is the answer to that call. Before you is a bill representing some adjustments based on consensus reached with the stakeholders involved. There remain some small differences of opinion that the varying stakeholders will speak to today. Joining me at the table are representatives from those stakeholders, as well as I know from MedChi and others as well, who will make their case for the preferred policy solution. And for these reasons, I respectfully request a favorable report on Senate Bill 919. Thank you.
Thank you, Senator. Gil, would you like
to? Thank you. Thank you, Senator Guile. Madam Chair, distinguished members of the committee, Gil Jen here on behalf of the Maryland Academy of Audiology. You're going to hear what other states have done with your landmark bill that you passed last year. The remaining issue is to clarify what is meant by health screening on page 2, lines 15 and 16 of the bill. We compromised with additional language, auditory and vestibular, and the last few words of debate are whether we should have third-party payer. We must have third-party payer language in this bill. Medicare is federal, Medicaid is state, but Medicare Advantage programs are private insurance programs. As Dr. Segev in her testimony said, individuals who choose an MA plan may waive their Medicare. Third-party payers, Blue Cross, Aetna, United, administering the MA plan can incentivize or penalize their network providers, such as audiologists. Therefore, audiologists can't be afforded to be penalized by not fulfilling the private contract provisions, such as health screenings. That's why we need the TPP language. You'll hear from the other side that they don't like third-party payer language. Appended to my testimony are 6 pages of statutes where that is used. So, for example, 15103, adoption of forms, is a healthcare practitioner means a person that's licensed or certified under the healthcare OC article, reimbursed by a third-party payer. In the dental practice, in the scope section, interacts with patients of third-party payers, as well as other provisions as well. In the physician, 14404, licensed physician discloses to a third-party payer. We think we've reached agreement. It's just this little phrase. We support a favorable amendment to 919. Thank you.
You. And finally, Alicia.
Thank you, Madam Chair and committee members. My name is Dr. Alicia Spohr, and I am strongly supporting Senate Bill 919, particularly the inclusion of third-party payers in conducting health screenings, which is still being debated. Audiologists are mandatory providers of Medicare Advantage plans administered by third-party payers, including Blue Cross and United Healthcare, which are regulated under the Maryland Insurance Administration. Medicare has threatened for years to include mandatory health screenings in Advantage plans, and United Healthcare already references that all plans have preventative screenings. If audiologists are not explicitly permitted to perform healthcare screenings by statute, they risk financial penalties on all claims in a calendar year. The clause third-party payers is crucial in Senate Bill 919 for this very reason. Also critical to the practice of audiology is the ability to order radiographic imaging and blood work in cultures. Prior to October 2024, Dr. Lee McCarthy, who practices in rural Leonardtown, evaluated a patient whose test results suggested a possible tumor. She referred the patient to General Ear, Nose, and Throat office, and the patient was seen at the first available appointment with the physician assistant. The PA ordered an MRI, which revealed a large brain cyst, and she was referred to an otologist in Washington for treatment. The process took more than 4 months. In January, I evaluated a patient whose test results suggested a possible tumor. Thanks to the passage of 795 last year, I ordered the MRI, which confirmed a brain tumor and a cyst. I contacted the primary physician, corroborated the treatment plan, and scheduled him with neurootology at Johns Hopkins. The process took only weeks. We have an opportunity to build on the 2024 passage with Senate Bill 919 to ensure patient access and affordability and prevent financial penalties to audiologists while continuing to set an example for other states. Thank you, Senator Guile, for your commitment, and I request a favorable report on Senate Bill 919.
Thank you all for your testimony. I do not see any questions. And so we're going to now go to 2 people favorable with amendment. Ashley Bagwell and Annette Pham.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. I'm Ashley Bagwell, here this afternoon for MedChi on behalf of the Academy of Otolaryngology in support of Senate Bill 919 with amendments. Thank you to Senator Guile for introducing this bill and to this committee for allowing us to revisit this issue one more time. The Academy, frankly, had a lot of issues with the bill that passed last year, but we've worked together to whittle that list down to just the most important issues that we'll highlight today. I will also note that some of the suggested changes we are requesting address some of the issues that the governor raised in his letter last spring. First, on page 2 of the bill, lines 1 through 2, this language was included in the bill as proposed last year, and this committee struck it. I think, frankly, maybe this language was inadvertent in this bill, and so we would respectfully request that that language be struck. Again, you heard about the health screenings language. In listening to the audiologists, we did hear their concern about participation in MIPS, and we understand that and feel like that needs to be addressed. We do have issue with the third-party payer language. We do feel like that's awkward here in this bill and gives third-party payers more input into scope than is necessary. We are in agreement with the radiographic imaging language that was mentioned before. Dr. Pham is here with me today and will speak specifically to the ordering cultures and blood work language that's in the bill. And with that, Madam Chair, I will turn it over to Dr. Pham.
Okay, go ahead.
Thank you. Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Senate Finance Committee. Thank you, Senator Guile, for bringing this back up. My name is Dr. Annette Pham, and I'm a double board certified otolaryngologist in facial plastic and reconstructive surgery, practicing in private practice in Montgomery County for greater than 15 years. I'm a member of Maryland State Medical Society and the Maryland Society of Otolaryngology. And I appreciate the time and attention you're giving to this issue. Again, I'd like to respectfully request language in the bill that allows the audiologist to order cultures and blood work be removed from the bill. In order for a culture to be accurate, more specialized training is required. It's not just simply ordering a culture, you actually order it and perform it yourself. And the ear is actually not a sterile area. So there can be unreliable results, which can lull you into the idea that pending results may mean, easy access to care, but that is not the case. And in fact, in order to achieve a really accurate result, you actually need to go into the middle ear space and get a culture, which certainly otolaryngologists can do, but I can tell you from standard practice and training, it is very uncommon for us to do routine cultures, and it's actually not indicated to do routine blood work related to auditory and vestibular disorders on a routine standard basis, because you have to take into account the entirety of the whole body. So I understand that there's some an argument that there's a lack of ENTs in some parts of the states, and I recognize that, but cultures can also be done simply by other physicians, pediatricians, and internists. And so really, in the end, we work closely with audiologists as part of a healthcare team, and we want to collaborate, and we want to improve access to quality care and not increase our costs by having unnecessary tests. So ordering tests is something that goes along with making medical diagnoses, and audiologists have a gap in training in making medical diagnoses. For this reason, we respectfully request this language to be removed. Thank you.
Thank you. Senator Lamb.
Thank you. So just looking through this bill, it includes requirements of for third-party carriers in the definition and the scope of practice for an audiologist. Right. Are you able to point us to an example in current law where third-party carriers are actually defining scope?
We did a search of scopes for all practitioners in Maryland and did not see where that was in the scope part, in the scope of any practitioner where it gave third-party payers the ability, it seems, to help determine scope.
Okay, so you couldn't find any reference to that. And how would a board determine if a third-party carrier's requirements were proper for use by an audiologist?
I think that's a challenge, too.
Okay. All right, thank you.
Thank you. I see no other questions for this panel. Thank you very much.
Great.
That ends the
Thank you,
hearing
Madam
on
Chair.
Senate Bill
Thank you.
919. Senator Guile, do you want to present Senate Bill 173? And it's Senator Guile, Jeffrey Buttle, and John Hall.
Good, how are you? Good afternoon, Madam Chair, members of the committee. You may recall little woman about this high, previously sat between the chair and Tammy over there. Anyway, this was her bill previously, and then when she went off to greener pastures in Baltimore County, I agreed to take it on. So with that, Senate Bill 173 would clarify the definition of disablement for workers' compensation presumption coverage for hypertension. Workers' compensation law establishes a presumption of compensable occupational disease for certain public safety employees who are exposed to unusual hazards in the course of their employment, and it's assumed that these injuries or diseases are due to the employee's work and therefore requires no additional evidence in the filing of a claim for workers' compensation. The clarification in this bill reinforces the original intent of the workers' compensation presumption coverage for hypertension that was first enacted in 1971. The proposed change ensures that disablement is clearly defined by incorporating well-established medical criteria for hypertension as outlined in the National Fire Protection Association 1582 Standard on Comprehensive Occupational Medical Program for Fire Departments. This bill's occupational disease presumption applies only to volunteer and career firefighters, firefighting instructors, rescue squad members, advanced life support unit members, fire marshals employed by an airport authority, a county, a fire control district, a municipality, or the state. Existing presumption eligibility provisions that require an effective volunteer to meet a suitable standard of physical examination before becoming a volunteer continue to apply. To demonstrate disablement and be deemed to have hypertension under the bill's expanded occupational disease presumption, an individual must have a blood pressure reading that exceed 140/90 as required for a finding of hypertension, have been required to use prescribed medication to treat hypertension for at least 90 consecutive days. This clarification is critical for several reasons. First, it aligns the workers' compensation presumption coverage with current medical standards, ensuring that individuals who experience significant hypertension-related health risks receive the support that they deserve. Firefighters and emergency responders are routinely exposed to extreme physical and psychological stress, which has been scientifically linked to an increased risk of hypertension. Given the cumulative toll this takes on their health, it is imperative that we provide them with a clearly defined pathway to obtain the benefits that they rightfully have earned. Furthermore, by explicitly defining disablement criteria, this amendment reduces ambiguity in workers' compensation claims, fostering a fair and more efficient adjudication process. Per the fiscal note, Senate Bill 173 would cause state expenditures to increase minimally, and for these reasons, I respectfully request a favorable report on Senate Bill 173. Thank you, Madam Chair.
Thank you. Jeff?
Good afternoon, Madam Chair. Jeff Buttle, President of the Professional Firefighters of Maryland. We represent approximately 10,000 active and retired professional firefighters and emergency medical service workers across the state of Maryland. We are here today in support of Senate Bill 173. I think Senator Guile did an outstanding job presenting the bill and describing parameters, so I won't repeat that. Madam Chair, as you know, we put a lot of work in this bill over the last couple of years. We've had a lot of discussions over those various sessions, and really we think this bill is in the right place to be able to more clearly define what constitutes disablement for a firefighter when it comes to hypertension. And really the idea behind it is to reference the NFPA medical standards, where once a firefighter gets above that 140 or 90, if they cannot get their blood pressure controlled below that level, it eventually will cause them not to be qualified to be a firefighter. So I don't know what could be more disabling that if you can't control your blood pressure and get it under control below those levels, you simply wouldn't be medically qualified to be a firefighter. So I hope we have the bill in a position this year where we can finally get this passed. And really what it's aimed to do is to have, because I know Mr. Hall is going to speak to this in a minute, there has been some inconsistencies with rulings from workers' compensation commissioners, and our firefighters deserve to have one standard that is applied equally, no matter if you're a firefighter in Ocean City, Garrett County, or anywhere in between, no matter what commissioner is hearing the case. Our firefighters should deserve to have a clear standard that is applied fairly and equally to all of them. So with that, Madam Chair, again, we are in support of this bill. We hope we can get this moved favorably, and thank you for your time this afternoon.
Thank you, Jeff. Mr. Hall?
Thank you, Madam Chair. First of all, I just wanted to say, introduce myself. My name is John Hall. I was a prosecutor in narcotics in Prince George's County for 6 years, and since 1998, I've been representing firefighters and police officers in the state of Maryland. Truly in the trenches, I probably had about 15,000 cases over my career for fire and police, and this bill strikes a chord with me because, and thank you, Senator Guile, for this supporting the firefighters. The problem with the workers' comp statute, the way it sits, is that there's no clear definition of disablement. So we recently I just had a case within the last 2 months where I had the typical standard used to be if the firefighter misses 3 days of work because of his hypertension, the doctor puts him out, they consider that disablement. I just had a hearing 2 months ago where I had a firefighter who was actually assistant chief at BWI who was out for at least 3 days with a physician's note, and it was declared not disablement. I've also wanted to stress upon you that many of the firefighters, they don't want to miss work. So they're not missing work. When they don't miss work, because they don't want to miss work because of the high blood pressure, they don't take care of themselves. We have a hypertensive crisis that ends up in a stroke or a heart attack. It's very important to understand this is a big problem for the firefighters and what they do. I also wanted to point out that you're going to hear from our opponents that are going to speak against the bill. We've tried, this is our third time up with compromises to try to get this through. The current language we have is based on the NFPA, which governs the firefighters and their ability to work. Our opponents today are going to tell you, oh, well, if they don't find disablement, it's not ripe and they can refile the claim. Well, what are we waiting for? A stroke or a hypertensive crisis? It just doesn't work that way. Right now, with the way the Workers' Compensation Commission is set up, we don't have a clear definition of disablement. That's the problem. This defines it, this sets it out, and this sets the standard so we don't have to go through that. I would just ask for favorable reading for Senate Bill 173.
Thank you, Mr. Hall. Do I have any questions for this panel? I don't see any. Thank you for your testimony. I tell you, based on my blood pressure this morning, I should be disabled. We have two unfavorables, Julie Murray and Michael Daly.
Good afternoon, Madam Chair, members of the committee. My name is Julie Murray, appearing on behalf of the Maryland Defense Council, and we are respectfully requesting an unfavorable report yet again on House Bill 170, I'm sorry, I'm saying the House Bill version, on Senate Bill 173. I would like to just briefly address something that was brought up by the panel in support of the bill, which is that there is not a clear definition of disablement under our Act. There actually is a clear definition of disablement under the Act, which is actual incapacitation. It's one of the components of an occupational disease, not just as it relates to hypertension, but as it relates to all occupational diseases that exist under our Workers' Compensation Act. And it's well established under years of precedent and years of case law and statutory provisions. The Act does require this because it's a component that is needed to prove a claim. In terms of the argument that people don't want to miss work, the problem with that is that if they don't want to miss work, once they have that actual disablement, their claim then does become ripe and they can then pursue their claim. The belief that because a person doesn't have disablement means they don't have a compensable claim is not true. If they don't have disablement, all they need to do is wait until they meet that legal threshold, and then they have a claim that they can bring under our Act. What this bill is trying to do is essentially fundamentally change the legal requirements of an occupational disease for just a small subset of the population under the Act, and for that reason, Maryland Defense Council does not support the bill and would request an unfavorable report. Thank you.
Daly?
Thank you, Madam Chair, Mr. Vice Chair, members of the Finance Committee. My name is Michael Daly. I am with the Maryland Defense Council. Respectfully, we ask this committee for an unfavorable report on this bill. One of the structural components to our workers' compensation statute is that one must have specific components to the claim. And when you look at the definition of an occupational disease under our laws, there has to be a disablement from the employment in which one is hired. And when you think about it, the rationale is very clear. In order for it to be an occupational disease, it must impact the ability of that employee to do the job. If this bill, as it stands now, goes through, this firefighter would never have to miss a day of work, nothing would be impacted in their job, and yet there would be a deemed occupational disease. The problem with this bill, however, is that it creates unnecessary adverse impacts within the structural integrity of the law itself. Because when you start chipping away at those components to what you need to show in order to establish what should be compensable and what may not yet be compensable, then that throws a whole hitch into it that could potentially create problems not only in the current status of occupational diseases, but throughout the structural integrity of the statute itself. In addition to that, when you look at what the commission does with these cases and how they try it, they determine whether or not that employee, with the presumption, because again, 9503 as it stands now, as the law is now, these firefighters have a presumption that their hypertension is in fact an occupational disease. So the employer must establish that it's not an occupational disease. One of the things that that employee must be able to show is that it's impacted their ability to do that job. Thank you.
Thank you. Do I have any questions for this panel? Senator Mounts?
Just one quick question. So the proponent table was speaking of a condition, and the bill is intended, maybe I'm wrong, correct me if I'm wrong, but the bill's intended to prevent or to get treatment for the police officer or the firefighter before they have the condition of being disabled, in other words, the stroke or the heart attack. Am I getting that wrong?
Well, just one thing, Senator, it would only apply to firefighters the way it's worded out. Would not apply to
firefighters, okay.
just firefighters, not police officers. And
I didn't mean to offend my firefighter friends.
And to answer your question, though, the way that the bill stands now, there has the disablement component that's required in every occupational disease is no longer applicable, but just to this condition. So they wouldn't have to prove any kind of disability of any kind. They just simply are reading by a standard that's not that's a static medical standard that could change.
Sure, and so I understand your testimony. Your testimony is that should not be qualified until there is a disabling condition, such as a heart attack or stroke or something like that.
No, certainly not a heart attack or a stroke. But what has to happen is there's got to be a doctor under a doctor's care that would say that the person's not able to do the job because of the hypertension, that it impacts their ability to conduct their job. And that's applicable to any occupational disease under Maryland law.
Okay, well, you answered my question. Thank you.
You're welcome.
Thank you, Senator. I don't see any other questions. Thank you for your testimony. That ends the hearing on Senate Bill 173, and now we're going to go to Senate Bill 219, which is a departmental bill. Michael Burns. Mr. D'Alessandro, do you want to come? You're both favorable with amendment, or do you want to wait? Mr. Burns, you can begin.
Thank you. Good afternoon, Madam Chair, Mr. Vice Chairman, members of the committee. My name is Michael Burns. I'm the director of the Maryland State Uninsured Employers Fund. That's a statutory agency that was created to protect Maryland workers when their employer fails to have required workers' compensation insurance, they are injured, and the employer refuses to pay the orders of the Workers' Compensation Commission. In that case, this agency steps in and pays both their medical and their indemnity payments. It is a fund that was established in 1983. When this legislature established this fund, it determined that the main funding mechanism would be an assessment on most Workers' Compensation Commission orders and settlements of 1% plus an additional 1% if it was required to maintain the solvency of the fund. That provides and has provided approximately 80 to 90% of the funding in order to take care of these injured workers and their families. Over the years, the agency has moved from the simple 1% and done the additional 1% since 2010 approximately in order to continue to pay these benefits. Unfortunately, in the last 2 fiscal years, the amount of the benefits has gone down that we've received by approximately $2.4 million, and the fund balance has also gone down by approximately $2.4 million. This reduction in assessment revenue has continued until this time. This represents the 3rd time I've come to the legislature with a version of this bill. We did a study in 2020 saying that the UEF would become insolvent by 2030 if there was not an increase in revenue. The agency is, frankly, on a trajectory to become insolvent. When I was in the legislature, I always admired plain speaking and honesty, so I will give you both. This is where we get 80 to 90% of our funding. This is how we pay for the injured workers, and this assessment needs to be increased. The bill increases it by an additional 1% if required by the fund to ensure the solvency of the fund. It is not a permanent 1% increase. What it is a safety valve to allow the agency to have the funding it requires in order to pay injured workers and their families. It is our belief that as time goes on, the fund will increase its balance to the point where it will be able to reduce that assessment from what would then be up to 3% to a lower amount. We have been in discussions with the administration. This isn't a more administration bill. We've been in discussions with the administration, with members of the Economic Matters Committee, and with members of this committee. And a consensus seems to have developed that rather than a 1% request, this should be a 0.5% request. This agency totally supports that, would offer that as an amendment to the bill. So instead of an additional 1%, it would be an additional 0.5%. The insurance industry does not like this bill. I do not blame them. I would not like paying this additional money either. If anyone has a better way to fund the agency, this agency is always available to any suggestions to do so. But considering that decision was made 42 years ago, I have to tell you that I believe that this is a prudent but absolutely necessary thing to do. Absolutely necessary. If the assessment revenue has gone down because we're not getting as much assessment revenue, it's got to be made up somehow, and this is how to make it up. As I said, this is the 3rd time I've come before the legislature offering this over the past 5 years. I strongly, strongly urge an amendment to this bill to make it a 0.5% increase, which is optional, in order to continue to pay the benefits to these injured workers and their families. I will tell you, it's only a couple of thousand people, but to those people, this agency is their life. This is the agency that keeps them going. And this decision was made 42 years ago. I am cognizant and sympathetic to the insurance industry, but I am more cognizant and sympathetic to the people that I've been taking care of through this agency for 8 years. It's necessary, it's required. I would urge a friendly amendment to make this a 0.5% and your favorable support for this bill. Thank you, Madam Chair.
Mr. Burns, thank you for your testimony, and thank you for offering the amendment. That's what we've been discussing. Tell us again, who pays this assessment?
This is paid on most orders of the Workers' Compensation Commission, which would mean that the insurers of the injured workers would have an assessment. The Uninsured Employers Fund has, and it has for decades, a 2% maximum assessment. The subsequent injury fund also receives an assessment. That is a mandatory 6.5%. So it's a total of 8.5%. So if we did increase it, it would go to potentially 9%. But I really think over time that that could be lowered back. The fund just needs the infusion of funds right now. And the way it works is, the sooner I tried to explain this back in 2020, the sooner we get the money in, the more money we get. So if we wait another year, another 2 years, we lose the benefit of that funding. And that has really, I think, been part of the issue up to this point.
So I just want to clarify, employers that carry workman's comp and their insurance pays the claims, so these are the good guys, right, that carry the insurance, those claims are paid, and then on top of that, 9% of that claim is paid to the UEF and the SIF.
That would be the case in this. It'd be the insurance company, yes.
Are you collecting any fines from these uninsured employees that are causing the problem that keeps UEF in business?
Absolutely.
Tell us about that.
Absolutely. When I got to the fund 8.5 years ago, collections had basically stopped. So we restarted everything. We have the authority to suspend business licenses. Well, we don't suspend business licenses. We try to suspend it under the statute. We have to go to the various agencies, the counties, municipalities, the state, the agency, and if there's an appeal, and get them to actually do it. It's cumbersome and slow, but we do it, and it's very effective. I also established, reestablished a program that as soon as we would get orders from the commission, we would begin the process of trying to collect the money. That had stopped. And I will tell you, when I arrived in 2016, we had employers who had been ordered by the commission to pay who hadn't been done by that agency in years. So now we do it immediately. We begin the process of business license suspensions immediately. There's a process of, we have to send out a certain number of notices, so there's a certain time lag in it. But we are right on top of that always now. When we have the employer, we go immediately after them. So yes, we do. Last year, the legislature, and this committee supported this, last year the legislature raised the amount of the potential fine for failure to have insurance from $10,000 to $25,000. And hopefully under the new program established by the Workers' Compensation Commission, this agency will start to see some substantial funding from that as well. I have great hopes for that, but that is a function of the WCC, and we have no control over that. And but yes, we do. We go after people. We have pay plans. I will tell you, I'm always open for business. I have pay plans that'll last 40 years, and the reason I do that, because money is better than no money, and you're not going to get rock from a stone. And any money I can get out of people, I try to get.
Thank you, Mr. Burns.
Certainly.
Senator Reedy?
Thank you very much. Just curious about this. Thank you for, and I've been looking at all of this since we had the briefing, and it's certainly, obviously, we're all concerned to make sure the fund is healthy, and we also want to be sure that we're going after bad actors. And I appreciate that you're talking about folks who, or businesses who are trying to pay back. And so, but can you just provide, do you guys have like hard numbers on projections of when the fund would run out, or if a certain amount of run on the fund would run out? I guess I'm trying to figure out, like, what do we have in the fund now versus what we project the needs to be?
Well, the last actuarial study was done in 2020, as I said, and it projected that unless there were increases to the fund, it would be I call it insolvent. You know, we're always getting money in and always paying money out. So we'd be kind of like the state of Illinois, the way they pay bills, like when they get the money in and you just have to wait. So we would always be paying bills and paying injured workers, but we'd be in some kind of a process that we'd have to watch what we were doing and all that. That's 2030. However, this decline in the assessment revenue, and it's just the way it is. This isn't a fault thing, that the assessment's down. This is not. Sure. And nobody's doing anything wrong. It's just what's going on. But it's been consistent now for 2 fiscal years, and it's going on now. We're just getting lower assessments from the old days, and that has taken a stable fund and is drawing our money down. If it continues, I would estimate at the rate we are, and this is an estimate, at the rate we're going, probably in fiscal 28 or 29, the fund would face a balance of zero. So, and we could do another assessment. I will tell you that as part of the budget committee's analysis, they want us to do another study about how we take care of the workers and paying for an outside TPA, which I've been talking to my staff about looking at that differently, like perhaps doing a new actuarial study as well at that point to see exactly where we are now in addition to that, because that's been an issue of do we pay them too much? Is that not something we should be doing in-house? We vehemently disagree with that. Others with less knowledge of what we do and how we function and what we actually have to do support it, but that's, of course, they're right.
Yeah, that I may be kind of getting at that, as I've heard a little chatter about that. I guess my question on that, so curious, it's hard for you to provide an exact amount of money that's in the fund day to day, but it feels like that's something we ought to be able, I understand it's like any sort of profit and loss statement or any sort of books you do, you can have a balance, and then just because my balance 15 days later is going to be different than it was 15 days before, but I feel like the TPA issues, feels like that ought to be something we're monitoring all the time and be able to have a quicker at our fingertips answer. So,
well, the TPA costs what it costs under the contract for their services. Everything else is payments that go through them, and that has created a lot of confusion. The pharmacy, they take care of the pharmacy benefits of injured workers. They take care of the medical. They do IMEs, evaluations. They pay for translation services, and all that gets funneled through. So the actual cost is a little confusing, but we know under the contract how much they get every month for their performance. And the new contract, which took effect October of last year, is 20% lower than the prior contract.
So if we had brought all that in-house, you'd have to hire employees for multiple different roles that you go through the TPA for.
Yes.
For one role. It's just, you can understand the question here because we're asking to double this assessment on businesses at a time when we're told we need to improve our private sector economy. So it's just this one thing might not seem like a big deal, but everything's a big deal right now to a lot of us. So I appreciate your answers to your questions, and I know we'll all look at the bill and see what we need to do.
Thank you. Thank you, Senator.
Senator Kramer.
Thank you, Madam Chair. Good afternoon, Director Burns. Madam Chair, I think the bill before us with the amendments as suggested by the Director is a good compromise. I had the pleasure over the interim of spending time with the Director and our outstanding Commissioner Quinn, from the Workers' Compensation Commission, and I see our friend Carmine D'Alessandro is here, and he may be coming up as well. So I had the opportunity to be with some of my favorite people, and want you to know how much I appreciate that. But I think the bill before us does reflect a good compromise, and I look forward to having a favorable report so that we can ensure that the UEF is stabilized. I do understand and share the concerns of my colleague about wanting to protect our business community, because it actually is the good actors who are offsetting the costs that the bad actors are creating. But having said that, I think we have a good work product. So thank you, Madam Chair.
Thank you, Senator. Thank you for serving on that commission over the summer. I don't see any other questions for Mr. Burns. Thank you very much for your testimony. Thank you,
Madam Chair, members of the committee. See you again soon.
I know. Mr. D'Alessandro, do you want to tell us about your...
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. For the record, Carmine D'Alessandro, representing Chesapeake Employers Insurance Company as its Chief Legal Officer, also serving as General Counsel to the Injured Workers Insurance Fund. Lindsay Menninger, who serves as President, is here as well. We are here to support the bill with the amendment of the .5. I appreciate Mr. Burns saying this was a consensus. I think the consensus right now is Mr. Burns and myself. Even though I'm with Chesapeake, I certainly am not speaking for the insurance industry, and I know they will be up to oppose this bill. And in all transparency, I agree with everything they are going to say. However, Mr. Burns makes one very good point. There are a great many injured workers that the UEF is taking care of. And while we talk about the potential insolvency in 2028, that's all things being equal. If 3 people are working on a scaffold down the street and they all fall because of the wind, and that employer is not insured, I can assure you the $5 million in the bank will be gone in 6 months. So the problem with that balance, and the reason I'm here to support reluctantly an increase in the funding is, we're talking about a projected insolvency, hoping that there's not some catastrophic injury that occurs that wipes that balance out instantaneously. As a member of the work group, and I would be remiss without thanking Senator Kramer for his guidance and influence during the discussions and keeping the parties in their respective corners at all times. I also was part, and forgive my disjointed, my support is conditioned on Senate Bill 695. As a member of the work group, the UEF was focused on finances, but there's infrastructure issues as well. And if we're going to give a little pound of flesh on the finances, I think we should also work to start building a foundation in the UEF futuristically, so we're not here every couple of years in a financial crisis. So thank you, and I'm available for any questions.
Thank you. Senator Motz.
Thank you, Madam Chair. Just one quick question, too, and for the committee members. When we're talking about a compromise and going from, one threshold to another threshold, where are those costs ultimately borne? And who's actually paying for this increase?
So those would be all of the policyholders that have insurance and also the state of Maryland. So for example, Senator Motz, just in since 2021, Chesapeake's insureds and IWIF, state of Maryland, contributed $6.8 million to the assessment. With the 1% increase, it would be an additional $1.5 million to the state of Maryland. So obviously with a 0.5 it would be less. But anytime the commission issues an award where basically an injured worker is receiving money, that award, there's an assessment on top of that. So every single employer who has insurance, once that employer has an award assessed against it, they would be kicking in. And if any state agency had an injured worker working for that agency that received money from the commission, at the end, DBM would figure out, in looking at the entire compensation bucket for the state, they would charge back to each agency, and that agency would also be responsible for the assessments.
Yeah, and the point I'm trying to draw out, which I think would be accurate, and I just want your confirmation to be accurate, that that's being paid for by taxpayers and employers.
Correct.
Thank you.
Sorry about that. Are there any additional questions for this gentleman? Thank you so very much.
Thank you.
We do have at least 2 people signed up unfavorable, Julie Mary as well as Michael Daly. You guys may begin when ready.
Thank you. Good afternoon again. Julie Murray on behalf of the Maryland Defense Council. We do have to respectfully oppose this bill. While the MDC is certainly aware of the UEF's funding problems and does not want to cause any problems for those injured workers that do rely on the fund for benefits, our concerns are essentially, as one of my colleagues said, that this bill is essentially using ibuprofen to treat a broken leg, in that without correcting some of the underlying systemic issues with the uninsured employers fund that have led us to this situation, that increasing the assessments against employers, insurers, and municipalities in the state does nothing other than just inevitably delay what may be a further financial issue in the future. We are certainly not opposed to coming up with some sort of compromise, but it would be our position that it must be more than simply changing the the percentage amount on the assessment, and there must be a more comprehensive approach to reforms at the Uninsured Employers Fund. For those reasons, we do urge an unfavorable report on this bill.
Good afternoon, Mr. Chair, members of the committee. Michael Daly for the Maryland Defense Council. And I certainly adopt what Ms. Murray has testified to. The other potential concern that we have, in the Maryland Defense Council, we are defense attorneys. We're the largest civil defense organization within the state, and our members represent insureds, self-insured employers on workers' compensation, as well as other defense matters throughout the state. The primary concern is the way that this bill is structured now. It gives internal control over that determination within the UEF as it exists right now to determine if they need to increase it. So that's a concern, because is this a Band-Aid fixing a problem for the short term? And how is the long-term problem fixed? And unfortunately, that's our primary area of concern with this bill. Our clients expected, as Madam Chair said, the good actors who have the insurance, they're paying this. They're self-insured employers are paying these assessments on each award of indemnity compensation. And yet they have little say, if any, or control over decision-making in terms of their money, in terms of what this agency is doing or not doing correctly. So those really are our focus concern areas. And for those reasons, we respectfully request an unfavorable report.
Thank you. Are there any questions for this panel? Senator Reedy.
Thank you. Maybe to Julie, you talked about the systemic problems. What in your view are those? I mean, maybe not a 20-minute answer, but I mean,
I won't. I know that there was a work group that spent a great deal of time studying this, and I believe that report was quite comprehensive. And I would defer to the recommendations and the evaluations that were contained therein. But the fund, obviously, we support the bill that is designed to change the makeup of their board. I think that's a large step in the right direction. And then also addressing perhaps some of the issues related to their ability to go after collecting fines. Some of the things that Mr. Burns spoke to are other issues we'd like to see addressed. In essence, we're not thrilled that the result is always we just need more money, whether it be from the subsequent injury fund or from increasing on assessments against employers and insurers. It seems as though there are perhaps some other solutions that should be explored in tandem with that.
So with the makeup, how do you think changing or adding to the makeup of the board specific? Because I've heard from a lot of folks on this bill on both sides, or at least a few folks. And how would the board, in your view, because you mentioned that specific, what's missing and what would altering the makeup fix?
That bill is coming up.
Oh, that's right. This is the next bill.
I don't want to steal anybody's thunder.
We'll talk later. That's fine. I'll wait for the next. I apologize. I'll wait for the next bill. That's fine. I'm trying to process it all. You know, it's a complicated issue, and we're trying to get it. I know we're trying to get it right. I'm very concerned about the push, as you said, for just always more money. I also understand that this is a benefit thing that costs money, so we got to figure it out. But thank you.
Correct. No. We are certainly sympathetic to that as well.
Thank you, Senator. We have one more witness, Nancy Egan, virtually unfavorable.
Good afternoon, and I hope you can hear me. I'm Nancy Egan from the American Property Casualty Insurance Association, and our members write 90% of the workman's comp insurance in the private market. Chesapeake is one of our members, and they understand that as a whole, we are opposing the bill. I won't go over, I echo the remarks that have already been made by my colleagues in opposition. One of the other things that we had concerns with is the third-party administrator of the UEF. I know that's a big cost on their agenda, but we agree that making the passing the Senate Bill 695, which gives more qualified people oversight, should also be considered as something to go favorable. And with that, we echo the opposition to the current makeup because of its additional charges against insurers. Thank you.
Thank you, Ms. Egan. Do I have any questions for this witness? Seeing no questions, that ends the hearing on Senate Bill 219. Thank you all for your testimony. Next, we're going to Senate Bill 227, Workmen's Compensation Payment from Uninsured Employers Fund revisions, and we have Michael Burns.
Thank you, Madam Chair, Vice Chair. Michael Burns, once again, on behalf of the Uninsured Employers Fund. This is also a more administration bill. This will be a little controversial, but only on the amendments. This bill is a result of the agency working with the Maryland Association for Justice. They had a bill last year to overturn a Supreme Court of Maryland case called Danner that was a strange case. It sort of indicated that the Uninsured Employers Fund did not have to pay injured workers while their case was on appeal, which was sort of unique in the judicial system. It had a convoluted history last year. We felt the appropriate thing to do was to work with that organization, and we did so, and we came up with this bill. And this bill, first and foremost, does overturn the Danner case. The agency is happy to pay injured workers while their appeal is going on. There will apparently be an amendment to have the following be the case, though, which is if the injured worker's case is appealed, and I will tell you, we do not willy-nilly appeal cases. We don't do it to save money. We don't do it to stick it to people. We appeal cases when the attorney generals feel we have a legal basis to do it, all right? Under this amendment, I believe, as it's going to be proposed, is if we do an appeal and the UEF prevails on the appeal, the worker gets to keep the money. Now, I was an administrative law judge, and I did a number of cases for both state agencies and federal agencies where if someone gets funding from the state or the government that turns out to be improper or not legally theirs, they have to pay that back. And that amendment would, on the other hand, say that no, they don't have to pay it back. So I would certainly urge you, if that's the amendment, to not support it. It just is not the way the system works. It works that way in temporary cash assistance for the feds. It works that way food supplement, which used to be known as food stamps. It's just the way the system works, that if you get money by mistake from the government, you pay it back, or because there's a legal determination it was not appropriate to do. The bill does some other things. It streamlines the cases of these workers so they get paid faster and easier. They will get their money quicker under this bill, which is another real benefit to it as well. It's a really good bill, and frankly, the current statute, which is 91002, is a mess. It's how we pay. It's not followed by the system because it just doesn't work. So before I got there, it was not being followed by the parties involved. It needs to be overhauled. We've worked with the Justice Organization to do that. This is a really good bill. This will help injured workers. They'll get paid quicker and easier. And so I strongly urge a favorable report, and thank you.
Mr. Burns, I don't see any questions. Thank you for your testimony.
Sure. Thank you, Madam Chair. See you again soon.
Yes, you will. We have two unfavorables, James Lanier and Matt Pavola.
Good afternoon, Madam Chair. Well, Mr. Vice Chair stepped out and members of the Senate Finance Committee. My name is Jim Lanier, and I'm here representing the Maryland Association for Justice. So unfortunately, MAJ has to come and oppose the bill as drafted for two very specific reasons. Mr. Burns is correct. MAJ and the UEF worked together over the summer to try to come up with this bill, and 90% of it is acceptable, is fine, solves many problems. But there's two problems that are significant enough to cause us to have to actually oppose it. One of them is that the UEF, and we do have a proposed amendment to address these two issues. We've presented it to the UEF. As Mr. Burns kind of indicated, they have not been receptive. The first one has to do with the penalties issue. As of right now, if there is no good cause and the UEF fails to pay an order in a timely fashion, they are not subject to any sort of oversight or potential penalty that the commission is allowed to assess on everyone else who fails to pay without good cause shown within a certain period of time. All we are asking with the first part of the amendment is that the UEF come under the same regulatory or statutory requirement to answer to the commission as all other stakeholders are required to do. So that's the first issue. The second issue is not exactly as Mr. Burns presented it. It has to do with subsection M, which when there is a double payment, like the uninsured employer makes a payment to the injured worker and the UEF also made a payment. The UEF wants the injured worker to write a check back to the UEF for the overpayment. No one gets money back from the injured worker. I'm sorry, very quick. If it's fraud, there's already a section for that. This is something that doesn't exist in the compact for anybody, and we cannot allow anybody to take money back from the injured worker when the UEF can always go get it from the uninsured employer, who are the people who actually broke the law.
Mr. Lanier, we don't see any request for amendment in writing, so if you have an amendment, will you please offer that up to us?
Yes, ma'am. I brought it with me today. I couldn't figure out how to upload it, so that's
okay.
my mistake.
That's fine. Thank you very much.
Yes, ma'am.
Do I have any questions for Mr. Lanier? No? No questions? Thank you very much for your testimony. That ends the hearing on Senate Bill 227.
227, that was a good show. I like that show. 227, you remember that? 227. Next, we're going to hear Senate Bill 306, Workers' Compensation, Prescription Drug and Pharmaceutical Services Reimbursements. And we're going to have Senator Beidel, Madam Chair, with her panel, Carmine D'Alessandro, Robert Enton, Carrington Anderson, and Bill George.
Dr. No.
All right. Madam Chair, you may begin whenever you are ready.
Let me get organized. Thank you, Mr. Vice Chair and members of the committee. Okay, thank you. Thank you, Mr. Vice Chair and members of the committee. This Senate Bill 306 is about insurance companies and self-insured counties, that's many of your counties, paying their fair and appropriate reimbursement for workman's compensation prescription drugs. You know, now if you have health insurance, you have probably a card that you go to the drugstore and you pick up your prescription and you pay your known copay and they know what to charge your insurance company. It's not like that with workman's comp. Workman's comp has no fee schedule, and we sort of think it's like the Wild Wild West. Whatever a pharmacy wants to charge, or whatever particular mail-in pharmacy wants to charge, they charge. And I'm going to go through some samples with you in the PowerPoint that you have in front of you. You may hear testimony that the bill requires that the Workman's Comp Commission use the NADAC price. I'm going to tell you about that in a minute. This bill does not decide on the schedule to be used. It mandates that the Workman's Comp Commission decide on a fee schedule. There are many choices. They could do AWP plus a percentage, AWP minus a percentage. They could use AAC, MCCP, FUL, SAAC, EAC, or usual and customary. And if you want to know what all those letters mean, I can tell you. I've been eating and sleeping this bill for about 6 months. The fee schedule will be decided by the Workman's Comp Commission, not this body. And for the reason is it gives them the flexibility. If a different pricing method arrives, they can change, but they do need to come up with a fee schedule. This PowerPoint's going to include a lot of details about the payment for prescriptions compared to the NADAC. NADAC is the National Average Drug Cost, and the AWP price, which is the average wholesale price. The pharmacy submitted prices, the actual cost of the fills paid the insurance company or county. So the pharmacy submits prices, and you're going to see what's submitted in the PowerPoint. Our major counties that are self-insured are paying 4 to 5 times the actual cost. We know this is true of Baltimore City, Prince George's County, and Anne Arundel County. We have not yet gotten the numbers from Montgomery County, which Senator Kramer is going to help me with, or Baltimore County, which I think our prior vice chair could be a little help with. Our employers are not self-insured, are paying for these high-priced prescriptions, and this causes the cost of workman's compensation to increase. It's particularly painful for our small businesses. I know the print's small on what I'm going to show you, but you have it in front of you. I'm going to go through the slides quickly because it's a long day, but I do want to mention an easy way to compare the average cost to fill a prescription. So this is a little chart that came later. I figured out this weekend, so it's not in your PowerPoint. Chesapeake Employers, which is the largest workman's comp insurer in the state, along with IWIF, pays an average of $111.16 per prescription. Baltimore City's paying $217.72 a prescription. They're actually doing a good job. They're fighting a lot of these fees that they're charged. Anne Arundel County's paying an average of $298.07 per prescription. And Prince George's County, and I'm sorry our representative from Prince George's is not here, Prince George's County's paying an average of $465.64 per prescription. So that's what we're trying to get to some reasonable, dependable price. So your first slide, turn your cover page back, and it's on the back of the page. This is Chesapeake Employers Insurance Company and the Injured Workers Insurance Fund, and this is their data for the paid fills in 23 and 24. So you can see the cost of their fills. For instance, the first line state they paid $2,268,944. This AWP prices, which you're going to hear that some companies actually want. Did I miss it? Tammy, I got something in the way here, and I can't get it out of the way. Let me see if I can. Okay, I moved it. Let me go back a minute. Okay. You can see that the AWP price was over $5 million, and the acquisition price, which is the NADAC, was over $1 million. So $1,341,000 is NADAC, and they paid $2.2 million. And then the same thing with Chesapeake Employers. The AWP price is $5.2 million, and the acquisition price is $1.6 million, and they paid $1.8 million. So on 37,000 prescriptions, these two major companies paid $2,153,225, but the AWP price would have been over $10 million. This is important because you're going to hear later that some of these prescription companies want us to use the AWP price. It's not our decision, but that's what they would like to see. The next screen is Chesapeake Insurance Company and Injured Workers Insurance Fund for paid fills for mail order pharmacies. And you're going to see the same kind of differences. The acquisition pricing versus the cost that's paid versus the AWP price, and then what they actually submitted. So they're even submitting more than the highest price of AWP. In the case of the first line, the state, the pharmacy submitted $1,582,474. They actually paid $659,842. So they were charging almost 3 times. So I'm not going to read you all the numbers. You're all very able to read, but you can see the differences here and what we need to be addressing. This next chart is the small counties and what they're paying versus AWP versus what's submitted and what's actually paid. So you have first column is AWP, the next column is NADAC, and if a drug isn't available on NADAC, it's then on WAC. What the pharmacy submits and what's paid. Let me see if I can find a county. I don't have any counties. I don't think any of you in this room are representing these counties. Dorchester County, Senator Mounts. They were billed. They were submitted $21,403. The AWP would have been $19,000. The acquisition pricing was just $1,280, and they paid $4,430. Now, you're a small county with not a lot of claims, but the point is they submitted a bill for 5 times what was paid. So we can look at each of those as it applies to your counties. This is the Baltimore City data for 2023. Baltimore City has been doing what Chesapeake does and trying to pay what's a fair price, not necessarily what's submitted. So you can see, though, that the pharmacy submitted over $5 million. AWP was $7 million, but in this case, they were billed $4 million because they're trying to get this under control. The Prince George's County data for 2023, acquisition pricing was a little over $2.5 million, but $10 million was paid. $11 million was billed. So pharmaceutical is about half of what Workman's Comp spends for care of our folks that have been injured. This bill does not in any way limit what an injured worker will receive. All it does is going to set a known pricing schedule that the Workman's Comp Commission is going to set. This is our Anne Arundel County data, and it's the same thing. The fee schedule, the retail price was $1.9 million, but they total paid $788 retail. So the program savings was over $1 million. To any county in this economy, $1 million savings is a lot of money. This next slide is the top 15 out-of-network mail-order pharmacies on very common drugs. So just go down the line and you'll see oxycodone, out-of-network charges $91.65. The average pay is $40. NADAC's only $25.90, and the average AWP is $54. So it's just a huge difference. Go down to, I can't say the sildenafil, 100 milligrams. The out-of-network is $1,656,000. The amount average paid is $490. The average NADAC price is $20.21, and the average AWP is $1,003,000. So the pharmacies are charging more than any of the other price values that we have. This is a very common drug for blood pressure, which we've heard a lot today about our firefighters and that they suffer from high blood pressure. This is valsartan, and this is what Optum paid versus what's billed. Again, huge differences. And then here's another prescription from Baltimore City that's two common prescriptions. And again, you can see the difference in Cost Plus is Mark Cuban. MCCP is the Mark Cuban Cost Plus, $72.30. And in some cases, it's being billed $1,401. The AWP is $1,146. So I hope you're seeing the differences in what's billed, what the actual costs are. This is high blood pressure medicine for heart disease. The amount billed, if we add these all up for a 90-day supply, go down February, August, October, March, June, and November, it would have been $1,525 for a 90-day supply. You could have walked into the pharmacy and gotten it for somewhere between $72 and $204 without insurance. That's how much counties and companies are being overcharged. And then this is another high blood pressure medicine, same thing. If you total the months of these renewals, $1,997, you could have walked into the pharmacy and paid somewhere between $132 and $324 if you were paying cash. So the differences are just significant. This is for erectile dysfunction, because usually with high blood pressure medication, Workman's Comp also pays for this erectile dysfunction medicine. The amount billed in column 1 for multiple prescriptions $5,598. You could walk in off the street for somewhere between $49 and $147. It's just outright abuse. So that's the bill we're talking about today. I hope that you'll give it consideration. I do want to mention we've worked, Council and I, Nathan, have worked with a couple of amendments. You're going to see an amendment that would allow a county or a company to actually work with a network and have a network. And so that would give them some certainty in what they pay. And then there are doctors that are prescribing some very different topicals. They're not anywhere on a schedule. And so the Maryland Prescription Drug Authority bill has agreed to do a study so we can come back with some kind of a schedule for those at another year. But it's just a study, and Dr. York has agreed to do that. So that's the bill with amendments. I hope I can count on your support. And if you don't have any questions of me, turn it over to my panel, and I'll be here. Thank you.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. For the record, Carmine D'Alessandro, Chief Legal Officer for Chesapeake Employers Insurance Company. Chesapeake insures about 20% of the private market. We have about 20,000 policyholders. Also here representing the Injured Workers Insurance Fund, the agency that is the third-party administrator for Maryland's workers' compensation program. And again, I was president. Ms. Menninger is here. I'm here to support Senate Bill 306. For those of you who may recall, we tried this about 10 years ago in the House to establish a fee guide. It failed for two reasons. One, the bill called for the legislature to establish the fee guide, and two, the bill was based on average wholesale price. This bill rectifies those two issues. It directs the Workers' Compensation Commission to come up with a fee guide, and it removes average wholesale price, or AWP, from the equation and mandates the use of some actual acquisition cost index. Briefly, and I'm not an expert on this, but AWP, average wholesale price, is in essence a sticker price that has no basis in fact, that a manufacturer just slaps on the prescription, says, try charging this. And what pharmacies do, they'll not just charge that, they'll charge 20 or 30% more than that. So imagine going into a car dealership, looking at a car you like, seeing the sticker price, and then offering to pay 20% more than that sticker price. I can assure you no one has ever done something like that. Actual acquisition cost is based on actual consumer transactions. What are the drugs being acquired for? They're based on actual transactions, unlike AWP. So how does that play out? Chair Bidle explained some of the numbers. For Chesapeake in the last 2 years, we were billed $10.4 million for 38,000 prescriptions. We were billed. That's AWP plus 20%. We only paid $3 million. You'll hear even worse numbers from MACO. Briefly, Chesapeake's legislative mandate, if you go to our statute, we are here to support the entire workers' compensation community. We have the resources to make sure the fair price is paid. This bill actually supports the rest of the industry, the 80% we don't insure, because they don't have the resources to combat this problem. And I'll be free for questions when the panel is completed. Thank you. God, 2 minutes is fast.
Mr. Chairman, members of the committee, Robert Enton on behalf of the American Property Casualty Insurers Association. Our members, including Chesapeake IWIF, strongly support this legislation. I will call your attention to the fiscal note. And what the fiscal note makes very clear, if you go to page 3, it says that at the county level and at the state level, we will have significant savings. It estimates that for the Chesapeake estimates if this model had been in place for the fiscal 2023 through 24, state expenditures for workers' comp costs would have decreased by approximately $625,000. Using the same pricing guide assumptions, Chesapeake estimates that Prince George's County alone expenditures would have decreased by several $million. I want to point out and emphasize that this bill doesn't say what the cost, the price that will be paid. What this bill does is it says that the Workers' Compensation Commission shall regulate fees and other charges for the reimbursement of prescription drugs and pharmaceutical services. That's our regulator for this industry. And secondly, it says that the reimbursement shall be limited to an index or indexes based on acquisition cost calculated on a per unit basis as of the date of dispensing, and this is key, and may include reasonable dispensing fees. Now, I just don't know what's wrong with that and why that isn't a good idea. Let's leave it up to the regulator to make sure that your counties and the state of Maryland aren't overpaying for the prescription drugs through the Workers' Compensation Commission. Thank you.
Thank you, Mr. Vice Chair, members of the committee. My name is Carrington Anderson with the Maryland Association of Counties, speaking in support of Senate Bill 306. First, I want to thank Chair Beidel for bringing this bill and for recognizing the need. Senate Bill 306 is an essential reform to workers' comp. It establishes a clear and sustainable fee guide based on acquisition costs for the reimbursement for prescription drugs. No fee guide, which is what we currently have, results in excessive and inconsistent pricing. For example, Prince George's in 2023 through 2024, they paid $10.2 million for prescription drugs. On the market, that cost was $2.5 million. The difference between those two numbers is what Prince George's was overcharged for prescription drugs. One more time, they paid $10.2 million. The average cost was $2.5 million. Prince George's is not the outlier here. This is the universe with no fee guide. Workers' comp is a significant cost driver for local governments, and no regulations result in inflated costs. This money could be spent on other programming, employees, and just critical programs and services. This bill levels the playing field, and it addresses excessive markups, which drive up costs for local governments, the state, businesses, and ultimately taxpayers. So for these reasons, MACo would suggest a favorable report on Senate Bill 306. Thank you.
Good afternoon. Bill Jorsch with the Maryland Municipal League here today in support of Senate Bill 306. Thank you, Chair Beidel, for bringing this. You've heard a lot about the bill, so I won't touch on that too much, but MML and our 161 members are fully on board with the provisions of the bill and the cost savings that will come along with it. Just a little bit of context from the local government perspective. One thing that sets our entities apart as employers is that we oftentimes offer significantly higher benefit packages as part of the total compensation. So for those employees whose claims are denied, they still have access to care through employer-sponsored health care when they're employed by local governments at a heavily subsidized cost. So in case that comes up, that is one of the parts that just want to make sure that that's part of the context of this discussion. Thank you. Ask for a favorable report.
Absolutely. Thank you. Are there any questions, Senator Guy?
Thank you, Mr. Vice Chair. I'm not sure who's best to answer this question, but I don't know, Carmine or whoever. Are injured workers aware of these costs when they go to pick up their prescriptions?
I would say no. Injured workers pay nothing for their prescriptions. So even if there's a dispute going on between, say, Chesapeake and one of the pharmacies over what to pay, that's being resolved in the background. An injured worker never pays for any medical treatment or prescriptions in the workers' compensation system. So I would be very surprised if they knew any of the numbers that were being. In fact, some of this is mail order. So they're just getting the prescriptions in the mail. They're not even going to pharmacies and seeing any cost. So I would say no.
And they can get their prescriptions anyway. Is there a problem with injured workers not being able to get their medication?
I'm not aware of any, and we have about 7,000 hearings a year at the commission, and we are not seeing an influx in. I can continue.
Yeah. No, there shouldn't have been a timer.
Someone else doesn't want me speaking.
This is what happens.
I am not aware of any issues with significant issues with injured workers being able to get their prescriptions. The issue here is a matter of cost between the payers and the pharmacies.
Okay. And it's Carrington, looks like you wanted to chime in.
If I may, I was just going to echo that on behalf of the counties. We're not hearing that. And again, kind of what my colleague said, counties and local governments, we have great benefits. And so if these weren't being paid for through workers' comp, they're being paid for by the benefit package that the county offers.
Okay, and maybe Carrington, if you're still on. And who's paying for these costs? Like, how are these costs borne? Is it on the carriers? Is it on Maryland businesses? If you know, or whoever, maybe Karma may. So
the costs are passed through to our policyholders, or if it's the state of Maryland, taxpayers. So anytime you have a workers' compensation claim, as the cost of that workers' compensation claim increases, it has a downstream effect on our policyholder, meaning their premiums are going to start going up because of all the money they're paying. As for IWIF, as you saw, IWIF paid several $1 million in prescriptions. That's taxpayer dollars.
And just one more question, Mr. Vice Chair. And Carmine, is this isn't just a bill to benefit Chesapeake and IWIF, right? Like, can you maybe elucidate a little bit?
Oh, that's a really good question. So I would say no. I would say of all the stakeholders that could benefit from this bill, we'd be the bottom of the list. And I say that because for years we have taken the position that we're not going to pass these costs down to our policyholders. So as you saw, Senator Guile, of the $10 million that we were billed, we only paid $4 million. We're not going to pay that. Prince George's County, who we don't insure, actually in those same 2 years, for 15,000 less prescriptions, paid almost 3 times what we paid. They would benefit. Mr. Enton's clients would benefit. So my competitors are going to benefit a lot more than Chesapeake.
Okay, thank you. Thank you, Mr. Vice Chair.
Senator Kramer.
Thank you, Mr. Chair. So I'm always a little bit concerned when I see Dr. No Enton sitting at a table supporting a bill. But I would like to ask if either Mr. Enton or perhaps Carmine could opine before the unfavorables come up as to your understanding of why they're opposed and how you would reply to that. Well,
I'll let Mr. Yes answer that.
Okay.
Senator Kramer, I think, and I'm basing this off, we did attempt this at the Workers' Compensation Commission, so I heard some of the reasons that there would be opposition. I think one of the things you're going to hear is that many states use an AWP index, and that Maryland would be one of the first states to move off of that to the AAC index, which is true. The AWP index was started in the 70s and 80s. By the 90s and early 2000s, it was clear from the literature it was kind of archaic. California has moved to what they call Medi-Cal, which is AAC. Massachusetts, and what's significant, Senator Kramer's 40 to 42 states in their Medicaid system have moved off of AWP to an actual acquisition cost, and Maryland is one of those states. So in terms of this debate, Maryland in another venue has already decided that AAC is better. So for example, what you could have right now are people on this side of the room receiving their medication in the Medicaid system, paying $10 a script. People on this side of the room, for the same exact medication, same condition, receiving their medication through the workers' compensation system, paying 1,000 times that. So this actually brings the workers' compensation system in line with Maryland's Medicaid system. I think that's something you may hear.
Okay, thank you for that. Thank you, Mr. Chair.
Thank you, Senator. Senator Jackson.
Thank you, Mr. Vice Chair. How did this pricing issue happen in Maryland? Anyone?
How did it happen? Well, I think different states have different types of fee guides and different systems, Senator Jackson. So the joke is when you've seen one workers' compensation system, you've seen one workers' compensation system. So some states allow the employers and insurers to direct care, meaning they can cost contain by sending injured workers to certain doctors and pharmacies. Maryland does not do that. Some states mandate that if you want your drugs reimbursed, you have to be in the insurer's network. Maryland does not do that. Some states do not allow the physician dispensing that Chair Bidle talked about. Maryland does not do that. So what's happened in Maryland is there are no counterbalancing guardrails on this issue. So it's just been, as Senator Bidle said, the Wild, Wild West. Mm-hmm. And Chesapeake, obviously, as I said, our legislative mission is to basically support the community. But I get it, the counties, when they're hiring people, when we're hiring people, we have 20 nurses on staff. We have a pharmacist on staff that looks at this every day. The counties are hiring police officers and teachers and trash collectors and firefighters. So this workers' comp becomes a very small issue on their radar screen. I think that's how it's kind of gotten out of control.
And is there a problem with injured workers not being able to get their medication?
Not that I'm aware of, and I think Ms. Anderson said the same thing. So.
Okay. All right. Thank you, Mr. Chair.
Senator Ellis.
Thank you, Mr. Chair, and thank you, Senator Bidle, for this educational experience. I have a question. It's more, well, two questions. One is very parochial. You mentioned all the counties that we care about, except the one I care about the most, Charles County. Do you have any idea if Charles is self-insured or how that's worked in Charles County? Or
I don't have Charles County.
Charles County is self-insured.
Self-insured.
We've reached out, and I know Ms. Anderson has done a phenomenal job reaching out to all the counties. Unfortunately, as I was explaining to Senator Jackson, because it's not exactly an issue on their radar, it's been difficult to get some of that information, but we are continuing to try, and Charles County is on the list to try to get the data.
You put it on my radar now, so
Okay.
it's on. So being self-insured, they are probably in the class where they pay more, like Prince George's? Is that a reasonable
I would say
guess?
they would be in that class, and I think one of the reasons the big counties are paying so much is, and if page 2 of my written testimony, you'll see a bunch of prescriptions, cholesterol, hypertension, erectile dysfunction, as Chair Bidle mentioned. Those are hypertensive medications, and they are long-lasting medications. When you're on those medications, you continue to be on medications.
Yeah.
So what do those larger counties have abundance of? Firefighters and police with their workers' compensation hypertension presumptions. So they file for their presumption, and then they get on the medication. That medication goes for years and years and years, and that's why you see the larger counties paying those amounts, as opposed to, say, a Talbot County that has more of a volunteer force that isn't paying as much. So I think that's one of the driving factors in those counties.
Okay, thanks. So I'm looking at the testimony here, and under your name it's just oral. You have that written anywhere?
It should be Chesapeake.
Chesapeake, under someone else's name submitted?
I think it's my name and Miss Menninger.
Manager. Yes, I see manager. Okay, so I'll read that later.
Thank you
so much. Appreciate that. And also, Chair Bidle, you mentioned the difference in, say, stark difference between, say, Prince George's, how much they pay or overpay, and Anne Arundel seem like they're paying much less. So why the difference between the, is it something they choose to do, or is it something in state law that allow Anne Arundel to pay less, or what do you account for the difference in, say, the two extreme cases?
It's not about being allowed less. It's about some counties like Baltimore City are fighting back, like Chesapeake Employers is fighting back, and they're saying, we're not going to pay that. This is what we'll pay. But some counties don't have the resources to investigate what an actual acquisition cost is, and they don't have the resources for people to fight back and lower the cost that they're paying.
Yeah. So okay.
It'll be interesting to see Charles County to see what they're doing.
Yeah, I'll definitely follow up.
We're happy to work with you on getting that. And again, just want to say, too, that Prince George's is not the outlier here. This is happening across the board.
So not with all the counties, though. Some are fighting back, some are not.
Right, but I would say that all counties are likely being overcharged. It's going to look different on whether, of course, a more rural county, that's going to be less so in comparison to one of the larger counties.
And Senator Ellis, I should say that 9 counties are actually insured with Chesapeake. So many of the counties on the shore are insured with Chesapeake, and it's in your packet, you'll see Chesapeake's counties, and there's been about between a 30 and 50% reduction in what we'll pay, but they're insured with us, so we're watching over them as opposed to some of the other. Yeah.
So you're the one, your agency, fighting back.
Correct.
But others maybe, it's hard to imagine, and I'm just asking the questions. And sorry, Madam Chairman, violating your rule. One question, one witness. I apologize. But when you say a county don't have the resources to fight back, say a county, I won't pick a name, but a county that's not fighting back, that's a larger county, you would think they have the resources to fight back. So why is that not happening as far as doing what your agency is
Can I
doing?
start? Yeah, absolutely. And I'll turn it over to you because you're the expert. But for one, I think counties are paying what they're charged. They don't necessarily have a pharmacist on staff to be looking into the weeds on all of these numbers.
But if you can pay a pharmacist $225,000 a year to save $8 million, wouldn't that be a good investment? I mean,
I see your point. I'm not sure that counties before this year were aware of how significant these differences were, but.
I think we reached out to Ms. Anderson, and one of the reasons we're having difficulty getting the data is we were the ones that sort of elevated this issue to the counties. They weren't aware. The other issue is when pharmacies feel they should be allowed more in billing, they can file issues with the commission and litigate. So Chesapeake has litigated well over 500, and we will continue to litigate. Counties are not going to have the resources to keep sending attorneys to litigate those cases.
And one last question.
Can I make one comment, Senator?
No, 1 second. One last question. I don't want to get my colleagues upset at me too long. So one last question that'll help my understand this. So what will this bill do with the situation you lay out? What will this bill do?
Let me say this, Senator. Yeah. What this bill will do is have an impartial, knowledgeable regulator that will set, the fees. And I think that's part of the problem, is that, this county's doing this county's doing that, this one's up here, this one's there. But what you need is the expertise and the impartiality of the state regulator of the workman's compensation system to do this. That's what the bill does.
Okay, thank you for that. Thank you, Madam Chair.
Thank you. Mr. Vice Chair, can I add one thing?
Yes, ma'am.
43 states have already done this, so we are really behind in getting this done, so we're not alone. Thank you.
Are there any additional questions of this panel? Seeing none, thank you so very much. We appreciate your testimony. Next, we will hear, let's just keep on with the favorables right now. Julie Mary, Ashley Smith, and Michael Daly. Welcome, and you guys may start whenever you're ready.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. Michael Daly for the Maryland Defense Council. I'm happy to support Senate Bill 306 for the reasons my colleagues just testified to, very detailed at length. I think one of the things that we need to keep in mind with bills like this is that this is not something new to our commission. We already have a medical fee schedule. So, for example, if I get injured on the job and I break my arm and my colleague Ashley has that same work-related injury and we go to that same or different doctors, it's going to be the same price for what the treatment is that we get to treat that arm. Why should there be a difference with our prescription medication? This has nothing to do, nor does it impair or impede access to care. The injured worker can go to any pharmacy. They can go to CVS, wherever they go to get their prescriptions filled. that's where they get their prescription filled. Nothing will change. I point that out because you may hear that thrown around by those that aren't supporting this bill. The important thing about this is this bill does something that is logical and fair, and it's part of what we refer to in workers' comp as the grand bargain. It's the compromise between not fighting injured workers, get them benefits that they're entitled to get, don't say that they're at fault for their injuries of any kind. In turn, the employers' insurers have an opportunity for some reasonable cost containment. That's what this is aimed at. This says that wasteful spending should not be allowed, and that it empowers our Workers' Comp Commission to put together a reasonable based fee schedule, which is already done for medical fees. This just pertains to the prescriptions. Employers, insurers, and the counties already pay assessments to the commission. They shouldn't have to pay additional assessments in the form of these excessive pharmacy pricing. This is an important and fair bill, and for those reasons, we ask for a favorable report. Thank you.
Thank you, sir. My name is Ashley Smith. I'm here on behalf of the Maryland Defense Council. I'd like to point out, in my capacity as a private citizen, I am the only attorney for an insurance company located in the state of Maryland. And one of our biggest clients is a municipality in Western Maryland that is in a more economically depressed area of the state. That client of ours is self-insured. Almost all claims are paid directly out of their own coffers up until the amount of the bills becomes too high, and then the insurance kicks in. I can tell you that a bill like this would have a real and dramatic savings for my client in Western Maryland as a municipality for what they spend, especially on their police and firefighter claims, and would really go a long ways in helping those smaller communities. I know we heard about the big numbers involving Prince George's counties and some of the other counties, but the fiscal impact and the savings that we could deliver to benefit our local municipalities would really be beneficial for those states and municipalities. I also just want to point out the average wholesale price. I'm going to give a very brief example of what we're talking about. Let's say you go to Giant and you want to buy a carton of eggs and it's $10. You go to Trader Joe's and it's $12. And then there's some guy on the internet who's got a website that says, no, the carton of eggs should cost $50. Well, you would think, reasonable minds sitting here at this committee, that the price would be somewhere between $10 and $12, because that's what we're seeing in the actual marketplace. What AWP is, and what these pharmacies that really take advantage of the system is, they say, okay, random guy on the internet says $50. So we're going to mark that up by 20% and we're going to send you a bill for $60. And we're going to use this random number on the internet that really has no basis in reality. And we're going to use that as justification for billing you 5 times higher than it should be. So for that reason, we're favorable, and we would request a favorable report.
Julie Murray, also on behalf of the Maryland Defense Council. I think everyone in front of me has spoken very eloquently on the bill. The only thing that I had left to point out was simply that we did poll the members of our organization with regard to the access to care issue, and we did learn that we do not have many members that have faced an issue where they are not able to obtain prescriptions, and we don't anticipate that being an issue. With this bill, most of the litigation involving prescriptions pertains to either, one, the pricing of the prescriptions, which does not involve the injured worker at all usually, or substantive litigation about whether the prescription is actually necessary, which again is not an access to care issue. Other than that, I would simply adopt the arguments by my colleagues and the panel before me and urge a favorable report. Thank you.
Thank you. Are there any questions for this panel? Seeing none, thank you so very much. Now we're going to go to favorable with amendments. We have Dana Kaufman, Jane Kresak, and Josh White. And you all may proceed whenever ready.
Good afternoon. For the record, my name is Dana Kaufman, and I'm testifying on behalf of MedChi, the state's medical society. In workers' compensation, there are physicians who do treat injured workers, but also dispense medications directly to those injured workers. This makes up a very small percentage of claims compared to those claims that are submitted by pharmacies. As one of the amendments, we want to thank Chair Beidel in working with MedChi. One of the amendments does limit this bill to pharmacies and recognizes the difference between pharmacies and dispensing physicians. We do support the study and commit to working with the PDAB on the data collection and coming back if any changes need to be made. But we do support the bill with the amendments offered by Chair Beidel, and we thank her for working with us. Thank you very much.
Chairman Beidel, Vice Chair Hayes, and members of the committee, my name is Josh White on behalf of Injured Workers Pharmacy. We speak in favor of a fee schedule. However, we have a great deal of concern about limiting to acquisition cost. If you have a business and you can only charge what materials, you would not survive. And we believe that pharmacies are really no different. And medication is just one part of the costs of doing workers' compensation. Right now, insurance companies can adjust pricing on covering administrative costs, but pharmacies would not be allowed to do the same under this bill. No business can survive by selling something for less than the cost to provide it. We wouldn't expect a contractor to charge only materials and eat the cost of labor, so why are we asking pharmacies to do the same under acquisition cost? That's why 35 of 37 states that have fee schedules use the AWP as a benchmark, because AWP controls the cost while allowing folks to have access to their medicines. And this bill tries to mirror what the federal reimbursement, but even the federal government uses AWP for workers' comp, and that's because workers' comp is different than health insurance. Maryland doesn't have to reinvent the wheel on this. We can actually do what other states are doing and save costs. We also agree that there should be a study on this. We think that there should be a study of the entire system, and that study should come back, and that should be done by the Workers' Compensation Committee. They have a fee guide committee that actually does exactly this. And they can come back and decide what is actually best for the workers, the state, the county, and the pharmacies.
Good afternoon, Chairwoman Beidel, Vice Chair Hayes, and members of the Senate Finance Committee. My name is Jane Kresich, and I'm here today also on behalf of Injured Workers Pharmacy to provide testimony on Senate Bill 306. IWP is a specialized workers' compensation pharmacy that ensures injured workers receive their medications without delay, removing barriers to access while navigating the complexities of the workers' compensation claims. We support the intent of SB 306 to establish a fee schedule for pharmaceutical reimbursement in Maryland workers' compensation system. A well-structured fee schedule can provide predictability, cost control, and fairness in reimbursement for both payers and providers. However, as currently written, SB 306 limits the Work Comp Commission to a significantly limited pricing index without the flexibility to explore other methodologies that are widely used across the country. Maryland should take this opportunity to establish a fair and data-driven reimbursement model that accounts for best practices from other states. To achieve this, we propose an amendment to Senate Bill 306 that directs the Commission to use its existing Medical Fee Guide Committee to review and compare fee schedules from other states to determine the most cost-effective and balanced approach, assess the impact of various pricing methodologies on pharmacy reimbursement, patient access, and cost containment, and ensure that Maryland's reimbursement model is sustainable, fair, and competitive with national best practices. This amendment would ensure that Maryland develops a comprehensive and evidence-based reimbursement system that is fair to injured workers, pharmacies, and payers alike. Injured workers rely on timely access to their prescriptions to recover and return to work. If the reimbursement model is too restrictive or does not fairly compensate compensate dispensers, it could limit access, especially for specialty medications and pharmacies serving rural and underserved areas. By allowing the Fee Guide Committee to conduct a national review, Maryland can create a balanced, flexible, and sustainable system that works for everyone.
Are there any questions for this panel? Seeing none, thank you so much for your testimony. The next panel will be a panel of unfavorables. We have 6 chairs at the table, so I'm gonna call the first 6. And we have Darren Thomas, Dolores Sanchez, James Lanier, Matt Pavola, and George Goodwin. And also, is Stephen McCombs there? All right. I'm gonna call him again so we can check him out. Darren Thomas, Dolores Sanchez, James Lanier, Matt Pavola, George Goodwin, and Stephen McCombs. Okay. I have 2 more. Kenneth. I'm gonna butcher your last name. Everybody does. Thank you, Kenneth, for your grace. And Timothy Frazier. Excellent. You all may start in whichever order you prefer. Whoever's ready, you can go.
Doctor. Dear members of the Finance Committee, I'm Timothy Frazier. I'm an orthopedic surgeon and partner at Premier Orthopedics. After completing 9 years of active duty training in the Navy, I came to and I was attracted to Premier Orthopedics because it specialized in the care of the injured worker in the state of Maryland. Police officers, firefighters, other public servants, they reminded me of the people I treated in the Navy, sailors, Marines, soldiers. Once I began the work of caring for the injured worker in Maryland, I realized that a large portion of injured workers were also without commercial health insurance. So I definitely take pride in filling that gap. So this is why I oppose this bill as written, SB 306, because it would all but eliminate our ability as physicians to provide the pharmacy services to the injured workers that routinely fill this gap in treatment. Given that in some years, nearly half of workers' compensation claims are contested initially, many of my patients would go without their needed medications in the acute phase of their treatment when the medications are needed. There have been many instances in which my surgical patients, after operating, they show up at a pharmacy and get denied the medications at the pharmacy. Being that I'm able to dispense medications at my practice, I'm able to fill that gap for those patients. Without that, the burden of this would no doubt fall on commercial insurance and our taxpayers because some of these patients would go to the Medicaid program to get their medications. Physician dispensing directly to the patient has amazing benefits to the injured worker in the form of access and compliance. Physician dispensing ensures that 100% of the patients that I treat get the intended medications, where studies have shown that up to 40% of prescriptions that get sent to a pharmacy can go unfilled for whatever reason there may be. So I just ask that you guys help me to continue that process.
Good afternoon, Vice Chairman and Finance Committee. My name is Chief Steve McCombs. I'm a few months shy of 40 years as a life member of the Graceville Volunteer Fire Department in Queen Anne's County. I currently serve as the First Assistant Fire Chief and have been a Chief Officer of the department for almost 25 years now. At the end of 2025, I'm going to step down, mostly because I can't physically do this job anymore. The one thing I truly love. I've dedicated most of my life to the fire department since I was 14 years old. During this time, I've broken my back twice, I broke my legs in 6 places, fractured my ribs, and a hairline fracture of my neck. I've also had high blood pressure and quite a few burns in my time. I'm currently employed with the Caroline County Department of Emergency Services, where I serve as a shift lieutenant on D shift in the 911 center. I was also a PG County fireman for 17 years, an Ocean City fireman for 3 years. I worked for 3 departments during my career: Centerville Fire Department, the Denton Fire Department, and the Camp Rescue Squad in Sherrillstown, Maryland. I'm here today in support of companies like Rescue Meds. For the last 14+ years, I have been through hell with my back. All my injuries and the quality of life now is horrible. I unfortunately rely on medications just to get out of bed on a daily basis. And without these medications that Rescue Meds provide to me, I tend to wake up depressed, very upset at my current situation. When I use pharmacies like CVS, I sometimes wait longer periods of times for my medications that I get immediately with Rescue Meds. I have to pay for those medications as well. They help me, and I have had no issues getting these medications I need on a daily basis. The reimbursement rates being proposed are unreasonable, and with the use of an acquisition cost index, it will prevent access to critical health care for injured firemen and other public safety personnel. We risk a lot on a daily basis, and go through what we do is unfair to us. I'm not alone on this. Many other firemen and police officers are in the same situation. I'd also like to point out other important information. I have another option to get my prescriptions, and how without companies like Rescue Meds, things could have gotten a lot worse.
Thank you for your testimony.
Good afternoon. My name again is James Lanier on behalf of Maryland Association for Justice. Although I'm sitting here in opposition, actually, Mr. White and Ms. Kresak kind of stole my thunder, which is looking at it a little more of a 30,000-foot view. The Maryland Association for Justice's concern is that injured workers of Maryland are able to receive all the recommended, necessary, reasonable, and related medical care. If and when an access for medical care comes up, the commission has a medical fee committee that can meet, it has to meet at least every 2 years. As part of that committee, you have payers and you have receivers. And there's, as you heard Mr. D'Alessandro mention, there have been committee hearings at the commission about regulating prescriptions. The commission already has the power to do that if they so choose to do so, which is institute a medical fee guide for prescriptions. Our issue, and I think to answer Senator Ellis and I think Senator Jackson, why are these disparities? And there are times in which one of the worst calls we get as an attorney, and admittedly, it doesn't happen every day, is when you get the call from someone who's at a Walgreens because there's no pre-authorization for their prescriptions. They can't get them. Yes, they can go to any pharmacy they want to, but they can't get the prescription unless there's pre-authorization provided by the insurer. So what are we left to do? They either have to pay out of pocket, and they don't all work for the counties when they have good health insurance systems. We have to utilize internet pharmacies to allow the person, because the internet pharmacies will utilize they won't require pre-authorization to provide the prescriptions that people like Dr. Frazier are going to prescribe for these people. So they have a necessary role when we have an issue with pre-authorization specifically for prescription medications. So when there's a problem with prescriptions and there has to be a change, the commission and the medical fee guide committee has the experience and the ability to make these changes that would have to happen if an issue about payments come up again, just as they can with all medical care. So I'm in opposition, but we are certainly in favor of a medical fee guide for prescriptions. Thank you.
Okay. Chair Bidell, Vice Chair Haynes, and members of the Senate Committee, I'm Kenneth Wisniewski. I'm a 22-year retired Army combat veteran from the 82nd Airborne. I was an Army Ranger for 22 years. Nearly 19 years served with Prince George County as a police officer. During my time as a police officer, I sustained injuries that I can continue to receive medical care under the workman's compensation that include distribution of pharmaceuticals. The legislation regarding the reimbursement rates that is being proposed are unreasonable with the use of acquisition cost index. This will prevent access to critical health care for myself and other injured workers. I have personally experienced delays with my own prescriptions that were unavailable at traditional storefront pharmacies. Without rescue meds, additional medical care might have been required, but I couldn't receive on medication from traditional pharmacies timely. Even though rescue meds may have an additional cost for their services, it provides patients like me peace of mind that I can get what I need in a timely fashion. Regulating charges for prescription drugs under this legislation would do a disservice to those of us who rely on rescue med service. Please reconsider this legislation for this reason. And thank you for your time.
Excuse me. Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. For the record, I'm Dolores Sanchez-Ificalche with Cornerstone Government Affairs representing Easy Scripts. We also are not opposed to a fee schedule where we think there should be some differences in legislation that, as introduced, is having a comprehensive study of Maryland's current pharmacy reimbursement practices done by the Workers' Compensation Commission Medical Fee Guide Revision Committee. The committee was established to review the methodology that the Workers' Compensation Commission utilizes to regularly review physician fees. Among other responsibilities, the committee is charged with the responsibility of recommending the best approach for distributing and annually updating the fee guide. Members represent payers and receivers, as you've heard from the Maryland Association for Justice. We would suggest, in addition to those members, pharmacies and pharmacy benefit managers should be included in those deliberations as well. So any changes, whether it's with NADAC or AWP to the fee schedule, we believe should be deliberated by those folks who are charged with doing this and who have experience with doing a review of that to understand what would be the best course moving forward, what would be the best fee schedule moving forward, as opposed to moving it through in a piece of legislation without that deliberative process. So that would be our basis for opposition, and we would urge an unfavorable report for the bill as introduced. Thank you very much.
Madam Chair, Vice Chair, and members of the committee, thank you. My name is Darren Thomas. I'm the Chief Operating Officer of Easy Scripts Pharmacy. We are a national workers' compensation pharmacy that specializes in providing medications for injured workers. We are in opposition of the bill. Workers' compensation, as I think we've heard a little bit today, is a little bit more complicated than what we look at on a Medicare side, Medicaid side, or in the private health insurance side. There are a lot of additional hoops that patients need to jump through, doctors need to jump through, pharmacies need to jump through in order to ensure that these patients are getting the correct therapies that they need to recover from their work-related injuries. The majority of states in the country are using a formulation of AWP. Some are plus, some are minus, and there's multiple reasons for that. One is pharmacy benefit manager systems. We've heard some testimony earlier today that the counties are self-insured. They're using third-party administrators that are filtering medication bills through pharmacy benefit managers who are repricing these bills and sending out payments. And I think as we look at what needs to happen, I think a comprehensive study that investigates what the total in-network, out-of-network pharmacy spend is, what are the PBMs charging to administer these benefits, and where that fluctuates as opposed to what out-of-network pharmacies are paying. Three things that we see typically happen across the country when states go and look at different radical changes to pharmacy fee schedules. One is access to medications. Access to medications, if the pharmacy reimbursement is not fair and equitable, patients will have trouble getting there. Also, cost shifting. We heard a little bit of that earlier. Cost shifting into other programs, out-of-pocket costs, Tier 3 copays for certain medications under private health insurance. And the last one is the potential increased costs to Maryland employers for pharmacy benefit managers that would have to set a specific, unique model to process pharmacy bills within the state of Maryland. Without that comprehensive study and that look at overall total pharmacy spend and it affects to all stakeholders, including the injured workers in the state of Maryland, we oppose the bill as it is currently constructed.
Thank you for your testimony. Now we'll start with questions. Senator Gao.
Yeah, Thank you, Mr. Vice Chair. Hey, Jim, good to see you. I got a quick question. So I was thinking about the testimony that you just gave, and you said you're opposed, but you're not opposed to a fee schedule. Is that right?
Correct.
Okay, maybe if you can
Not
move
me
the mic.
personally.
Maybe if you
No.
can move the microphone. I mean, I realize.
Yes,
I mean,
I know.
by you, I mean MAJ.
Yes,
I
I'm the
realize.
embodiment of the trial lawyers today.
But I mean, you touched upon one that the commission can already, and it sounds as if your opposition is one that the commission already has the authority to set the fee schedule, and you would rather the commission set the fee schedule versus the Maryland General Assembly. Is that right?
Yes, Senator. The commission already sets the fee guide for every other medical service. Just three things that are out of that is dental, durable medical equipment, and prescriptions. So the commission can set, if they so choose, the rates for those three things if they've tasked themselves to do so. And we have the medical fee guide has been around for years. Again, it has the ability to take in all the information and make a decision. I'm not a member of the committee, but I watched some of the proceedings. I don't know why ultimately the decision wasn't made to implement a final fee schedule, but the commission does have the ability to do this, and they have the experience on both sides, the payers and the receivers, to debate this issue, to investigate it, and to come up with a system. It may not make everybody happy, but it can do it.
So why can't the Maryland General Assembly do that?
Because it's a matter of nimbleness. If we have to come to the General Assembly to change the statute, that is a heck of a lot harder than convening the Medical Fee Guide Committee to make decisions, because the Medical Fee Guide Committee already has to meet at least every 2 years. So as necessary, the commission can react much faster than if we have to wait for the 90-day session every year to make changes to 9663 if this bill was to pass and become law.
Okay. You also touched upon, I think, access to medications. So, I mean, there's some pretty concerning numbers as far as what was being charged. I mean, I understand that, if folks, and with all due respect to our panelists here, I mean, I truly understand and recognize the need for getting medication folks when they can, but I'm not sure that these charges justify that access. I mean, maybe you can help me understand why is it, I mean, and maybe when answering, if you could help me understand too, I mean, is there a particular fee guide that MAJ is supportive of, or are they taking a position on that?
No, there's not a specific guide that MAJ is going to take a position of. Quite frankly, Senator Beidel knows those alphabet soup better than I ever will. My job is to make sure that my clients can get all the medical care that is necessary, reasonable, related. When it gets to the charges, it's about the reasonableness of the charge. That's where the commission, when they come up with a medical fee guide, that's where the reasonableness is decided. I don't have to go to the commission to decide whether or not Dr. Frazier should get X amount or Y amount for the surgeries he provides, because there's already a fee guide and we're going to follow a CPT code to make sure that he gets repaid and the anesthesiologist gets paid and everyone gets paid. We don't have that per prescriptions. However, that CPT code equals that number, that's what the Medical Fee Guide Committee decides, and that's what they should also do for prescriptions.
Yeah. I mean, it almost sounds like you're making taking the position that they could charge whatever they want just so that they can get access, so these injured workers can get access to that medication, which I think is what seems a little bit troubling. But I do have one quick question for Darren before I turn it over, Mr. Vice Chair. Darren, are you willing to share your acquisition costs or prove the need for your pricing?
Will I be willing to share my acquisition costs? That's a great question. One is potentially.
Potentially?
Potentially, yes.
Okay.
And the reason I say potentially is in the majority of these cases, when we are submitting our cost to an insurance carrier, it is going over to a pharmacy benefit manager and it is being repriced. Our price is being reduced. And I bill over 80 insurance carriers within the state of Maryland. And the majority of carriers will take my bill, and it is marked up 120%, and they'll get marked down to average wholesale price, and they'll pay it, and that's what their PBM is paying us, right? So my question then is, will the PBMs provide their contracts, and will the insurance carriers provide the contracts they're paying to the PBMs to see if there really is a big difference in what we're getting paid as opposed to what these insurance carriers are paying the PBMs to administer these benefits.
Okay. Well, maybe let's start with your acquisition costs, and then we'll go from there. But thank you very much, and thank you, Mr. Vice Chair.
Oh, Senator Reedy.
I've been listening to all of this, and it's very interesting. I've met with people kind of on both sides, or all sides of this, I guess. Mr. Lanier, so you just mentioned the PBMs, and it's spurred my interest. So is it your contention that these entities that are paying a lower price are paying a lower price, but they're not including in how they've told us their prices, they're not including what they had to pay to the PBM? Or I'm trying to understand how that makes it. I know PBMs make money, so I'm just curious about
Yes, to answer your question, I think that's an interesting fact. We heard a lot of data thrown out from the counties, from Chesapeake and IWIF in regards to what that pharmacy spend is. I guess the question there is, what's the difference of that pharmacy spend? Is that what the CVS is getting paid under that PBM contract, or is that what Chesapeake or IWIF or the counties are paying the PBM in order to administer the benefit, right? There's a difference there because PBMs, right, we all, and they're up a lot nowadays, but PBMs get a spread pricing difference. They contract with retail pharmacies to pay lower rates, and then they get paid a certain rate from the insurance carriers. And where I think a comprehensive study that looks at how this all shakes down and looks at what are the right methodologies can look at what is the difference. Now, in my experience of over 20 years in work comp pharmacy, in many of the contracts that I've created with pharmacy benefit managers, they're typically around average wholesale price minus 15, minus 20, 25%. But they're paying the network pharmacy an average wholesale price minus 80 to 90%. So they're keeping that spread in the middle. So if we were to look at those numbers and say, PBM's getting minus 20, we're paying out-of-network pharmacies average wholesale price, we're not that far off from having that right conversation to say, what do we do?
Okay, but is it not true that the insurer is paying, in this case, like a county would be paying less still, even if they're paying out to something that's a PBM? I'm just trying to...
They might be paying less. They may not. It all depends on how that contract is set up and what version. Our bills in Maryland, and I bill, again, over 80 insurance companies in the state of Maryland, 98% of those insurance companies are paying average wholesale price today. So if they're paying me average wholesale price and they're paying the PBM AWP minus 15 to administer the benefit, there's a little bit more cost there, but in many cases, those PBMs don't pass that cost through back to the insurance company. They eat it.
Okay, all right, thank you. Thank you.
Chair Bidle.
No, I just, if I can just clarify something Mr. Lanier said. This bill does not make you come back to the legislature for any changes. All this bill does is mandate that the Workman's Comp will set the fee schedule, and Workman's Comp will make any changes later they need to make. Isn't that true?
With respect, Senator, I don't read it that specifically. I think that anytime you're going to put you're going to dictate something to the commission then has to follow those dictates. They don't have the freedom that they do with all other parts of the medical fee guide. I don't know how else.
This allows, I just want to be clear, this allows the Workman's Comp Commission to set the fee schedule. And yes, they worked on it a couple years ago and could not come to conclusion. So the idea of this bill is to mandate that they set a fee schedule, and that's the purpose of the bill. Thank you.
Yes, ma'am.
Senator Kramer.
Thank you, Mr. Chair. And I just wanted to follow up quickly on that because, and I'm still not quite following, the bill specifies the commission shall regulate fees and other charges for the reimbursement of prescription drugs and pharmaceutical services under this subtitle. So what is it that I'm missing that you're under the impression that there would be this need to come back here to be looking at those regulated fees?
So the issue is that if it simply mandated that the commission set a fee schedule for prescriptions, add them to the medical fee guide. Senator Kramer, I agree with you. If it simply gave them the instruction to do it, then they would do it. But then there's the additional language in the bill that talks about which indexes to use, and the more you put limits, or not limits, but the more you put requirements to the commission, the more that they have to follow, they're required to follow a requirement by definition. So you're you're limiting their ability to do what they believe is necessary without having to come here to change the bill. If it simply said, hey, Workers' Comp Commission, you shall set a rate for prescriptions, I don't have a problem with that. The Maryland Association of Justice doesn't have a problem with that because it should happen. But the more that there's the more specificity, the more the commission becomes hamstrung, becomes required.
So if I understand, you are vexed with the paragraph that simply says it'll be based upon an index or indexes based on acquisition cost.
Correct. If it was simply just on B2I and just requiring the commission to set the rates, I don't have an objection. The MAJ does not have an objection to that.
Okay. All right. And a quick question is it Mr. Thomas?
Correct.
On the end. Did I understand that you were implying that maybe by doing this, there would be a access problem to certain drugs? It sounded like that's something that you were asserting. Is that
Yes.
correct?
Yes. So if we're going to move to some sort of acquisition cost, NADAC cost, WAC cost index, between the complexities that already exist within the workers' compensation systems in order to even provide medications, you're going to have pharmacies that just say, we're not taking work comp patients anymore.
So let me ask you this. If that is your concern, it appears as though there may be a majority of states that have already moved into this direction, as well as I believe there were representations that under Medicare, so there's a similar process. Are you aware of complications in availability in all of the jurisdictions that have moved in this direction? And can you identify what those would be?
I think you might be referring to where we heard earlier that 43 states have moved to this. Is that-
I don't recall the total number,
that
but
was stated
they're-
earlier, and that's not the case. There's 37, 38 states that have current fee schedules today.
I'm sorry.
That have
repeat
current
that.
workers' compensation fee schedules.
That have fee
That
schedules.
have fee schedules. 34 of those states, 30 actually more than that, 35 of those states are based off a formulation plus or minus of average wholesale price. There are no states currently today that have a NADAC value workers' compensation fee schedule. The closest one is the state of California, because the state of California work comp statute says that workers' compensation drugs have to go through our Medi-Cal database, which is the Medicaid database, right? No other state, Massachusetts does not use NADAC. They're another one that they do not use NADAC in their fee schedule.
And the Medicaid databases do have that.
The Medicaid databases do.
Okay.
Okay.
And are you aware whether that has posed a problem in access to medications where the Medicaid fee schedules have these requirements?
Well, under Medicaid fee schedules, right, those drugs, as long as they're Medicaid approved, right, which is that big, long list, they're going to get those medications. Okay. That vastly differs from the process of workers' compensation, where patient can walk into a retail pharmacy and an adjuster hasn't updated a benefit and eligibility file, and now they can't get their pregabalin medication because that hasn't come through the system. That doesn't happen in a Medicaid system. That happens in a work comp system. So going to this route and having it, so then what that entails doing is now you have a pharmacy that's got to make a bunch of phone calls. Or in a retail setting, a pharmacy is just going to say, I'm sorry, do you have another form of insurance? Or do you want to pay for it out of pocket?
Okay. All right. Thank you, Mr. Chair.
Thank you, sir. Senator Ellis.
Thank you, Mr. Chair. So following through here, trying to understand the reason that you oppose this bill, just want to reach out to the firefighters and say thank you for your service and your pain as a military member who went through a lot of disabling stuff. I definitely been through a lot of stuff. Not saying I know exactly what you experienced, but I can empathize a lot. So, question to you. What's your name, sir?
Steve McCombs.
Steve McCombs.
Steve McCombs.
Okay, Mr. McCombs. So, your fear is if the prices are set lower, Is it that you won't have access to these medicines under the current system? Because, say, rescue meds are there, they're willing to make an entrepreneurial decision, take that risk of offering you that medication, not knowing that 100% they will get repaid, but the reimbursement rate was higher when they get paid, balanced out when they don't get paid. Is that a good reading of it, or?
Yeah, my concern is that in past, when Rescue Meds wasn't available to help me, because they did, I believe it was Rescue Meds who helped me before, and something happened with workman's comp and I lost the ability to get my medications through Rescue Meds. I went through quite a few years of not getting my medications on time. And I rely on these medications, like I said, just to get out of bed every day. I wake up 4:30 in the morning to take my medications just so I'm not in pain at 7 o'clock. So my concern is going back to the way it was. And I always paid for my medications with CVS. I don't mind paying. I've paid for my medications for 14 years now. But with the way that Rescue Meds handles the medications now, I leave the doctor's office. I left yesterday. I went to pain management in the morning and went to another pain management in the afternoon. And I get an email from Rescue Meds, and my medications are at my front door the next morning. So my concern is losing that and going back to not getting the medications on time. And there's been days when I didn't have my medication called Examsta that I would call out from my full-time employment because I was in so much pain, my lower back, and I just miserable. I couldn't go to work. So that's my concern. I'm nervous. I'm scared to lose them for that reason. And I'm being kind of selfish, and I feel bad about it. But they've done a lot for me, and I appreciate it.
Well, that's not really selfish. I mean, something you experience with so many others experience it. Years ago, as an employer, I went to a workers' comp hearing, and there was a police officer who got hit on the job on the highway, and he had to go through this fight, through these hearings, and it was, I was in the hallway, and he was talking to his lawyer, he was crying, like, why am I going through this? I mean, and so I understand in a lot of ways, and the system needs to be definitely fixed. Question to, I don't know, someone who knows the system really well. Why couldn't there be a presumption of medical necessity? I know in the military, you have a lot of presumptions. If you were in Vietnam, Agent Orange, in the zone, you come up with these cancers, you're presumed to be service-connected. And so why couldn't we have a system like that in workers' comp to presume that if you're going through these issues, then you get the meds, work through the system? Because there's this human element to all the stuff we talk about. Does that exist, or is it possible to exist? A presumption of medical need? If a firefighter, police officer is going through this stuff, why should they worry about getting the medication, which we know they need?
Well, Senator, the word presumption in the workers' comp system is like the third rail. It's very controversial. As of right now, we have presumptions for certain diseases, mainly for firefighters and for police officers and some other public safety people. But as for that, just gets you those presumptions for that situation allows for the claim to be entitled to benefits, what we call compensable. Once you become compensable, it is always the injured worker's burden to prove that the medical care or whatever other benefit is necessary, reasonable, and related to the claim. So the problem with the presumption is it's our responsibility to prove that the injured worker needs this medical care. The insurance companies don't have to disprove that. We certainly could upend the entire workers' comp system and change who the presumption goes towards, but Senator, that would be a rather heavy lift and would change basically the entire Comp Act.
The entire what?
It would change the entire workers' comp system in Maryland to switch the burden from the injured worker to prove the entitlement to the benefit to the insurance company or the employer and the insurer to prove the otherwise.
Well, if the system is broken, it's not working for first-line responders, police officers. I see the bill file. All these firefighters, police officers are opposed to this. And, they're out there working hard, suffering what they do. So why shouldn't we do the heavy lift and make it a presumption and so where they can get the help that they need. I mean, we're here to do the heavy lift. And so if we can't contain the price and make sure our public servants get the help they need medically, what good are we? I mean, what good are we? I mean, why are we tinkering at the edges? I mean, as a society, that's what we're here to do. Because guaranteed, when our house is burned down or in a car accident, these men and women are showing up for us, okay? They showed up for me, so why can't we show up for them and make sure we make a system that works for them? And I would love to work with you to make sure, it's not this bill, but to make sure that we do the heavy lifting, to make sure we take care of our first responders. Because 9/11, our firefighters and police officers fought like you know what to get the federal benefits for many, many years. And it shouldn't be that way. So are you willing to work with me to kind of, after this, to look at that additional presumption so they can get their medicines? And
Senator, the Maryland Association for Justice is going to always do whatever is necessary and reasonable to get injured workers of Maryland better and back to work, however we can do that.
Okay. So, I mean, that's a yes or no?
Absolutely.
Okay, thank you.
Yes,
thank you, Mr. Chair.
Thank you, Senator Ellis. Well said. Are there any additional questions for this panel? Thank you all so very much. We're going to move to our virtual testimony, starting with Nancy Egan. Nancy, are you with us?
Good afternoon, everyone. My name is Nancy Egan with the American Property Casualty Insurance Association. Our members include Chesapeake, and we represent 91% of the workman's comp marketplace. I am actually in support of the bill as currently drafted, and I echo all the remarks of my prior colleagues that were in support of the bill. We think that the cost savings by having the Workman's Comp Commission to set up some sort of index, and then as stated in the law that they would review that index every 2 years based on acquisition costs, is a great idea to pass savings on to our private employers throughout the state. And with that, we urge a favorable report. Thank you.
Thank you so very much. Next two virtual testimonies will be favorable with amendments. We're going to start with Lisa Ann Hurt Forsyth.
Hi, good afternoon. My name is Lisa Ann Hurt Forsyth, and I represent the American Association of Payers, Administrators, and Networks. We're a nonprofit association with a number of different workers' compensation payers, workers' compensation pharmacy benefit managers, et cetera. Pretty large conglomerate of different payers. We are here in support of the bill. We would request a couple amendments, and we did discuss those already with Chair Vital. But we are very supportive of Chair Vital's efforts to rein in costs and introduce some certainty in pricing in the workers' compensation system in Maryland. One point I did want to touch on that was mentioned before was with respect to disputes. It is in everyone's interest in the system for the friction level in the system to be reduced. Considerable litigation and disputes are costly from an administrative standpoint, but it's also difficult for all parties to have to hire counsel and come in and dispute all of these. So disputes are very costly to the system, and it's definitely better for the system overall for it to be a self-executing system. And I think this bill is an important step towards that. The only things I would ask was with respect to the pricing index, just that we have the words nationally recognized pricing index inserted into the bill language. We would appreciate that. We would also appreciate making sure that the scope that the Maryland Commission is permitted to rate set for would be inclusive of all medications that are dispensed for outpatient use. That would include compounded medications, topical medications, and over-the-counter medications. So we would just ask that that scope be expanded. And with that, we would offer our support. Thank you.
Thank you so very much for your testimony. Lastly, we will hear from Brian Allen, who's signed up to testify favorable with amendment.
Yeah, thank you very much. My name is Brian Allen. I'm with Enlight Pharmacy Solutions. We are a work comp pharmacy provider. We typically contract with self-insured employers or insurance carriers to help them manage their pharmacy costs and their pharmacy programs. We appreciate the members of the committee, Chair Vidal and Vice Chair, for your time and attention. I know it's been a long afternoon. I'll be brief. My goal is to get done before the buzzer goes off. So this is the third time I've been before a Maryland committee to testify about the pricing fee schedule. We are in support of the bill. We appreciate the inclusion of the amendment that allows us to continue to contract at a different index or whatever different fee schedule from what the commission might set. We have a lot of faith in the commission. I think it's interesting. There's been a lot of discussion around the indexes themselves. I don't think there was anything in the bill that required that the pricing be at the index level. I think commission has the flexibility to go to a multiple of the index. If I don't believe that NADAC in the workers' comp space would encourage a lot of pharmacies to want to dispense medications, but there's usually a dispensing fee involved, and there's some compensation that helps them with what they do. Additionally, the PBMs need to be compensated. I will guarantee you that our pricing is very competitive. We do a fairly steep discount off of AWP right now. And so we're happy to, if somebody wants to compare numbers, we're more than thrilled to do that. We have no shame in what we do, and we think we do it very fairly. And I think any of our customers will tell you that we do it very fairly. Our world's very competitive. It's a blood sport when contracts come up for renewal. So we are trimming costs constantly, and every year we trim our numbers down even further, and sometimes you're talking about halves of percentage points, but it makes a difference, and we're trying to do all we can to help payers manage their costs well, but still provide care for injured workers in a timely manner.
All right, thank you so very much. Are there any questions for our virtual panelists?
Excuse me.
Sorry, we don't have anyone else signed up to testify. We did call a couple of people earlier that may not have answered, but that time has since passed and we're moving on. So this ends the hearing on Senate Bill 306. Next, we're going to hear Senate Bill 695. Signed up to testify and favorable on the panel is Carmine D'Alessandro.
Thank you, Mr. Vice Chair, and members of the committee for hearing Senate Bill 695. For the record, Pam Vidal, District 32. This bill, we've talked earlier about the UEF, and the UEF pays for people that are injured, but their employer did not have insurance. But the bill does two simple things. One is that it requires that they have a reserve funding. Now it says they may have reserve funding limit, but this says they are going to be required so that they can meet their potential losses. But the other thing is, we've heard there have been some issues with the expenses of the UEF fund, and we thought maybe by adding, they only have 3 board members, right? 3 board members, and we'd be adding 2 additional board members with bringing some experience to the board that could really help them to better manage the funding that they're using. Remember, their funding is from insurance companies that are claims that are paid by insurance companies. So we want to really be careful that we protect that money and know that it's used wisely. So for the long-term solvency of the UEF, we'd like to add a couple of members to the board and require that they establish the reserve funding.
Thank you, Chair Vidal. Mr. Vice Chair, again, Carmine D'Alessandro, representing Chesapeake Employers Insurance Company and the Injured Workers Insurance Fund. And I believe this bill addresses, Senator Reedy, some of your questions when we had the first part of this, and that is what are some of the systemic problems. And you talked about a P&L type situation, which is difficult with a state agency, but I think this starts the process. As we said, the work group was faced with many challenges, fiscal and operational, and there were many, many suggestions of how to move forward. We realized that we couldn't implode the UEF and try to do 1,000 things at the same time. And that's the heart of the compromise that I put forth before. We're giving the UEF a little bit of money, but this bill then starts some structural changes. For example, right now the board's expertise per the statute, 3 members, 1 is union, 1 is management, 1 is public at large. And without being critical of those subject matters, there's not much there that would help you run an insurance company or a TPA. Mr. Burns rightfully says we're a state agency. We're not a TPA or an insurance company. But if you read the statute, they're supposed to act like one. So this brings in 2 insurance people, a finance person, a policyholder, because the policyholder is the ones that are paying the freight here, and then a public. So it starts to give some expertise to help Mr. Burns. And again, this is not being critical of Mr. Burns. We have been on the different sides of many issues here, but I can say he inherited a mess in 2016, and a mess is an understatement. So this is providing some support. And the other thing, going back, Senator Reed, to your P&L comments, by establishing reserves, and yes, it might be an unfunded liability, but at least it tells you what your potential financial issues are with claims. So it allows you to then determine what kind of finances you have and whether you can get contracts and things like that. So we think these are 2 small steps to help, along with the increased assessment, to right-sizing the uninsured employers fund. For those reasons, we support the bill.
Absolutely. Thank you for your testimony. Senator Reedy.
Brief, Mr. Chairman, thank you. So this answers a lot of my questions earlier, and I'm sorry I got mixed up on the 2 bills in the middle of one of the bills. We've had a lot going on this week today. But establishing the reserve, so it's, number one, I think the changes to adding to the board and requiring some basic, some minimum standards of, not minimum standards, but standards of people who have expertise in this field is really good. Number 2, if the reserve, we know, and I understand from Mr. Burns' testimony on the last bill a little bit, we can't really know for sure how much you're always going to need. But if you have a reserve fund, even if it's not perfect, you at least have some contingency, right? I mean, that's basically what we're trying to do here, is just have some level of contingency. Obviously, if some disaster strikes, then, you know, we're going to have to supplement. But this would make sure there's at least a building reserve over time, correct?
Correct.
Okay, thank you. Thank you, Mr. Chairman.
Are there any additional questions? Senator Mouse.
Yeah. And we had hearings earlier in the session about this fund, and this is in lieu of a conservatorship or something like that was mentioned at the hearing. Is that a correct assessment?
I would have to speak with Chairwoman Quinn. I don't know if she still intends to have someone with, we were looking at a former workers' compensation commissioner with significant experience that may be as a help or an advocate. So I don't know where that stands with this bill.
Okay.
I wouldn't put words in her mouth. I'll defer to her to answer that question.
Well, that's okay. I can figure that. Thank you.
Thank you. Are there any additional questions? Seeing none, thank you so very much for your testimony. Now we will hear from, excuse me, Julie Mary, Michael Daly, and Michael Burns. If you're here, I know you're signed up favorable with amendments, but if you all would come up to the table. Julie Mary, Michael Daly, and Michael Burns.
Good afternoon, or perhaps we're entering evening. Julie Murray again on behalf of Maryland Defense Council. We think that the bill is very well drafted, very carefully calculated to lead to some improvements in the operations of the uninsured employers fund, and MDC would strongly support the bill and urge a favorable report. Thank you.
Thank you.
Thank you, Madam Chair, Ms. Vice Chair, and members of the committee. Michael Daly for the Maryland Defense Council. As Ms. Murray said, we do believe the proposed changes to the board members and their qualifications hopefully will provide the support needed for Mr. Burns and the UEF to make great strides to improve the efficiency and operation of the UEF. For those reasons, we ask for a favorable report.
Good afternoon to all again. Michael Burns, the Director of the Uninsured Employers Fund. I would like to thank the sponsor for meeting with me to discuss this bill and for giving me some very good ideas about it and being open to an amendment to this bill. I believe it's much more effective to build than to tear down, and I think it's more effective to add than to subtract. And since this bill is styled as to assist the functioning of the agency, I think the way you would assist the agency is you would keep the people with the expertise who have served on the board. Two of those members who would be removed by this bill have a combined 12 years of experience on the bill, on the board, and adopt instead of totally reshuffling and bringing in 5 people who don't really understand the agency, why not keep the 3 you have now, one of whom does represent the general public in both the current situation and in the bill, but add 2 people to the board. So add a person who has substantial experience as an officer or employee of a property or casualty insurance company, 1. 2, add somebody who has a policy of workers' compensation insurance issued by the state. So 3 of the 5 suggested members of the board that are suggesting this bill would be on the board, as would 2 others who have been on the board. So you would have a much broader base of experience, as opposed to throwing out 2/3 of the current board members. I will also note that I'm sure the insurance industry likes this bill because they would have at least 2 and perhaps 3 and perhaps more people with skin in the game from the insurance side running the agency. And I don't think that's appropriate, and I don't think it's what you all would want. So I would urge you to approve the bill with the amendment that we've submitted to the committee. Thank you.
Thank you. Are there any questions for this panel? Senator Reedy.
Thank you. Mr. Burns, I understand the argument for some continuity, although it sounds like things have gotten a little bit away from the current board. That may not be totally fair because I'm not immersed in this every day, obviously. But your comment about having too many people from insurance on the board, I guess it doesn't track with me because this essentially is you're helping to run an insurance operation. That's what this fund is. It's not insurance as such because it's a state agency, it's a state entity, but it is ensuring that we have what is needed to cover injured employees who have worked for companies who don't have the right insurance. So I mean, I would understand if this was like having insurance industry overseeing the price of drugs or something. I could see the next. I guess I don't understand why is it inherently a conflict? We are a payer of last resort. We are not an insurance company. We do not issue policies. We do not set premiums. We do not require premiums. We take whoever comes in the door. We are an insurance company. We are a collection agency. We are a medical TPA. We are a state agency. We are an investigator. We're a private detective agency. We do a number of things that you don't have time for me to explain right now. But as part of it, I get that. I totally get it, and I guess I don't understand what the conflict is because you just said you're an insurer of last resort. MAIF is an insurer of last resort. I don't know if anybody has a problem with the MAIF board having an insurance, people with car insurance backgrounds on the board.
I just would point out that we are 80 to 90% funded by an assessment on the insurance industry, and three of your board members would have something of perhaps an interest in that, and so that would, instead of having a 5-member board with 2 members directly related to the insurance industry and 3 representing management, labor, and the public, you would have a different scenario. I will say this, we've been setting about the reserves. We couldn't set reserves when I got there because they didn't even know how many cases they had.
I understand.
But we've been setting reserves for 5 years, so
okay.
Fine. It's done. That's done. So it's fine to make it mandatory.
I'm not trying to like pick on you, but I just don't. I feel like this is similar to MAIF in the sense that it's insurer of last resort. I don't think there'd be a conflict with having people with a lot of car insurance background be a part of a MAIF board. I don't think there'd be a problem. But that's what we could maybe agree to disagree. Thank you very much.
Sure.
Thank you. Senator Ellis.
Yeah, thank you, Mr. Chair. Quick question, sir. You just saying all the things you are. You throw out a term TPA. I'm Googling tissue plasminogen activator. I don't think you were that. What's TPA? I mean, there's a whole bunch of stuff. I mean, what is TPA? You say you're a TPA.
I'm sorry. I hate to do that. Lawyers always do stuff like that. I apologize.
No problem.
It's a third-party claims administrator.
Oh, okay, yeah.
It is how most of the major counties in the state do what we do. They hire a national professional claims administrative company to manage the claims for us. And most of them hire the company we hire, Corvell. But that's what a TPA. We take care of that. They do all the whole injured worker part.
Yeah, thank you.
Sure.
Thank you,
Okay.
Senator Ellis. Are there any additional questions for this panel?
Okay. Thank you for your time.
Seeing none, thank you so very much. Nancy Egan, once again, joining us as a virtual witness. You may proceed, Nancy.
Thank you, Senator. My name is Nancy Egan. I represent the American Property Casualty Insurance Association. Our members write 90% of the workman's compensation market, and one of our members includes Chesapeake Insurance. We are fully supportive of the bill, and I think that setting up additional members that have experience in handling claims and adding someone that is experienced in accounting and finance, which does not reference insurance, but specifically in accounting and finance. By having members of the insurance industry, they also are very knowledgeable about working with TPAs and their cost, would be something that would be very, very favorable to working with UEF to set the financial record straight and get that moving into a more positive area. It just would provide better oversight of UEF, and we would appreciate a favorable report on Senate Bill 695. Thank you.
Thank you so much for your testimony. Are there any questions for Nancy? Seeing none, this ends the hearing on Senate Bill 695, sorry.
Thank you, everyone. We're now going to go to Senate Bill 830, Workers' Compensation Claims Application Form, and the Vice Chair is the sponsor, and he's going to bring Maureen Quinn and H. Scott Curtis as his panel.
How you doing? Good afternoon, Senate Finance. Thank you for hanging in there. We're going strong. Senator Antonio Hayes from the 40th Legislative District, here to present to you Senate Bill 830, Workers' Compensation Claims Application from Authorization for Release of Information. For the record, I'm Senator Hayes, as I said, representing the 40th Legislative District. This legislation simply modifies the workers' compensation claim process by improving access to claims records through the CompHub system, eliminating unnecessary administrative burdens and ensuring a more efficient and fair process for claimants, employees, insurers, and state agencies. I'm going to keep my testimony very short, as I know the hour is long. This bill does 5 key things. It expands access to essential information, clarify the scope of release information, establish a defined authorization period, promoting administrative efficiency, and there will be some minor technical amendments shared in our testimony. Colleagues, I urge a favorable report with the amendments on Senate Bill 830.
Chair Bidle, members of the committee, for the record, Maureen Quinn, I'm the chair of the Workers' Compensation Commission, and this will be the easiest bill you hear all day. I am going to just simply give credit to our Assistant Attorney General, who came up with this crafty solution to a problem with accessing prior claims. And typically, it would be a departmental bill, but his spark of enlightenment came in late December. We quickly assembled all the stakeholders, and we got to yes very quickly. I want to thank Senator Hayes for stepping in and sponsoring our bill.
Madam Chair, Mr. Vice Chair, and members of the committee. So currently, consent to access medical records is a required element of filing a claim before the Workers' Compensation Commission for a claim. This bill improves the party's access once the claim has been filed within the CompHub system. The CompHub system, if you're familiar with the court system, is kind of our MDEC. It's our online filing system for workers' compensation claims. This allows the parties to access prior claims and actually subsequent medical records that are relevant to processing a workers' compensation claim. It also, as a technical sort of amendment or part of the bill, clarifies that the parties include the UEF and the SIF. And for the only time today, the UEF, SIF, WCC, the entire community is on board with this. So there is one technical amendment, I guess you would call it, which would be this is the same wording that applies to Labor and Employment Article 9-710 and 711. It appears in as a bill in front of you is an amendment to 9-709A, so it would be 9-710B, 9-711A. So that's it.
That's great.
Thank you.
I love when everybody sings Kumbaya.
Great.
Thank you. Do I have any questions? No questions for this panel. Thank you.
Thank you.
So we have a lot of support. Hopefully these are Me Too's. Julie Murray, Michael Burns, Carmine D'Alessandro, James Lanier, Ashley Smith.
Can we all hold hands?
1, 2, 3, 4, 5.
Be the only time we
1,
ever
2,
have one
3,
here.
4, 5. Matt, are you still here?
This is good.
Matt's not here. Michael Daly.
It's nice.
Don't get used to it.
Yes.
Never be sitting next to each other. All right, you each have 2 minutes, and if you use less, you get extra points.
I'll start then, Chair Bidle. Thank you, Carmine D'Alessandro. Me too.
I'll try to be even faster. Julie Murray, me also.
Ashley Smith on behalf of MDC. Me too.
James Lanier on behalf of MAJ, me too.
Michael Burns on behalf of the Uninsured Employers Fund. Me as well.
Michael Daly on behalf of the Maryland Defense Council, me too.
Is that the fastest ever?
Thank you all
I'd like
for
to
your
think we set a
testimony.
record.
Nancy Egan.
I don't see any questions. I do have Nancy Egan virtually. Nancy?
Nancy Egan, APCIA, me too.
Thank you.
Yay!
Thank you all. That's got to be the quickest bill in our history. That ends the hearing on Senate Bill 830. Thank you, Mr. Vice Chair, for the bill.
It's good we can get together.
And the last bill of the day, Senate Bill 957, Morticians and Funeral Directors. Senator Wallstreicher, are you here? He's on his way up. I'm sure he didn't think we were going to be this quick. Okay. Let's give him a minute.
Should be on.
Senator Wallstreicher, thank you. You are our last bill of the day.
Well, thank you, Madam Chair.
And you have someone with you. Is that Syed?
No.
This is Mr. Van Emden.
Yeah, okay, you had another person that doesn't appear to be here, Syed.
Mr. Naqvi was called to do a funeral. He's
Okay.
trying to get here, but I don't know exactly where he is.
Okay, very good. Senator Rothstreicher, please introduce your bill.
Thank you, Madam Chair. Thank you, Mr. Vice Chair. Thank you, members of the committee. It's a rare day where finance goes long and JPR is out, so this is unique indeed. So, but given how long a day you've had, I'll certainly keep this brief. On behalf of my constituent, Guidon Van Emden, I wanted to bring Senate Bill 957. And I'll just start with a really kind of basic point. We allow corporations to form however they choose in almost every industry. And so if you want to be for-profit, great. If you want to be nonprofit, great. But there is one industry where that is not true, and that is the funeral industry. Maryland law does not allow nonprofit funeral homes, and Senate Bill 957 changes that. It simply puts the funeral industry, the death care industry, on the same footing as every other industry. Let me give you an example. So barbers and cosmetologists, as this committee knows well, are actually surprisingly highly regulated industries. In Maryland, you have to have a license, you have to get renewed, and most barbers are for profit. You pay them, they give you a haircut. But if you want to start a nonprofit haircutting operation to serve people who are homeless or veterans or cosmetologists who care for people who are terminally ill, and you want to start a nonprofit to do those things, you could absolutely do that in Maryland. And you could form, if you wanted to be for-profit, there are many ways to do that. You could be a public corporation, you could be an S corporation, a pass-through. This committee, under the leadership of the former vice chair, created benefit corporations, B corporations. You could set up like that. Barbershops, sometimes the people who are cutting hair are paid by the owner. Sometimes they are independent contractors. The point is, by analogy, there are millions of ways to set up your business in Maryland, and we provide flexibility for all sorts of industries, including heavily regulated industries. The death care industry is the only exception to that. And so this bill would simply put the death care industry, as a matter of fairness, in the same position as every other industries. With that, I'll hand it over to my constituent and ask for a favorable report.
Thank you, Madam Chair and Mr. Vice Chair, Senators. My name is Guidon Van Emden. My uncle and my grandmother were very involved in their Jewish community's funeral practices, and I continue that tradition as chair of my synagogue's Funeral Practices Committee. I'm involved with the Jewish Funeral Practices Committee of Greater Washington, and I serve as a consumer member of the Maryland Board of Morticians. I'm here today, however, strictly in my personal capacity to advocate for SB 957. Not-for-profit funeral homes already exist legally and safely in almost 20 states, as Senator Rothstreicher just pointed out. And in many, many sectors of our economy, they contribute uniquely to our society. So the proposed bill is brief and simple. Over the past months, in discussing these issues with many Marylanders, most people simply responded with, "Are they not legal now, and why not?" So the requirement for ownership excludes not-for-profits, even as the law does allow for a grandfathered exception for corporate licenses. One could even say great-grandfathered at this point, because they had to be in existence since 1945. So what this bill proposes is simply to allow a not-for-profit entity to apply for a new corporate license. That entity has to fulfill all the other requirements. It has to pass an inspection, appoint a supervisory mortician, and ensure that all matters that require it are handled by someone with a license. This would allow religious groups to better manage their members' deaths according to their traditions. It would also allow smaller communities in our state to continue honoring their dead locally, even when a local funeral home owner retires. In discussing this bill with Jewish, Muslim, African American, and other community leaders, I was often told that they would like to support this bill, but are afraid to do so because it might upend their current relationship with a funeral home. The fact that folks are so concerned about retaliation that they fear speaking out is living proof that we need this bill. This bill, which will cost nothing to implement, can help Marylanders save money at a time when everything is getting more expensive. I ask the committee to report favorably on this bill.
Thank you very much, Senator Ellis.
Thank you, Madam Chair, and thank you, Senator, for this bill. It had me thinking. So if you run a funeral business, funeral home, it cannot be nonprofit. So why wouldn't you be able to just return your profit to the community? Is there a cost savings, or what is the impetus to have a nonprofit funeral home versus what's allowed now for profit?
It's less about the profits, which will make a difference, but it is also about the structure. Currently, you have to be a licensed mortician or funeral director to apply for an establishment license. And that license for the establishment is completely dependent on that person. So if the Jewish community wanted to hire someone, or your church wanted to set up a funeral home, they could do so. They could have someone who goes to mortuary school and gets all the qualifications and opens a funeral home. But if they decide that they want to go live with their in-laws in Florida, or that the weather is better in Arizona, that entire establishment is down the drain. So as a community, you can't count on that. The example I love of this is Nantucket in Massachusetts. There was a funeral home there that was over 100 years old, and the owners wanted to retire, and their children were not interested. The community didn't want to have to ship their dead to a funeral home on the shore only to bring them back for burial. So they wanted to start a community funeral home. They wanted to take over this home and do it themselves. They were not allowed to do that. So they petitioned the Massachusetts legislature, and that's how the Massachusetts law was changed, so that now not-for-profit funeral homes are able to exist there, and the community can take care of its own.
Yeah, thank you for that explanation. So let me know if my summary, my understanding is correct or not. So if it's a not-for-profit funeral home, you don't need a licensed mortician.
You do.
You do.
So right now, you need, as a mortician, you need a license to conduct mortuary science or to conduct funeral direction. You need a license as a mortician or a funeral director. But to establish a funeral home, the ownership of that establishment has to be fully licensed morticians or funeral directors. So you have the level of the establishment, and you cannot practice outside of a legal establishment, a licensed establishment. Then you have to appoint a supervisory mortician, and everything that needs to be handled by someone who's licensed has to also be handled by someone who's licensed. So there's 3 levels. And all this is asking for is that we're allowing not-for-profits to apply for new corporate licenses the way that they already exist as grandfathered in for big corporations or sometimes smaller ones.
Great. All right,
So
thank you.
all the other licensing remains the same.
Okay, thank you for the explanation. Appreciate it. Thank you, Madam Chair.
I don't see any other, Senator Guile.
Thank you, Madam Chair. So there's a little bit of opposition to this bill. I'm just wondering, for the bill sponsor perhaps, is there any effort in order to try to figure out a compromise or I guess maybe just inherently based on the nature of what you're attempting to accomplish by the bill, that maybe there isn't a compromise, or maybe you could comment on that, or maybe just kind of overall comment on the extensive opposition that there is to this, and maybe help us understand.
No, thank you, Senator Guile. I appreciate it. So in answer to the first question, the answer is, of course, yes. I'd like to find a place where the proponents and the opponents can come together and see if there's room there to pass a bill. But let me take this opportunity to say thank you to some in the opposition who approached me beforehand to let me know about their opposition, and also to talk about the cost structure for people who die in indigency. Because one of the benefits of this bill is nonprofits could provide these services for people who are unable to afford it. But I also wanted to be clear, in talking with the opponents of the bill, I learned about the extensive infrastructure that many faith traditions have under the current law. In other words, for-profit companies who have contracts with local jurisdictions or local social service agencies to provide burial services at very low cost. And so their point to me was if this bill is about cost, we want you to be fully informed of the current programs that they have in place where people of their faith tradition who die in indigency are taken care of. Now, I don't think that's a reason not to do the bill, but I did want to express my appreciation to them for sharing for me their structure. Some of them lose money on those contracts, but are doing it as part of their faith tradition.
All right, thank you. Thank you very much. Thank you, Madam Chair.
Thank you. I don't see any other questions. Thank you for your testimony.
Thank you, Madam Chair.
Thank you.
So we have a few unfavorables to call up. Eric March, Camille Fesh, Bill Castelli, Matt Levinson. I'm going to call until 6 chairs are filled. John Mitchell. James Schwartz. Anna Delaney. Okay, that's it for right now. Okay, who would like to start? Bill, would you start, and can we just get on the line? Thank you.
Thank you, Madam Chair. Bill Castelli on behalf of SCI International. SCI International is North America's leading provider of funeral and cremation cemetery services, and we are also opposed to this legislation. You know, this is a very regulated business. Much of the regulation falls under the health article because these businesses are health service providers. They take care of families. They take care of families' loved ones at the most dire times in these families' lives. So while they are for-profit businesses, they operate very differently than a normal business. So we have a lot of concerns about opening this up to a nonprofit. We believe that these businesses need to be well capitalized, need to be well funded in order to continue to provide the highest level of services. And for that reason, we would encourage an unfavorable report.
Good afternoon, Madam Chairwoman and Mr. Vice Chair and members of the committee. My name is Eric March, March Funeral Homes in Baltimore and Richmond and DC. My family's been in funeral business for 68 years. I believe my colleagues will speak to the requirements for becoming a funeral director and the things that have to be learned and exercised for the public good and the public safety. I'm going to raise a different issue here. I serve on the board of several nonprofits. I support the work of nonprofits, but in a competitive market, nonprofits entering into our business is anti-competition, and I'll tell you why. As a nonprofit can go to the general public to raise funds, tax-free funds, to invest in their business for capital as well as operational needs without any consequence. Whereas a business owner has to go to his own assets or finances, puts his assets at risk for collateral to enhance his business. And these are the things that cause a business to operate. Now, a nonprofit doesn't have any of those hindrances and therefore is not a true competitor with a for-profit funeral home.
Thank you, Madam Chair, members of the committee. My name is Matt Levinson, and I'm the 5th generation of our family's business. It's been over 130 years in Baltimore, and we do oppose this bill. The main reason we do is, we know the importance of what we do. We've been all doing it for generations, and we take this job very seriously. We work with families that are going through maybe the hardest time of their life. We went to mortuary school. We passed the national board test. We were regulated, and we got licensed through the state board. And this is not so much as the nonprofit, but I think it's a really bad idea to have non-licensed people to own funeral homes. If you look at the state of Colorado, where up until now you didn't have to be licensed, do a quick Google search and you'll see what's happening in that state. And now they've changed the law, so everyone has to be licensed. I do not believe this is regarding low cost. We have plenty of low-cost providers in our state. I don't want to speak for everyone on this panel, but we're a Jewish funeral home in Baltimore, and when there's a family that has a need or they have no money, we provide the funeral. We've been doing that for 100 years, and we will continue to do that. Our last point is right now our state board is going through a transition, and I think the state board needs to focus on managing and overseeing and inspecting our current funeral homes and not new funeral homes that haven't been part of our industry. Thank you very much.
Okay. Madam Chair and members of the committee, I thank you for your time and attention to this matter. I am Jack Mitchell. I represent the 6th generation of my family in funeral service in Baltimore. I'm a past president of the Maryland Funeral Directors Association and have recently had the privilege of serving as the president of the National Funeral Directors Association. Most funeral homes in Maryland are small family-owned businesses, as is my own. But I have a great respect and appreciation for those who are not born into funeral service, who simply chose, once they experienced the death of a loved one themselves, after they were so moved by the funeral director who helped them through that difficult time, decided, I want to do this. I want to help families through the most difficult experience. And the highest compliment that we get, and we get it all the time, is when families say to us, I could never do what you do, or I would never want to do what you do. Sometimes they even say, why on earth would you ever go into funeral service? It's so sad and depressing. But for all of us, it is a calling. It is truly a calling. And it makes me question why someone would want to own and operate a funeral home if they did not also want to become a funeral director. In Maryland, it's not so simple as to just fill out a form and become a licensed funeral director, and it shouldn't be that simple. But Maryland does not require a bachelor's degree, as some states do. We do now have, again, as many states do, a funeral director's only license, so you don't have to go through the embalming and mortuary science aspect of it. So I just question what would motivate somebody to want to own and operate a funeral home without being further motivated to go ahead and become a funeral director. Do they want to do this because they're looking at it more as a successful business venture and not so much about the families? And the passage of this bill would allow them to do an end run around a good and already existing bill that allows only those of us who have answered the call to own and operate funeral homes, and that would not be for the greater good of Maryland funeral consumers. Thank you.
Madam Chair, Mr. Vice Chair, committee, my name is James Schwartz. Excuse me. I am the president of Myers-Durborough Funeral Homes. I'm president of McNabb Funeral Home, the Cremation Society of Maryland, and Metro Crematory. In whole, we're probably one of the largest funeral providers in the state. I started my company in purchasing these businesses 4 short years ago with my own investment along with my wife. In doing that, we did it because we felt a calling over my 30-year career as a funeral service provider that we wanted to be able to be there for families. And one of our calling in our business is that we provide, as Mr. Levinson said, for everyone. No matter your need, no matter your economic class, we're there to provide you and take care of your family. We always work within everyone's budget. We do have a price list, but we try to work within everyone's budget to make sure every family gets and receives the dignified service they're looking for. To say to do it as not-for-profit, that you can't operate that way. There's too many costs that go into operating and owning funeral homes and running them not to be in it as a calling and a lifestyle to be able to serve those families. The state of Maryland offers an outlet for people who are not licensed funeral directors to own a funeral home, and that is the 45 corporate charter law. Those charters do exist in limited capacity. If somebody wants to go into business and is a corporation and is not a licensed funeral director, they can approach one of the charter holders to purchase a charter. There's no need to have a law change for this. Our business owns a charter, as many of the other ones do. For good reason, we had them from when the charters were there. But we don't need to change the law. We need to remain the people who are called to provide funeral service to provide that funeral service and do it so that we don't end up in the situation that we have right now with some other funeral providers throughout the state. Thank you, and I hope that you provide an unfavorable rating for this bill.
Good afternoon, everybody. Thank you so much for allowing all of us to be here and to listen to all of our points. As I sit up here with all my colleagues, they really have nailed every point that I have gone over in my head as well. I'm an apprentice at the Cremation Society of Maryland. I also work for Myers-Darborough Funeral Homes as well as McNabb Funeral Home. And I wanted to do all this since I was a young kid. And I got into all of this because I felt such a strong calling, as everybody else here on this panel did as well. And there are so many ways that we can serve our families and still have everything in place that we already do. As I said, everybody else pretty much hit it on the head. We all very strongly oppose this bill, and I think that we can continue as we are going. There are so many ways that we still serve our families. I can't tell you how many phone calls we get that families are, hey, they're upfront with us. We don't have as much money as we need, but we are still able to serve these people, and we love what we do, and we're going to continue to do that. Thank you all.
Thank you. Do I have any questions for this? Senator Kramer.
Thank you, Madam Chair. Just a quick question, and I appreciate your passion for the jobs you all do, but I thought, at least a couple or more references to somehow this is skirting some kind of existing process or licensing. And I'm looking at the bill, and under the bill, it still requires that each licensed funeral establishment shall have a supervising mortician. A licensed funeral establishment shall designate a licensed mortician whose license is in good standing with the board to be the supervising mortician for the funeral establishment, et cetera. So I don't, and please direct me to where in the bill it may change, but I don't see any modification to standards or licensing or requirements, just simply that it allows a not-for-profit organization to be able to perform the services that you all do.
Right. If I might answer that, the bill does stipulate that there be a licensee, that there would have to be a licensee as acting as a supervising mortician, but not that the ownership would have to be, that the owner would have to be a licensed funeral director. And the supervising mortician essentially operates at the behest of the owner. The owner continues to set policies, procedures, practices. And as I understand it, a not-for-profit, there wouldn't be a singular owner. It would really be a board of directors. And if no one on that board knows an 18-gauge seal or casket from an espresso machine, the supervising mortician can only do so much to ensure that the families are well taken care of. Our experience and our comfort is with the ownership lying with a licensed funeral director.
So, and again, I'm trying to, it sounds a little bit like semantics that, currently a for-profit corporation could be in the business. Is that correct?
Yes.
A for-profit corporation. And it is, in fact, then, would it not be that corporation that might own the entity? In other words, this is a non-profit organization as opposed to a corporate entity, a for-profit corporate entity. So, I mean, at the end of the day, the owner could be a corporation.
As in like a Service Corporation International is a...
Just Senator Reedy Funeral Services, Inc. And that's the entity that owns the facility, as opposed to, it could still actually be the same name, except it's a not-for-profit.
Okay, so in the state of Maryland, first of all, in order to be an incorporated funeral home, to have INC behind your name, you must have a pre-45 charter.
Which is, just real briefly, what does that do for us?
A pre-45 charter gives you the ability that Senator Reedy can invest in my funeral home. He could be the owner. It's how SCI operates their funeral homes. They're allowed to have outside non-licensed owners. So you could own the funeral home. Senator Reedy could. Ms. Delaney, who's not licensed, you can. If you have a charter, you can own a funeral home.
All right, so
if you don't
can
have
we
a
step back real fast, because I just heard the advantage to being for profit is that there's an owner.
Okay.
Now you just said we could have businesses without owners.
The reason the charter system was stopped in 45 was because the funeral home board, my understanding of history, was they found that not having funeral home owners licensed was a detriment to the consumer and to the funeral home, because again, as it goes to Mr. Mitchell's point, you have people who are overseeing the company that do not have the ability or understand the ability of how to run the funeral home. If you look at SCI and some of the other larger funeral homes, the people who run those businesses or are on their boards or their chief executives or other people are licensed funeral directors. They're just with larger companies. We're all corporations. Don't mistake that.
Right.
We're all corporations.
And under the bill, it sounds like you still have all the exact same licensing requirements, unless I'm mistaken.
Except they're asking for the charter law to be reopened. So if you open the charter law for the not-for-profit, are you not going to reopen it for the profit businesses? Is what I heard the one gentleman asking.
Under this bill, it specifies a not-for-profit organization.
Right, but how is it fair that we can have all these not-for-profits? Well, the next thing you know, the Catholic Church is opening funeral homes.
And would you find that disconcerting? If
the Catholic Church opens funeral homes, they did it in California. The Catholic Church had funeral homes in conjunction with Stewart Enterprises, and the market share went disproportionately towards the Catholic, because the Catholic priests were saying, see our funeral directors.
It's an issue of competition.
Well, it becomes an issue of competition. How can I as a small
how
can I as a small business owner operate my business and do what my overhead is when the Catholic Church has billions of dollars?
But see, that's what I'm trying to get at. In other words,
and they don't have to operate as a profit.
There's licensing that would be different, or not the right people in place. So it sounds like, at the end of the day, the issue is competition.
Yeah.
Well,
okay. No, I mean, if that's it, God bless. I appreciate if that's the concern, but I was trying to get to the point, and it sounds like the point is competition. So with that, that's where I was just trying to see,
Senator,
where this was going to
land. If I could, that's why I said what I said. Because the typical funeral home operator is playing by a whole different set of rules when it comes to business and what it requires to run a business. It requires investment. It requires capital. It requires operating funds. Now, in order to get those funds, we have to earn them by the sweat of our brow. However, when you're a nonprofit, I can go out to the general public, ask them for funds that are not taxed, ask them the funds that they don't have any real tie to once they grant, and the word grant, those funds. that's not a level playing field. That's not
Okay.
fair. That is
No,
not
and I
fair.
appreciate it, so thank you. I was just trying to get at the heart of the concern, so thank you for that. Thank you, Madam Chair.
Thank you.
Thank you. Senator Motz?
Thank you, Madam Chair. Just a quick question. The proponent panel was talking about Nantucket, and I live in a remote area, rural district, and the description was, well, the funeral home, the family got old, they didn't want to carry on the business, so the funeral home moved. In the practice of, in your practice, when a funeral home is going out of business, generally, how was that dealt with? And if it isn't maintained or carried on, why is that?
Anybody?
When a funeral home, and I just experienced this with the McNabb company. Mr. McNabb had no survivors. His daughters did not want the business. I was his key employee. He came to me, he said, I have no one to take the business over. Would you be interested? I went to the bank, I got a loan and worked with Mr. McNabb, and he financed some of the deal. And I continued on the McNabb name. If Mr. McNabb had not done that, in the state of Maryland, what would happen in short is he would have had to appoint a successor funeral home. He would have had to have come to Mr. Mitchell and said, I'm closing, will you take on my pre-needs and be the appoint person for the closing of my business? And he would have had to close it down. People don't go into the business because, like I said to you before, this is not a job. This is a lifestyle. You live this business. I live it 24 hours a day. My phone rings day and night. If you call my funeral home at 2 o'clock in the morning and ask to speak to me, I answer the phone. I mean, I ask any of you, if your phone rings at 2 o'clock in the middle of the night, do you answer your phone? Yeah. I mean, do you? Well, but I mean, do you give it out to your constituents? Can I have your number to give you a call and say hi? I mean, how many of you get your doctor at 2 o'clock in the morning without going through the answering service or anything else? If you go to my website, my cell phone's there. I believe in what I do. I believe in what I do, as these gentlemen and ladies do and the ones behind me. This lifestyle is not just, well, we need this congregation or that congregation to own the funeral home. That's fine. As Mr. March said, it is not a level playing field when it's not for profit and for profit. I have to go out and earn the money. I can't come to you all and say, hey, can I have a donation to keep my business open? I have to keep things going just as these other people do. I talked to one of my colleagues, they want to build a funeral home. They got to find financing to build their building. They can't go out and just have a bake sale and collect money and solicit money. We're here because we believe in funeral service. The fact of the folks with the Jewish Funeral Practices Committee of Washington, I'm familiar with that contract. In 2001, I was at Heinz Rinaldi Funeral Home as the Assistant General Manager and Director of Operations when Bob Hausman brought that contract to us and wanted us to bid on it. We bid on that contract and we served that community, and they're still to this day serving that contract. And they serve that contract at a fair price, and to help the families because they believe in it and they're trying to pass on those savings. But what supports and allows that to happen is because Heinz Rinaldi has a viable business model that other people are paying full service charges for that allow that discounted price to be passed on to those particular clientele. That contract gets opened up for bid once a year, I believe that we said. But again, it just depends on if we're able to afford to do that because, again, we have to be profitable to be able to provide the service. And if we can't provide the service because we can't do it at that price point, well, that's just unfortunate. But again, things cost. Who saw the news today that eggs, Denny's, $2 more per egg meal. So instead of being the 2, 4, 6, 8 meal, it's the 4, 8, 10, 12 meal. It's the same idea. It's profit. We have to make money to survive, to run our businesses. You pass this, you could put us all out of business, and then who's going to pay our debts?
Do I have any new questions for this panel? Thank you all very much. We got 4 more
Thank you.
unfavorables.
Thank you, folks.
I think. Thank you all. Christopher Boggs, Holly McComas, Albert Bloomfield, William Nathan Malloy. I wonder if this is Susan McComas. There's a relator. I think Susan McComas' family. Thank you. I think.
You guys can go. I'll be away.
to begin?
I'll start. I don't pay attention, I'm sorry. Thank you. Thank you for hearing us. I am Holly McComas, seventh generation funeral director, Harford County. I know I have sent all of you my testimony, and I just want to touch on one particular issue that I think is very important. I heard that it doesn't cost anything, won't be a financial burden for the nonprofit funeral homes to be out there and offered. I don't agree with that at all. A for-profit funeral home contributes significantly to Maryland's economy through taxes and job creation. The transition to a not-for-profit model could diminish tax revenue and employment opportunities in the funeral sector. The majority of Maryland's existing 217 funeral homes are mostly long-standing businesses that provide almost 2,000 jobs that are stable and integral parts to their community. The McComas Funeral Home was established 1808, 217 years ago, and we currently employ 14 full-time and 51 part-time employees. Disrupting this economic fabric could have unintended consequences to both employees and local economies. Many for-profit businesses give back to their communities, both financially and through volunteer efforts. These contributions support local charities, community programs, and public initiatives. In contrast, not-for-profit businesses do not provide the same level of community reinvestment. In fact, they want community to invest in them, which could place additional financial burdens on the government to increase the funding to local nonprofits. I encourage you to vote against, in opposition of Bill 957. Thank you.
Thank you, Madam Chair and Vice Chair and members of the committee. My name is Albert Bloomfield, and I have been a licensed funeral director for over 32 years. I'm a third generation. I own several death care businesses in Maryland, including funeral homes. My business partner and I work diligently and invest significantly to ensure that all of our companies operate with the highest integrity, leaving no room for improprieties. We're committed to serving our client families with exceptional care and fair pricing. I strongly urge you to oppose Senate Bill 957, which seeks to allow individuals and organizations with no funeral service experience or licensure to own and operate funeral homes in Maryland. To become a licensed funeral director in Maryland, one must complete mortuary school, pass the national board exam, complete an internship, and pass both the state's jurisprudence and practical exams. These rigorous yet reasonable requirements ensure that those entrusted with the care of the deceased and grieving families are qualified, experienced, and held to the highest professional standards. And this would undermine these protections, allowing unlicensed individuals working for not-for-profit organizations to own funeral homes without meeting any of these critical qualifications. Additionally, religious-based not-for-profit organizations could claim religious objection to state board oversight. Those already operating cemeteries, such as the Catholic Church, could expand to include funeral homes and crematories on their properties, effectively bypassing state regulations. The Office of Cemetery Oversight does not regulate religious cemeteries, meaning approval of this bill would leave these organizations unchecked, putting grieving families at risk. In fact, that on the website for the Oversight Committee, they indicate there that any complaints that a family has regarding a religious cemetery, that the office director may attempt to negotiate a settlement. So once you have a burial or any problem in the Catholic Church, no one can help you. You're giving the keys away. I would strongly oppose this bill.
Thank you. Who'd like to go next?
Good evening, Madam Chair, Mr. Vice Chair, members of the committee. My name is Christopher Boggs. I'm a first-generation funeral director, and unlike anyone else here, I own absolutely nothing. I just work as a licensee in the state of Maryland. First, Maryland already boasts a competitive landscape of funeral homes, many of which provide pricing options below the national average. The introduction of not-for-profit funeral homes could disrupt this balance, potentially increasing costs for families in the long run. Moreover, these are significant concerns regarding the potential for religiously oriented not-for-profit organizations to operate funeral homes. Such entities might seek exemption from establishment state regulations, creating unfair competitive advantage and undermining consumer protection. The recent closure of Heaven Bound Cremation Services serves as a stark reminder of the importance of rigorous oversight in this industry. The financial instability inherent in not-for-profit models could jeopardize operational standards and consumer safety. For-profit funeral homes are bound by strict consumer protection laws that ensure accountability and high service standards. While the intent to offer affordable options is commendable, the regulatory framework currently in place guarantees that all operators maintain these essential standards. It's critical to remember that non-for-profit does not mean no profit. This shift could have adverse economic effects. The lack of compelling research supporting the need for this bill is concerning. There's been no clear evidence demonstrating that non-for-profit funeral homes would serve Maryland communities better than the existing trusted providers that come from diverse faith groups. While long-standing relationships with local funeral homes are notably absent from this conversation. Additionally, the proposed legislation would allow unlicensed individuals to own funeral establishments, undermining the accountability and training that licensed professionals undergo. I urge an unfavorable report. Thank you.
Thank you. And the final panelist?
Madam Chair, Vice Chair, esteemed members of the committee, my name is Walter Nathan Malloy Jr. I am the attorney and lobbyist for the Maryland State Funeral Directors Association. Since 1919, the Maryland State Funeral Directors Association has been dedicated to professionalism, integrity, and the highest ethical standards in funeral service in Maryland. We are at a critical time in funeral service. What the committee does here today will have an everlasting impact on funeral service and the Maryland consumer. I cannot sufficiently stress the importance of opposing Senate Bill 957 for the state of Maryland and the consumer. Senate Bill 957 will have unintended consequences that will severely impact funeral service and the consumer in Maryland. Senate Bill 957 attempts to relax the restrictions codified in 7-309 and 7-310 of the Health Occupations article for funeral establishment ownership, which were designed specifically by the legislature to protect the consumer. Senate Bill 957 would allow unlicensed individuals who are less educated, possess less training, possess less skill than is currently required by Maryland law to form a not-for-profit board of directors to control and operate a funeral establishment. The restriction on ownership in Maryland was challenged in the U.S. Court of Appeals, and the court noted the restrictions on funeral establishment ownership are rationally justified because the use of corporations causes such business to be owned by people who do not know anything about the business, and because the restrictions foster a greater degree of accountability to regulators. The same holds true for nonprofit operation of funeral establishments. The Court of Appeals went on to state that the Maryland General Assembly had a rational basis for believing that limiting funeral home licenses to licensed individuals would foster a greater degree of accountability to regulators than with the continued licensing corporations, which are inherently designed to limit personal liability of owners. Now is not the time to deregulate funeral service. Now is not the time to have less accountability. Have current events in Charles County taught us nothing? Winston Churchill said, "Those who fail to learn from history are doomed to repeat it."
Thank you, Mr. Malloy. Do I have any questions for this panel? Seeing no questions, we have one virtual favorable, David Zinner. Mr. Zinner, unmute. Unmute. There
Good
you go.
evening, Madam Chair, Vice Chair, and committee members. I'm David Zinner, testifying in support of Senate Bill 957. I have extensive experience working with funeral homes, including negotiating community funeral contracts, evaluating funeral home back-of-the-house conditions, and providing training for Jewish groups washing bodies at funeral homes. I know many of the people who are on the panel who are opposed, and I'm a little bit shocked at their intense testimony. But in addition to my work as a death care educator, I also do a lot of work with cemeteries, and you can see details of my experience in my written testimony. The new category of nonprofit funeral homes will create new options for parts of the state where there are significant distances to the closest funeral home. It will increase competition in the funeral industry, and it will allow religious organizations to provide funeral services for their members. Working with funeral homes, both profit and nonprofit in other states, I've developed great respect for funeral directors. It's a tough job and one that requires a wide range of skill. But in both profit and nonprofit settings, I've seen no discernible difference in funeral director competence, professionalism, or compassion. Nonprofit funeral homes in other states may also do extensive community education and offer counseling services. Many folks misunderstand nonprofit ownership. I've been working with and for nonprofits for about 50 years. Not-for-profit ownership is not about low cost. It's a different type of ownership. And all nonprofits boards set policy, but under this bill, the board must hire licensed funeral directors to do the work. The nature of the ownership does not impact the requirement to hire qualified licensed professionals. Today I was talking to a Muslim friend who was totally in support of this and said it's really important to the Muslim community. Religious institutions should have the same right of funeral home ownership as for-profit entities. In Maryland, religious organizations have the right to own a hospital, to own a school, or a university, or even a cemetery. Why not a funeral home? I urge your support of SB 957.
Thank you, Mr. Zinner. Do you have any questions for Mr. Zinner? Thank you for your testimony. That ends the hearing on Senate Bill 957 and ends the hearings for today. Thank you, committee members.